Hi. Well, while people are still logging on, it's 10:02, so I think we'll go ahead and get started. First, I'd like to welcome you all for joining this webinar. The assessment of kidney function is a topic that has really been near and dear to my heart and many of us nephrologists and physiologists for some time. And now as the treatment modalities and molecular technologies continue to make headway, I believe it really might be worth more than ever for us to rethink our approaches and work to expand upon them. Also hoping that this workshop will stimulate a lot of good discussion moving forward. Advance this slide. There we go. I have nothing to disclose except that all views here expressed are solely my own. So there's a chance that I might be somewhat biased, but I can't help to agree with the 2023 World Kidney Day logo. Kidneys really are amazing. Now, we're not going to go through all of these functions. I just wanted to really list them as a reminder of all the various things it does. Of course, there's a filtration and excretion of waste products, the regulation of fluid volume, blood volume, pH, ionic composition, sodium, potassium, chloride, and so on, osmolality, blood pressure, hormones, EPO, renin, clotho, prostaglandins, and so on. And of course, even a meaningful role, sometimes underappreciated, in glucose regulation. Now, despite all of these, our focus for pretty good reasons to date has been mostly around the glomerular filtration rate and a little bit of selectivity with proteinuria, which captures only part of that. However, we really have yet to standardize and fully explore in a comprehensive manner the totality of these functions and what they mean combined. Also have to remember that really the kidney is dynamic and not a static processes, and we have often relied on static measures. GFR, for example, has been shown that can vary from about 30% with diurnal variation from morning to evening. If we look at potassium, at one point, it might be very different than what it is after a high potassium diet. And these are other factors that we need to consider when we're trying to assess what the kidneys can and cannot do. So why are we here? The first part is a little bit easier, and that's a critical evaluation of really inherent limitations in our current methods for assessing kidney function. The more challenging and fun part, perhaps, is then trying to discuss potential paths forward towards developing standardized battery of kidney function measures that could then accurately evaluate distinct functional states, reserve trajectories, and various kidney compartments. The overall goal in some ways may be to help propel a paradigm shift towards a more comprehensive approach to assessing kidney functions, dysfunctions, which can then in turn improve our ability to identify the underlying affected pathophysiologic pathways, disease subgroups, all as needed to better target treatments and assess response. So I have two clinical and one research case scenarios to help elucidate some of the primary shortcomings as related to our current ability to assess kidney function. So our first case here, this will be a 45-year-old male with unremarkable medical history and family history. BMI is 28, blood pressure is a little elevated, 132/85. Physical exams pretty much unremarkable. LDL a little bit elevated, CBC, metabolic panel, all and report come back normal. However, if you look at it more closely, you see the eGFR is 75 mL per minute, even greater than 60 stated as normal. Urinalysis is unremarkable. The albumin to creatinine ratio is slightly elevated at 70 milligrams per day. And if you do a 5-year KFR, kidney failure risk equation, you get a risk of 5 years of only 0.1% risk for kidney failure. So what does this mean? It's not technically very abnormal. It's not completely normal. Can we discern the clinical significance of this in a 45-year-old, or which nephron segment might be most affected? What about the meaning of this 20 years down the line? The KFR is for 5 years. This person's only 45 years old. They have another 40 years or more to go. When and what therapy might we initiate? Should it just be SGLT2 inhibitors? Should it only RAS, or should I consider aldo blockade? And really, the more we look at this, the more we can see that we're really limited by static and partial assessment of what's going on. So questions become, are there test tools that might help us better understand and categorize the disease process? Cycle clinical case here is that of a typical one seen in many nephrology clinics or in primary care. 7-year-old female with a history of well-controlled hypertension, back pain, gastric reflux, no diabetes, mild hypocholesterolemia, and progressive, slowly to moderate progressive CKD. The GFR is 40 mLs per minute. Albuminuria is 150 milligrams per day. And if you do a KFRA risk, it's 4.2%. So what is the disease process? This might often be tagged as hypertensive nephropathy, but really, what is hypertensive nephropathy? Is it a reliable disease category or not? Can we clinically discern between this versus chronic AIN or other possibilities? So then comes, might there be relevance to whether, apart from this GFR and proteinuria, if she has the impaired ability or not for various functions, respond to potassium or acid lows, maintain volume homeostasis in light of a trip and high sodium intake, respond to diuretics, has higher or low renal reserve capacity, can maintain appropriate glomerular permecellular activity, hormone regulation, and of course, any combination of the above and more. Might hypertensive nephropathy have more RAS and perm selectivity disturbances, and AIN more tubular dysfunction or different response to renal stress at the same GFR level? We don't know. However, I think it's reasonable to expect that there are many potential use for patterns that can reveal subgroups and more. But first, we really need to establish the tools to be able to study and explore these more systematically. The third case scenario is that for research. So many of you might already be familiar with the KPMP. For those who are not, this is a NIDDK initiative with the goal of safely and ethically obtaining research biopsies in individuals with AKI, hypertensive, and diabetic kidney disease, who, as you well know, we have traditionally not biopsied, and then apply state-of-the-art technologies to the various groups to better delineate disease subgroups and the pathways by which these progress to end-stage kidney disease, with the clear goal of identifying new disease subgroups and improve on individual level targeted therapies. Now, there are many state-of-the-art technologies that are applied to these, which include the transcriptomic, proteomic, metabolomics, epigenetics, and state-of-the-art imaging processes. And even at the early stage of this study, there are really some amazing results. There was a fantastic publication that came out of this last year in Nature by Blue Lake and al. And not meant to go through this, but these are one of many interesting figures and results that come out. So there's from the spatial result atlas of the molecular cell types, where they are, and so on, to the expression of and signatures of different cell types that might be either adaptive or maladaptive. So as incredible the resolution is that we're getting here and all these new pathways that we're targeting, and it's only the beginning, I believe, these are still now being primarily tagged to change in GFR or development of end-stage kidney disease. Now, ideally, I think we would reliably try to tag these molecular signatures to segment-specific proximal tubule, distal tubule, GBM, and so on, and functional status of the kidney, such as renal reserve, response to stress test, sodium handling, and so on, and try to then get a much better in-depth understanding of what's going on in each individual. And while within KPMP, there is the goal to try to do as much of this possible, it is quite challenging because the approaches and tools to do these, at least on the clinical phenotyping end, have really not been fully developed or standardized. So I'm just going to do one brief analogy with cardiology. I may at times, or actually often have jokes with my cardiologist friends and tell them that the function of the heart is to pump blood to the kidneys. But of course, I must acknowledge that in the end, they really have had more success than we have, at least in recent times, coming up with effective treatments. Now, what if the cardiologist only looked at left ventricular functions, if we just look at GFR, and not deeper into the other chambers and sections? What if they did not perform stress tests before deciding on a treatment plan? Why is it that we find it reasonable to have stress tests, echocardiograms, many more biomarkers, NT-proBNP, LDL, lipoprotein A, for cardiac workup, but then often I expect people to think that for kidney workup, it should not involve functional testing because they're not convenient, and it shouldn't cost more than $20, hence cystatin C. Of course, the initial response to that is, well, deeper renal phenotyping, as it is now, is not associated with clear changes in therapy. But then the point is, could the cardiologist have figured out the utility of identified subgroups of heart failure, preserved or not preserved ejection fraction, diastolic versus systolic, and different treatment modalities without comprehensive testing in the first place? In other words, we can't assess what we do not measure. As you also might imagine, this being a fun topic for many of us, I've discussed this with many colleagues in the hallways or at lunch during ASN, and there's often both agreement in terms of our shortcomings, but I also at times get some resistance. Say, well, GFR proteinuria has been serving us well. Isn't it really enough? How much would we gain by going further? I would first push back and say, well, our track record really hasn't been that great. We haven't come up with new treatment modalities. And the SGLT2 inhibitors, which have been fantastic, really was serendipity, not based on findings there. And I'll acknowledge that eGFR and albuminuria offer very good prognostic abilities. Sorry for the typo. However, what we need moving forward is where they fall short in, and that's providing an understanding of disease processes, subgroups, or therapeutic targets. Molecular profilings, well-down value pathways and subtypes, will have limitations in capturing functional status or of the individual renal compartments. So increased fibrosis or pathway activated in KPMB doesn't tell us whether the kidneys are managing volume, acid, or other things. So this indeed could be a bottleneck for us developing precision medicine-based approaches. So moving forward, what are some potential next steps? One, I think we really need to go back to our physiology roots. Rethink things, not what we've been doing, but where we are at this time approach, what approaches might add to what we can do on molecular, and how can we not just capture static, but also dynamic and functional renal functional states. I'd like to establish pathways to really better match the distinct processes to distinct renal compartments. I think it'd be important to try to distinguish between time average versus acute functional changes, like the diurnal variations we talked about, or having this similar hemoglobin A1C versus finger stick glucose that the endocrinologists use. And also, I think we really need to establish standard and solid platforms. Once we have those, then we can move forward to maybe pragmatic or biomarkers or other estimating approaches for all these varied functions that may be hard to do otherwise. And in the end, really, we're going to have to integrate these and make them fit for each case scenario. Obviously, not everyone is going to need a measure of tubular function, but we need to think about for what case scenarios, whether research, disease staging, drug dosing, what measures do we want to do? One size, such as creatinine or creatinine cystatin C, does not fit all. And of course, the reason why we're having this workshop is to solicit broad and diverse input from the community. So in summary, the kidneys are really pivotal for health and homeostasis, extending beyond GFR and proteinuria. And our failure to really reliably capture other processes might have impacted our progress. And then, I think this may be the time to really revisit and reformulate a comprehensive standardized battery of various kidney functions that can accurately evaluate distinct functional states, reserve, and trajectories in the compartments, aligning with the principles of precision medicine. So next, I'm just going to briefly go over the agenda. So for day one, we have multiple lectures by a series of fantastic speakers and great moderators to take us through them. You can type all of your questions in the chat section at the end of the talks. The moderators will then read the questions to the speakers who will be able to answer them. The Q&A session will be at the end of the talks for the full session, for the first 4 sessions, except for the new technologies lightning talk, where there'll be Q&A after each of the 6 talks. And then for the second day, this really should be the most engaging section. We very much want to hear directly from all of you, so you will all be able to speak during these breakout sessions. To do that, to stimulate discussion, we have put forth some questions, which you can see on the online agenda, and have also been, I think, mailed to you this morning in the form of these Google link docs in which people can type into it directly. So I know it's challenging to find a time, but we sincerely want to solicit broad feedback. So please be sure to try to join us tomorrow and share your direct perspective on these important issues. Last but not least, I'd like to thank the members of the organizing committee, notably the external panel. Sus Weikar and Peter Bornstadt served as co-chair and have spent an enormous amount of time helping organize this. We've also received excellent feedback and help from Tim Meyer, Eliza Thompson, Brian Kestenbaum, and Jesse Sigmiller. And of course, I'd like to thank my colleagues down the hall at me who've helped organize this meeting. So without further ado, I'm going to now turn this over to Rob Starr to provide some welcoming comments from our director.
So I want to start with the thank yous. Afshin, I want to thank you and the organizing committee for putting together what we hope to be a really nice meeting. All the KUH staff that helped, and the speakers, and of course, all the 145 people that are on Zoom right now. For those of you who have been around more than a couple of years, you probably remember that we had a meeting sort of like this, I don't know, 10 or 15 years ago. I don't remember the formal title. My sort of internal title was ABC, anything but creatinine. And I think that the purpose of this meeting is to sort of keep exploring what other functions, not just the glomerulus, although there's plenty of talks today and tomorrow on glomerulus, but what other functions of the kidney do, as Afshin talked about, in order to help us to define kidney diseases, plural, better, to find the subgroups that Afshin talked about, so that we can treat people more precisely. I'd like to paint a picture. What Afshin's really asking us to come up with, and this is not my idea, others have come up with this, is what's on this cart, this renal function and stress cart that gets wheeled into a room of a patient or patients with kidney disease. It's not just measuring creatinine, it's not just an ultrasound machine. What else is on it? What real-time measurements can be made? What blood tests can be sampled? What stress tests need to be done to uncover where that particular person is in their journey through kidney disease. So I think that's the image that we're looking for. What's on that cart that gets wheeled into the room? The other thing I want to do is to please ask people to please turn on your cameras. These Zoom meetings are really difficult. This is a 2-day meeting, 6 or 7 hours long each day. And if we don't see each other, we're all going to go to sleep. So please turn on your cameras. I will keep mine on also. And I think that will help engage us a bit. So in summary, keep thinking of that renal stress cart, and let's get some really good ideas on the table. And I want to again thank Afshin and the organizing committee and everyone else for putting this together. Thank you all. Afshin, back to you.
Thanks, Rob. Okay, at this point, I'm going to turn it over to Tim Meyer and Valerie Loix to kick off our first session, measuring tubular functions.
So, thank you very much. I hope you can hear me. I'm very honored to be asked to moderate this first session on tubular function together with Tim Meyer. Tim Meyer is from Stanford in the VA Palo Alto, and he became interested in tubular secretion because it's the mechanism by which the kidney removes the best known waste solute derived from colon microbes. From my side, I'm a nephrologist currently based in Zurich, and actually an adult nephrologist working in pediatrics. And so increasingly actually seeing the value of physiology in the children with my sort of adult perspective. I've always been extremely interested in the physiology of the kidney, very interested in early diagnosis, especially across the life course, and also thinking quite a lot about renal functional results. That's really a privilege for me to be here. I guess, should I go ahead then and introduce the first speaker, or Tim, would you like to do that?
Well, we can both introduce Brian, but we'll do it briefly. Brian's a professor of medicine at the University of Washington and has, Brian, for 10 years, I think, been measuring the secretion of largely organic acids by the proximal tubule, a neglected feature of what happens downstream of the glomerulus, and has found variation in the secretion of these substances, which is independent of the degree of decline in the GFR. I think that's enough because I've seen his slides and he's got a good presentation. Brian, go ahead.
I'm sorry, if I can just briefly say, we will have 20 minutes for questions and answers afterwards, but if you could please put questions in the chat so we can try to moderate them, that would be great during the talk.
All right, thank you to the organizers. Thanks for the moderators. Afshin and Rob gave a really great overview here, which makes the introduction part so much easier. I'm going to talk on the faster side because I do have a lot of stuff to go over, but very excited to talk with people after about all these potential applications. So here's Seattle on a as it is every day on a beautiful sunny day. Okay, hang on. There we go. So as Ashton pointed out, the kidneys do many different things, and they are physiologically distinct things. And yet, when it comes to the clinical assessment and monitoring of kidney function, we focus entirely on the glomerulus, right? We focus on glomerular filtration, and we focus on the glomerular permeability barrier. GFR and albuminuria are the way that we monitor patients, and the way that we initially detect disease and even stage the degree of chronic kidney disease. So we don't typically evaluate the other functions. This idea of using a purely glomerular-centric assessment of kidney function would potentially work if all of the other endocrine and synthetic and acid-base handling and secretory functions were all inexorably linked, so we could just follow one and all the others change in lockstep. We know, of course, that that's not true. This is just one of many, many examples. This is the synthesis of 125 dihydroxyvitamin D, which is mostly synthesized in the kidney as a function of GFR. And you can see there's a huge amount of scatter. So the two functions don't go down in lockstep, which is not surprising. We've been focused on trying to come up with a way of quantifying the secretory clearance aspect of the kidneys for the last few years, and have come up with some ideas and some start as to how to do that. Just a sort of overview here of the secretory side of the kidneys. You have the renal blood flow coming in, and then about 20% of that renal blood flow typically is filtered, depending on the filtration fraction. And the remaining 80% or so goes to the peritubular capillaries, where that blood is then subject to be secreted into the proximal tubule. So contrasting filtration and secretion gets more blood flow. It uses an active mechanism through active transport to actually pull organic solutes through the cell and then into the urine, whereas filtration is primarily passive. Secretory clearance has the capacity to remove protein-bound solutes, whereas filtration does not. And secretion is the primary mechanism by which we eliminate prescribed medications. Well, secretory clearance is complicated, not just distinct from glomerular filtration. The process involves the solute itself having to move from the peritubular capillary into the interstitial space, whether on albumin or not. And then in the interstitial space, that solute interacting with one of many high affinity organic anion transporters or other transporters that are energy coupled, which bring the organic solute into the proximal tubule, and then energy direct coupled transporters have to immediately secrete that solute into the urine because many of these solutes are toxic and would be toxic to the cell. It's quite a complicated process. This is from Tim's group. This is Tim Research's data from a while back. Just really nicely highlights the concept that many solutes in the body are cleared to a much greater extent by the kidneys than a filtration marker. In these normal volunteers, these are 24-hour urines to calculate the total kidney clearance. The average creatinine clearance was 142, mostly filtration, a little bit of secretion. But you can see the kidneys have the capability of clearing other solutes from the body at much higher speeds than that of creatinine. So if something was truly toxic, this would be a mechanism by which the kidneys could get rid of it very quickly. So how do you go about quantifying tubular secretory clearance in a person? I mean, in theory, it shouldn't be too bad. You find a marker. It could be an exogenous marker if it's going to be an exogenous test, or you find an endogenous marker. And that marker should be ideally avidly secreted by the kidneys, not appreciably metabolized by other organs, minimally filtered if possible, and can be measured reliably. So as an example, in this theoretical marker, it's bound to albumin. So there's going to be very little filtration, but that marker is highly is a strong substrate for the organic anion transporters in the basolateral side of the proximal tubule. And if we can then measure the clearance of that marker, we can get an estimate of what's going on with secretory clearance. To do this, we partnered with an outstanding laboratory medicine person. This is Andy Hoofnagel and some of his many different technologies who helped us develop targeted LC-MS assays for secretory solutes of interest. And Ashton asked me to talk a bit about the standardization process. I could go on for much too long about that, but we'll just say that for each patient sample, there's internal standards that are run with every individual well. There are external calibrators that are run on every plate. And then we've taken the external calibrators up to the upper campus to do NMR to get the actual concentrations that are present in the external calibrators, so that in the end, we can convert all of this back to a real mass. We can actually say the concentration of kynurentic acid is 5 nanograms per milliliter. Without that last step, we can't take it all the way to a mass. However, despite all of our work to try to get precision in the laboratory as low as we can, the real elephant in the room for variability is not in the lab. So this was a study we did early on, once we had some solutes of interest in healthy adults who were participating in an endocrine study in which they came in for an initial visit before they had any intervention, had an indwelling IV placed, and had blood samples collected every 30 to 60 minutes for 24 hours continuously. And so we got a hold of 14 samples collected over the 24-hour period. And we looked first at serum creatinine. We could see one reason why serum creatinine is a pretty nice marker when it comes to the lab. Within an individual, there's very little change, even after you eat or while sleeping. There's a little bit, but overall, the coefficient of variation in a person for a 24-hour period is 7%. Here's one of our first candidate markers, hip urate. Not so good. The coefficient of variation within a person for hip urate was 52%, with large changes seen with meals, and there was a diurnal pattern as well. And many of our secretory solutes that were of interest, which circulated much lower concentrations than creatinine, have large coefficients of variation within a person, far larger than the intra-assay or inter-assay CV in the laboratory or other laboratory issues. It's the biologic variability that was by far the largest. And this is important because we'd like to calculate the clearance, the kidney clearance of the marker as UV over P. And that assumes that the P part is staying constant over the time of your urine collection. But if your plasma concentration is moving all over the place, you'd have to get, and we have done this, get many blood collections over a period of time and get an average, or try to find a marker that doesn't do that. This shows some of the properties of the solutes that ended up sort of making it to the final group. We selected solutes based on extensive literature review, some protein binding experiments, to try to find the ones that were the most avidly transported by the kidney transporters, had the best laboratory properties. Here are the ones that that turned up at the top. They all ended up being OAT1, OAT3 substrates. Here shown is the protein binding, the diurnal CV, the plasma CV, and the urine CV. I put kynurentic acid in bold here because, as you'll see as we go through, this one's really turned out to be the best marker that we found. It's highly protein bound, 97%, very unlikely to be filtered to any appreciable degree. The diurnal CV isn't perfect, but it's not bad. We can measure it pretty well, and it seems to track with most of in all the studies really we've done with secretory clearance as estimated by some of the others. Okay, so the first place we turned to look at some clinical consequences was the chronic renal insufficiency cohort study. This is a CKD study of about 4,000 people from 14 sites. The participants completed 24-hour urine collections at baseline, and a third underwent iothalamate measurements of GFR. The reason we chose this is because we got a hold of the baseline samples, yet these participants had been followed now for 15 plus years, and so there were outcomes available on long-term progression of disease. So we measured our secretory solutes in paired 24-hour urine and plasma samples in 3,406 participants who had available samples at baseline, and we calculated the clearance of the marker as UV over P. One of the first things we did was looked at the association or relationship between measured GFR, which is shown on the x-axis here, and secretory clearance, which is depicted by the clearance of kynuric acid, a highly secreted solute, on the y-axis. And what we saw is that secretory clearance and GFR were in fact correlated, but there's quite a bit of intra-individual variation. And we can see that by regressing in quantiles. We can regress the 25th percentile and the 75th percentile, which gives you basically the expected kynuric acid clearance, a surrogate of secretory clearance, for any given level of GFR. For this person with an IGFR of 40, most kynuric acid clearances are between somewhere around 50 and 100, but there are some people who have quite low or relatively low kynuric acid clearance for that level of GFR. And there's other people who have quite high kynuric acid clearance for that level of GFR. You can call them high secretors for the purposes of explanation. And then we looked at whether that being in that high-low or relatively high or relatively low secretory clearance for a given level of GFR was related to long-term progression of chronic kidney disease. There were 1,206 such events, which were defined by a doubling of creatinine requiring dialysis or kidney transplant. And you can see that lower clearances of our secretory solutes were mostly associated with a higher risk of kidney disease progression over follow-up after adjustment for baseline GFR and albuminuria and other risk factors. We also calculated a summary score, which was an average of the 8 different secretory clearances, and that was also associated with a higher chance of CKD progression. These are associations with mortality. They were in mostly the right directions. Some did not meet the multiple comparisons statistical significance, and some of the associations appeared to be stronger than others. But in general, the direction of association was in the same way as it was for CKD progression. And again, this is after adjustment for GFR, albuminuria, and other risk factors. Okay, so to summarize, in a national cohort study of adults with chronic kidney disease, we found IGFR and secretory solute clearances to be correlated in overall, but there was considerable variation in these functions across individuals. And we found that lower net secretory clearance was associated with CKD progression independent of GFR and albuminuria. Limitations: we have no gold standard for confirming purely secretory clearance in this study. So we're using, say, kynuric acid as a surrogate based on its properties, but we don't have this, the gold standard being measured in each person the way we do for, say, iothalamate or iohexol. And then, of course, errors in all the different ways we measure these solutes, as well as even IGFR, may have contributed to the observed differences that we're seeing. So the actual scatter is probably less. Okay, I'm going to turn quickly to a second study about this called the PROCLAIM study. This is the beautiful Northwest Kidney Center, the first dialysis organization in the world. Across the street from this is where Belding Scribner first put people on dialysis in 1962. So the purpose of this second piece is, as I was explaining before, secretion really is the primary kidney mechanism for clearing most drugs. This is just a partial example of drugs that are cleared through the secretory clearance pathway. Yet we dose drugs based on estimates of filtration. Either it's a Cockcroft-Gault creatinine clearance, or now can be an MDRD or CKD epi-based creatinine clearance or GFR, but it's all based on filtration, despite the mechanism being that of secretion. So if the two functions are tightly linked, that would work. In situations or diseases where they're not tightly linked, medication dosing may not work as well. The goal of our study was to compare tubular secretory clearance with GFR for predicting the clearance of empirically determined kidney drug elimination. To do this, we recruited 54 outpatients across a wide range of kidney function. Some were normal, some had CKD. And we excluded for dialysis a kidney transplant or the other conditions shown. And the procedures were that we gave each participant a cocktail of in this case, two medications that we thought were the best prototypes in this example. One was IV furosemide, which is 97+% protein bound. It's an OAT1/3 substrate, and it's highly secreted by the kidney, not metabolized appreciably by other organs. The other prototype was penciclovir. This is an OAT2 substrate, much less protein bound, but very highly secreted. They also got IV iohexol, so we could calculate GFR. They had indwelling IVs placed, and we were able to collect blood samples multiple times over 10 hours, as well as a timed urine sample. We calculated the kidney clearance of the administered drugs as the urine recovery divided by the AUC. We calculated the kidney clearances of our endogenous secretory solutes as UV over P, and we determined iohexol disappearance. There was also a second study where people were invited back to have a second cocktail of two different drugs, and that was a smaller group, so I'm not going to show those data here. The average age of the participants was 55. A third of them were women, and the average GFR, IGFR, was 73. They were distributed as 20 of them had a GFR less than 45, 22, I'm sorry, that's 20% had a GFR less than 45, 12, sorry, yes. Okay, so yes, this is the distribution of the GFR categories. We were trying to get a range in this study, we're not going after, in this case, a specific disease. So the participants turned out to not have very much in the way of albuminuria. The clearances, so the furosemide kidney clearance comes out to be pretty close to what a person's creatinine clearance is, just a little bit higher, even though furosemide is completely protein bound and not filtered. It just turns out that's a typical clearance for that drug. Penciclovir has a much, much higher kidney clearance than GFR. And for each of the drugs, we wanted to calculate how close the kidney clearance predicted, drug clearance was to the actual drug clearance. So just shown here is a plot of kynureninic acid clearance on the x-axis versus the kidney furosemide clearance on the y-axis. So in this example, we're using kynureninic acid clearance to try to predict kidney furosemide clearance, with kynureninic acid clearance serving as a marker of secretory clearance. So for the individual highlighted, they have a measured furosemide clearance of 140 mils per minute and a kynureninic acid predicted furosemide clearance of 110 mils per minute. So that's a 21% difference. And then we can use leave one out cross validation to estimate the average percent difference for each of the different measurements. So here's the results. We'll start with furosemide. So if we look at eGFR as a means of predicting furosemide clearance, on average, the average error in predicting furosemide clearance from eGFR is 33.5%. If you use IGFR, you get somewhat better prediction of furosemide clearance. And the different secretory solute clearances vary in their prediction of furosemide. Some were better, some were worse. If you combine them using a secretion score, you get a somewhat better overall prediction, or somewhat lower mean percent error compared with IGFR. But the differences were not statistically significant. As you can see, they're somewhat moderate. though moving in the right direction. The same was true for penciclovir. EGFR has an average percent error of 29.8, IGFR 24.1%, and the summary secretion score has an average percent error of 18%. So I'll summarize this by saying in a cohort of stable outpatients with and without kidney disease, the kidney clearance of endogenous solutes do predict the kidney elimination of avidly secreted drugs. But the improvement over IGFR was only modest because in this setting of stable outpatients with disease, the correlation between secretory solute clearance and IGFR was quite high, higher than that observed even in CRIC, because we were able to measure it with a much greater precision. We did see some additional improvement in prediction by combining secretory clearance and IGFR. So that's my whirlwind through two of our data sources. We have lots of others. My view here is that I think that some of these secretory clearances that we have are able to actually get at this function of the kidney. It does seem that in people who have achieved a stable sort of situation with whatever disease they have, the two functions do sort of come closer in line, and distinctions between the two might be less prominent. However, if you're present at the right time in the right disease state, I think the differences between, say, GFR and secretory clearance might become quite large. As an example, in acute kidney injury, where the injury begins with the proximal tubule, at least through that beginning section, before GFR is reflexively decreased, you might see large differences in the two functions. And we're testing that in a current study. Okay, I want to thank everybody that was involved in this. This was an NIDDK funded grant. These are some of the many people who worked on these studies. There's many more. I'll thank the organizers for inviting me and everyone who's come to listen.
Thank you very much. That was a wonderful presentation. We'll now move on to the second presentation. We'll collect all the questions. Thank you. I see several of you are typing questions into the chat, so we will get back to those. The second speaker is Dr. Jay Coyner. He's an associate professor of medicine in the section of nephrology at the University of Chicago, and the medical director of the inpatient dialysis unit and director of the ICU nephrology. And his critical care nephrology research interests are focused on the utilization of plasma and urine biomarkers to improve patient risk stratification outcomes in the setting of AKI. And as we're about to hear, kidney stress testing. So thank you very much, Dr. Coyner.
Thank you for the kind introduction. Thank you to the organizers for the opportunity to talk today. It's an honor to speak to you guys. Everyone can see my slides.
Yeah.
Right. I have some disclosures. Full disclosure, that's my barbecue last Super Bowl Sunday. We'll see what it looks like this Super Bowl Sunday this week. Right. So here's an outline. We're going to talk a little bit about why we think we need functional stress testing of the kidney. Both Dr. Parsa and Dr. Starr and Dr. Kestenbaum sort of laid that out. We're going to talk about different areas, not just the furosemide stress test. Maybe we'll talk a little bit about RAS. We'll talk about the furosemide stress test and then some other segments. And maybe we'll talk a little bit about a research agenda along the way. At least for me, this is how my journey began. I can remember being a medical student, and George Kalianides, who was a nephrologist at Stony Brook, where I went to medical school, handed me this paper about the idea that we all don't pee ourselves to death when we have AKI, right? That the kidney is smart enough to figure it out. And we as nephrologists, or I'm going to assume the supermajority of us are nephrologists on this call, all know the things that the kidney is supposed to do. We know how much potassium or how much phosphorus is supposed to be in the urine, and we have equations and ways to think about those things. But I think that it's a remarkable organ, but we have yet to sort of translate it into some of the tests. And this is actually what Sus said to me, I think on the second or maybe third time we spoke about the meeting. We need tests as elegant as the kidney itself to understand that when the kidney is and isn't working, right? And that's sort of the essence of why we're here. And I think that that's true for AKI and CKD and all aspects of kidney function. This is a case, right? It's a 56-year-old man. He's seen in my post-AKI clinic after a 2-day admission for a rule out of an acute myocardial infarction. His creatinine at the time was 1.8 plus. He has not seen a physician in a long time. He was discharged on a beta blocker, and he wasn't started on RAS in-house because it wasn't clear if he had AKI or CKD. In clinic, he's still hypertensive. His creatinine is down a little bit, but not really much at all. And you decide to start him on some olmesartan. What do you think his creatinine will be? What should you expect a change in the creatinine to be, whether from the olmesartan, recognizing that you think he may actually need both an SGLT2 and an MRA down the road? And so we're going to talk a little bit about some of the data around this. It's easy to sort of start with something like the SOLVE trial, which was published now close to 35 years ago. It was the first study that showed that in the setting of heart failure, starting people on ACEs actually improved their outcome. You can see, and you can define outcome here, whether it's death, readmission for CHF, or a change in your CHF status. Across the board, enalapril at the time actually improved outcomes. Everyone already knows this, but what you may not be familiar with is an elegant secondary analysis done by Jeff Testani and Steve Coca several years back, where they went back and looked at this cohort and said, we know that the ACE inhibitor is supposed to change and drop your GFR, whether we call that worsening renal function, AKI, not AKI, and they went and they redefined the entire cohort, looking to see whether or not they were randomized to ACE or placebo, and if in the period after starting the ACE, their creatinine changed. And they demonstrated what we all know as nephrologists, that if your kidney responds to the ACE, you have the glomerular changes that you expect, and you have a slight drop in your GFR and a rise in your creatinine, you actually did the best. The people who did the worst, not surprisingly, were those who received placebo and had a similar drop in their creatinine, or in essence, they had AKI, and the other groups changed across the way, right? So the idea here being that if you give someone a drug and their kidney responds to it in the way that you think that they should, it's probably a good sign that the kidney is functioning. The data around this is a little bit mucky because in the UK, where instead of looking at it just in the setting of heart failure, they looked at it in all comers. They demonstrated that in the broad population, if you start people on ACEs or ARBs, that any change in serum creatinine is associated with an adverse outcome. And adverse outcomes, as you can see here on the left, whether you talk about the development of end-stage renal disease or cardiac issues or mortality. And this was a large-scale epidemiologic study across the whole population. And we have to figure out, well, what's normal? What should we expect? And are there subtypes? You heard from Dr. Parsa that in cardiology, they've done a nice job of sort of subphenotyping their groups. Who should we expect a change in serum creatinine in, and who we shouldn't? There isn't a ton of data outside of ACEs and ARBs around this, but we all know as nephrologists, we're seeing more and more people who were starting on SGLT2s and MRAs. There's some data from 2013 looking at small cohorts started on spironolactone and demonstrating that that same phenomena, the drop in GFR that you can see around the time of starting the spironolactone is associated with decreased proteinuria long-term and perhaps better mortality. But with regards to the SGLT2s and MRAs, in preparation for this talk, I went to my friend George Bacris, who has an office a few doors down from mine, and asked him, hey, George, we know that the people who get started on SGLT2s have these large or changes in their GFR and creatinine. Is there any data to support the idea that a 0.2 change is great, but a 0.5 change signals some sort of error? He didn't have that data. It doesn't exist. I think that we as nephrologists should be thinking about that to try to determine, as we start more and more people on SGLT2s and MRAs, what is the significance of those changes in GFR over time, right? So we're going to transition now and talk a little bit about the furosemide stress test. This is a second case from a patient we actually enrolled in one of the FST protocols that you're about to hear. 54-year-old gentleman. He's got a known history of chronic hemorrhagic pancreatitis, both from a history of diabetes as well as alcohol use. He was in our ICU. His hemoglobin was dropping. He was becoming more short of breath. His pancreatic enzymes were up. He failed non-invasive ventilation and required intubation. You can see there with 60% FiO2, a little bit extra PEEP. He had low MAPS and was not yet on vasoactives, but getting some fluid, and his urine output was low. Over the last 6 hours, he was making 30 to 40 cc's per hour. His creatinine over that same period of time is drifting up from 1 to 1.3, so he has early stages of AKI. And you are about to give him, or someone is about to give him some furosemide. And the questions are, what does his response to it tell you? Are there other biomarkers that can sort of help you figure out which way this patient is going? And this leads us to the furosemide stress test. This is sort of a mini journey of my furosemide stress test history. It starts up here at Stony Brook, where I was in med school, where George Kalianides ran my medicine rotation. And I distinctly remember on a Friday morning, people saying, hey, we're going to give this guy some Lasix, and if he doesn't pee, we're going to start him on dialysis before the weekend. And then I went to the University of Chicago, and they said the same thing. And then I'm not sure if this was Dr. Starr's ABC meeting. No, he's saying that it wasn't. But I distinctly remember meeting this guy, Ming Chawla, at this meeting and having him do the exact same thing. The meeting was in person at the NIH campus. He was at GW at the time, and he had to go back to GW because the patient had failed their unprotocolized furosemide stress test. And he had to go back halfway through the meeting to go put the line in. And it led to a conversation where eventually we started to collaborate and do work to look at the furosemide stress test. As you've already heard from other speakers, right? And as a reminder, furosemide is not filtered at the glomerulus. It's secreted in the proximal tubule, and then it needs to make its way to the thick ascending limb, where it can block the sodium potassium 2 chloride pump. And then you need the rest of the distal tubule and collecting ducts to all be acting okay in order for it to have its optimal impact. And so that's why nephrologists have used it for all this time, is that it is a great marker for how well or not well your nephron is working in multiple segments of it. And so with that in mind, Ming Chawla and I and others published this first paper in 2013, which was a combination of retrospective as well as prospective patients who had early AKI, just like the patient I provided, the patient case I provided, stage 1 or stage 2. Specifically, we only wanted patients who were euvolemic or hypervolemic. This involved going to the teams and saying, do you think your patient has euvolemic or hypervolemic AKI? And if they do have euvolemic AKI, what do you want to do if we give them protocolized furosemide and they pee 5 liters? So there was an option here to give people fluid back if you thought they were euvolemic, to make sure you didn't induce hypovolemia. And so we gave patients either 1 mg per kg or 1.5 mgs per kg of IV furosemide, depending on whether or not they had ever seen a loop diuretic in the past. And we demonstrated that in the setting of that early AKI and the protocolized furosemide, the amount of urine a patient makes in the next 2 hours could actually be used to predict a variety of short-term outcomes. We demonstrated that if you did not make 200 cc's of urine in those first 2 hours, you were more likely to progress to stage 3, more likely to require the need for dialysis. It actually received dialysis, and that the cutoff of 200 cc's in 2 hours provided sensitivity and specificity both of around 85 to 88%. And you can see on the left, we started with a small cohort, but you see very nice AUCs in terms of above 0.85 for progression, the receipt of dialysis, which we'll come back to, a little bit less strong for mortality. It is harder to predict mortality, and then still above 0.8 for the combination of progression of AKI and death. We then went on to validate this same idea in a multi-center cohort with colleagues from Canada and UCSF and Hopkins, where here now we had 90-something patients. We demonstrated the same idea that whether you talk about the individual hours or the cumulative 2-hour urine output, how much urine you make in the setting of early AKI after a protocolized dose of furosemide can predict your progression to stage 3 AKI. and not just stage 3, but again, the receipt of dialysis and increased risk towards death, longer lengths of stay, both in the ICU as well as throughout the hospital. And this is data that others have validated since. Katja Gist and a group have looked at it in kids. You can see over 100 kids, about a quarter of whom, or 20% of whom, had severe AKI, and they demonstrated the same idea that if you give them a furosemide stress test, the 2 and 6 hour urine outputs predicted progression of AKI. Kent Doi in Tokyo demonstrated the same thing in a Japanese cohort. They had a slightly different cutoff of 232 mLs in 2 hours, but a very similar performance. And then Boheen McMahon and others have published that the same thing is true in the setting of transplant. If your transplant surgeons are like my transplant surgeons, right after they anastomose the kidney, they usually give a slug of urine because a slug of Lasix, because they love seeing that urine output. And the same idea here, that if you give, instead of a weight-based protocol here, they demonstrated that if you give 100 milligrams of furosemide, which is what they were doing at Hopkins at the time, to a freshly transplanted kidney, if it didn't make 600 cc's in 6 hours, you get a similar AUC for the need for dialysis and a protocolized definition of delayed graft function. Right. And so the kidney is able to sort of tell you its response to furosemide. It is imperfect, but still performs pretty good. We, back in 2015, hard to believe that's nearly a decade ago, published a paper looking at the performance of biomarkers in a cohort who'd gotten the furosemide stress test. And we demonstrated that many novel biomarkers at the time had the ability to similarly predict the progression of AKI to stage 3. None of them were able to match the performance of the FST. Very few of them were able to actually predict the need for the receipt of inpatient dialysis. I'll take the time here to sort of highlight that the FINA, which was something also that George Kalanides taught me about decades ago, didn't really perform well at doing any of these things. I still find it vexing that people still order it, people still use it, people still teach about it, even though over the decades, it hasn't really been as well validated. What we did show was that combining the biomarkers with the FST actually improves some of your AUCs. That if you look at patients who have either elevated urine NGALs or elevated TIM2 IGF-BP7s prior to the FST, those two things begin have the ability to increase your AUCs, and you see we were able to get AUCs up above 9, recognizing that combining biomarkers and having a multimodal approach, perhaps similar to what Dr. Parsa described the cardiologists have done, improves our ability to find patients in the hospital who are destined for some of the worst outcomes. We have looked at other biomarkers besides NGAL and TIM2 IGF-BP7. Here's some data looking at some of the proximal tubule markers that you heard Dr. Kestenbaum talking about. They did not, unfortunately, demonstrate the ability in the plasma to predict whether the need for dialysis, progression to stage 3, or death. When we looked at these same markers in the urine, we saw that hipurate, which is something you heard about in the previous talk, maybe had some ability to do it, but some of the other uremic toxins that are usually transported across the proximal tubule didn't share that ability. And it's probably because they're just giving you information about the proximal tubule function in these folks, and you need those other pieces of information, the information about the thick ascending limb, the information about the distal tubule. Others have attempted to use the furosemide stress test. This is a paper that was just published a few months ago by Raj Basu and Stu Goldstein, who I think is talking later in the sessions today, where they used a multimodal approach. They used the renal angina index, which is a tool that they use to identify sick or critically ill pediatric patients who are at high risk for AKI. They then use the NGAL, just as we described in our prior paper, as a trigger for a furosemide stress test, as a way then to determine whether or not patients should be fluid resuscitated or perhaps even be started on RRT. This is the Taking Focus 2 study. Right. Others have similarly used the furosemide stress test. This guy here is Alex Zarbach. Alex, myself, and Melanie Mearsh looked at a separate biomarker, CCL14, which is a marker of macrophage activity in the setting of patients who had established AKI. So here we're looking again, patients with AKI, we looked at more than just CCL14. We looked at DPP3 and NGAL, and demonstrated, though, that in this cohort of patients with established stage 2 AKI, CCL14 correlated and was able to identify which patients were going to fail their FST, which patients had low urine output following the FST, was being able to be picked up by the CCL14, and that it not only predicted the failure of the FST, it also correlated with patients who had a clinical indication for dialysis, not necessarily receipt of dialysis. As you guys all know, there's been a wealth of studies out there recently looking at the timing of initiation of RRT in the setting of AKI, and something that our first FST studies didn't do. We just looked at patients who received RRT, and we now know that probably 20 to 30% of patients who maybe have an indication for RRT never actually receive it, whether because of goals of care or because it isn't needed because they remain polyuric. And this study actually demonstrated that not only could the CCL14 predict the failure of the FST, it was very accurate in predicting who would have an indication for dialysis, regardless of whether or not they received it or not. Right, going to transition away from talking about the FST per se, but there is plenty of other data looking at the response to Lasix. Our cardiology friends, as Dr. Parsa talked about, have done a nice job here, and this is more data from Jeff Testani from his time at Yale, where they looked at a multi-center cohort of patients who had heart failure and looked at the response that patients had to Lasix in terms of looking not just at the how much sodium was in their urine in response to the diuretic, but also using liquid chromatography to look and see how much furosemide actually appeared in the urine, perhaps as a marker for how well or not well the kidney was working. And they demonstrated that you can use the urine sodium to urine furosemide ratio in order to assess whether or not your patient is having an appropriate response to the furosemide. And this is, again, a paper that is 10 years old. Since that time, Jeff and others have begun to do a lot of work looking at the urine sodium after protocolized doses of any diuretic to determine the ideal way to diurese a patient in acute decompensated heart failure. They've developed complicated machine learning algorithms that can, based on the patient factors, tell you how much and what the ideal protocol is to diurese those patients. So much so that within the European guidelines 3 years ago, looking at the spot urine sodium was part of the active plan for diuresis. And taking it one step further, just within the last few months, there was a randomized control trial that was published looking at urine sodium values to guide diuresis, and building out an entire protocol that if your urine sodium does not get up above 70, you need to step up your diuresis, and increasing the dose in response to how much sodium is in the urine was demonstrated to improve the diuresis, not necessarily improve the outcomes. I think that it's an interesting concept. They demonstrated that you can make 600 cc's to nearly a liter more in 48 hours by checking Q6 to 8 hour urine sodiums and escalating your diuretic regimen, and it will lead to negative fluid balance. I'll take the opportunity to chide the cardiologist that not every study that they do is positive, because it didn't lead to improved mortality. It didn't lead to changes in some of the other biomarkers that they have built, but it has helped get fluid off of people and maybe get them out of the hospital faster, even if it doesn't improve their outcomes. But this idea that we've got other folks, non-nephrologists, using the kidney's output as a way to improve their treatment should be, at least for some of us, motivation to sort of better harness the kidney and all the things it can do. I'm going to close out with 2 last slides here talking about a separate biomarker. This is urinary or bladder-based oxygen. This is a slide from a paper recently published by Ronaldo Bellomo and his group in Australia, where they use a sheep model of sepsis, and they use this device up here in the upper right to measure bladder the bladder's partial pressure of oxygen. And they demonstrated that in the setting of giving these sheep sepsis and looking at the bladder oxygen, and then actually being able to measure it a little bit easier in a sheep model than in humans to compare it to medullary PO2. They demonstrated, as you can see here, that medullary PO2 within the kidney correlates quite nicely with bladder-based partial pressure of oxygen, and that the changes that you see in it occur earlier than, say, changes in serum creatinine or even changes in urinary NGAL that you can see down here. And so that you're going to hear more and more probably about the partial pressure of oxygen within the kidney. And for some of you, you may have already heard about it. There's lovely data out there looking at cold MRI and oxygen consumption within the kidney as a marker for CKD. This is a study that uses both the oxygen consumption, but uses furosemide as a way to measure that when you give furosemide, as we talked about before, it inhibits the sodium potassium 2-chloride pump, and then that will actually decrease oxygen consumption. This is a lovely study that is now close to 15 years old, where they looked in patients who had known renal vascular disease, so that they all had either renal artery stenosis or an atrophic kidney. They gave those patients furosemide, and they were able to demonstrate through bold MRI that there were no changes in the kidneys that were ischemic or had decreased blood flow, but that within kidneys that were being perfused, you could see that there was the drop in oxygen consumption that you would expect to see. And so there may be ways, as we figure out better ways to measure urine or bladder partial pressure of oxygen, being able to use that in concert perhaps with bold MRI as another way to sort of think about stress testing the kidney, or thinking about it in concert with furosemide, right? So as I close out here, right, I think that there are several different clinical questions that we can think about. The first one, as I mentioned in the first few slides, is when and what does a change in creatinine or change even in cystatin after starting SGLT2s or MRAs, or in the setting of active acute heart failure, where I know in my hospital, oftentimes now people are leaving the hospital being started on all three of these things, if not more. Figuring out what's the appropriate change in creatinine is important. Standardizing some of these biomarkers, which are in place for things like NGAL, but less so for things like partial pressure of oxygen. And then how do we go about identifying new or different biomarkers, right? There are several of these stress tests that exist. Some of them are validated, some of them aren't. You've heard a little bit about, I already said all these things. So I'm going to stop because I think I've run a little bit long. I want to thank my colleagues who made some of the FSC and other work that we do possible. And then this is me standing underneath a rainbow. Look so happy.
Thank you very much, Dr. Coyner. There are quite a lot of questions in the chat. Dr. Meyer, would you like to start off? I think we've only got about 10 to 12 minutes for questions.
So I'll try to summarize some of the ones directed at Dr. Kestenbaum, and I apologize to people for not identifying them as the originator. I've tried to compile a list while Jay was speaking. Brian, a first question is, when you calculate secretory clearance, should you subtract the GFR? In other words, what you're asking is a separate index. And related to that question then, what's your GFR measure going to be? You use creatinine, which is itself partially secreted. And a third possibility, of course, is that the secretion depends on the renal blood flow, which may be reduced independent of the GFR.
That's a lot. Okay.
There's more.
Yeah. So, I mean, in terms of the subtraction part, I mean, I think ideally we'd like to stick with, if we had a marker that was truly, 97% protein bound or higher, and we're pretty convinced that there's not much filtration of that marker, we wouldn't. But if the marker was something more like the old PAH, where it's not completely protein bound, it's only 30% protein bound, yes, I think ideally subtracting off measured GFR would be a good idea. And creatinine, obviously, because it's partially secreted to a small degree, would not be the ideal way of doing that. The second question in there, I'm trying. Can you remind me of the second one?
Well, in other words, the secretory clearance depends. I can summarize some of these by saying investigation of things that might have affected the secretory clearance independent of the GFR. And your questioners have asked you about known genetic differences. They've asked you about known differences in expression of the secretory transporters. They've asked you about the effect of agents that affect tubular metabolism, in particular SGLT2 inhibitors.
Yeah, and blood flow. And blood flow, of course, is huge, right? Because if there's a change in the per tubular capillary flow, I mean, there's a change in renal blood flow, and it affects both, GFR increases or decreases GFR and secretory clearance. That could be sort of an overriding factor in which both filtration, GFR, and the clearance of a secretory marker both increase or decrease in lockstep, right? It's possible that if the renal blood flow is going up and down, those two could go up and down together. Genetic stuff, as people have pointed out, there's many pharmacology papers showing that these different polymorphisms in the oats or in the ox have effects on certain drug metabolism. It's not as I've gone through those, not all of those replicate very well. And I'm not sure the actual role in a large population of truly getting at the variance in the oats and the OCT transporters and seeing what their functional significance actually is. It's something that we need to do. I'm not convinced that I do think we have polymorphisms in those genes, but I'm not convinced that those polymorphisms, at least based on the data I've seen, have large impacts on the function of the transporter.
And how about, Brian, again, more of the same, different disease states having different relative effects on secretion versus GFR?
Yeah, so we saw we did a pilot study in PKD, early PKD, before GFR was appreciably decreased, and found that on average, their secretion, their ability, or at least their kidney clearance of these suspected secretory solutes was lower compared to people without polycystic kidney disease, which could suggest that there's one state there where there could be an early defect in secretory clearance, and we're trying to follow that up with additional studies. I think any disease state in which the timing and or the pathophysiology targets the tubules is the time, a time when you'd see distinctions. It could be early AKI, it could be in metabolic effects in PKD, it could be in an interstitial nephritis, say, where you think that GFR is mostly preserved or should be preserved, but there's difficulties in potentially the active transport required to pump these things across into the urine.
But Brian, would it be fair then to say that we haven't got far enough to do that yet, except for your PKD study, that you and I can't go through a population of CKD patients and say, this is the subgroup which, either because they're genetically different or because the tubular injury is different, this is the subgroup that has reduced tubular secretion compared to GFR.
Right. We do have a funded grant to look at the trajectories of this in AKI, and we've finished recruiting, and the measurements are ongoing, but I don't have any data.
So you've just answered one of the other questions. Let me just make sure I haven't neglected a question to Jay here. I had one about the renal oxygen, Jay. The late Frank Epstein, who I thought was the leader in renal physiology in the last, around the year 2000, for a long time considered the possibility that it was increased oxygen consumption in the thick ascending limb, where the oxygen tension in the environment is lowest, that drove AKI. And I think there was a long series of experiments, not only to use furosemide as a test of AKI, but to prevent AKI. My memory is, I was younger at the time and knew his lab people, there was that every study was another nail in the coffin.
Yeah, right. I think that you're right. If furosemide was able to actually prevent AKI, no heart failure patient would ever get AKI, but we know that they do. I think that there are these interesting techniques that not just Belomo or the studies that we showed. I know that Prasad up at Dr. Prasad up at North Shore is continuing to look at both the partial pressure of oxygen within the bladder, but pairing it with these ideas of using the furosemide as the ability to suppress oxygen consumption. It seems feasible, right? This isn't my area, and I will claim that I'm just a humble clinician investigator, but I think that you're right, that those studies demonstrated that didn't prevent AKI, but I think the idea would be to use it as a marker for the patients whose kidneys are most injured and not demonstrating the physiologic response that you expect to see to the furosemide as a way to then trigger other interventions in them, if that makes sense.
And Afton, I think we have about one more minute. Another question, Jay, and this is a clinical question. Some of the guidelines talk about doubling the outpatient dose of furosemide. When we see trainees, I sometimes ask them, why don't you just give the patient who's fluid overloaded the max dose and see how fast you can get them to pee? Why give them a dose of 1 milligram per kilogram or twice the oral dose IV?
Yeah, so there I think that some of that relates to the potential toxicities and the idea that, yes, you want to get these people peeing, but you also, I'm fond of saying that slow and steady wins the race, that you don't get any extra effort for getting 4 liters out in half a day versus 4 liters out in the day, and that doing it over time. And now we've got ample data, not just from what I showed you, but from looking at things like the Caress and the Rose trial that have, you're not starting at low doses, but starting at mid-range doses and then escalation protocols in place rather than starting, say, with a drip, where there is ample data that demonstrates exposing people to a continuous drip of a loop diuretic actually puts them at risk for harm, whether in randomized controlled trials or actually in retrospective cohorts, which are obviously biased because people are starting the drips perhaps because there's the patient is more critical. But even in some small RCTs, starting people on higher doses or higher exposures has been associated with adverse outcomes.
Afton, I think we're done
you.
30 seconds early.
Could I just jump in very, very quickly? Because I think there is one quite interesting question from Dr. Chen here. I think, and it applies probably to both, but I will direct this to Jay, just the question of how the furosemide stress test works in patients who have underlying CKD. And I think one could possibly add to that, I think cardiac output, serum albumin are obviously also things that probably impact the responsiveness. And then the final question there would be, you mentioned patients who've chronically been on loop diuretics. Would you give a thiazide like metolazone as well? But the first question was really in terms of when a patient has underlying CKD, is it as helpful?
So in our studies, for sure, it was helpful that the average patient enrolled in those studies, we believe based on how we calculated their baseline function, that they had CKD. And then speaking honestly and anecdotally, that when you start thinking about what the cardiologists do, the supermajority of their patients all have some amount of kidney dysfunction. In terms of hypoalbuminemia, I think that that's an interesting question. I think that we know that the albumin in our cohorts was low, but not kicking and screaming low in the between 3.5 and 4. I think that there's an interesting study that I think just started recruiting out of Canada to look at the idea of supplementing albumin in people who have established AKI as a mechanism to perhaps improve outcomes. I can't in good faith say that we gave people albumin plus diuretics. I think that in patients who are not responsive to the furosemide stress test, or now we've got good data in patients who are not having solute diuresis, that yes, you have to go through the algorithms, which to me, the next step would be adding a thiazide, but can include things like adding a carbonic anhydrase inhibitor and moving towards total nephron blockade, blocking with even something like spironolactone, whereas I'd say 25 years ago when we started, the idea of giving someone an aldo agent in the setting of early AKI would have been taboo. I think that we are a lot more comfortable doing that, knowing that the data in certain populations around heart failure and maybe even liver patients demonstrates that getting them decongested is the key. Changes in creatinine and our ability to manage hyperkalemia are secondary factors.
Okay, thank you. And maybe just one final comment. I think this has been really a fantastic session. We all know that there are patients with very, very low GFRs who do pass quite a lot of urine. Those patients tend to do better on dialysis. So one kind of wonders whether somehow the tubular function might actually be helping, you know, those patients to do so much better. So I guess hopefully we'll be unraveling this a lot in the future. So thank you very, very much for your wonderful presentations. Thank you for all the questions, and back to Afshin.
Okay, great. Well, thanks for a great session and a fantastic kickoff. I think it's probably okay if individuals want to put in more questions in the chat, and then maybe Jay and Brian can respond directly there. And of course, tomorrow there'll be a full session to really discuss this and go over questions in much more detail. We're only about 2 minutes behind, so we'll switch now to the next session, which is measuring glomerular function. And Shishu and Andrew Rule are both going to moderate that session. And again, we have hopefully some stimulating talks. So I'll turn it over now to our moderators.
Hi, everyone. I'm Shishu. I'm a nephrologist and a clinical researcher at UCSF. I'm going to introduce Jesse Sigmiller. I see him on the Hollywood Square here. He's a board-certified clinical chemist and associate professor in the Department of Lab Medicine and Pathology at the University of Minnesota. His primary research interest is kidney disease, where he focuses on novel testing at the University of Minnesota Advanced Research and Diagnostic Lab. He also runs the, as medical director, the mHealth Fairview Health System, where he oversees esoteric and toxicology testing, as he puts it.
Good morning, everyone, or for some of you anyways. I'm Andrew Rule. I'm the other moderator. I'm a professor of medicine and nephrologist at the Mayo Clinic in Rochester, Minnesota. I'm going to introduce the second speaker, Leslie Inker. She is a professor of medicine at Tufts University School of Medicine and medical director of the Kidney and Blood Pressure Center in the Division of Nephrology at Tufts Medical Center. Dr. Inker is a co-director of the Chronic Kidney Disease Epidemiology Collaboration, known as CKD-EPI, and her work there has been critical for progress in GFR estimates and endpoints used in clinical trials. And we will now start with our first speaker, Dr. Sigmiller.
Thank you for those kind introductions. Hope you're all able to see my slides okay.
Yes.
All right, here's some disclosures by Dr. Inker and myself. And the objectives for this talk today will discuss the current state of measuring GFR. We'll also go over the difference between measured GFR and true GFR, and the impact and limitation of measured GFR on derivation and evaluation of eGFR, and then close with some clinical and scientific gaps in this area. So overall, the GFR provides the best measure of kidney function to date, and that's kind of what I think everybody's convening today. I like GFR because it's relatively simple on what it's supposed to do, right? So markers of GFR should have the following qualities. It should only be removed by the kidney's glomerulus. It shouldn't be secreted. The marker shouldn't be secreted or reabsorbed. It shouldn't be bound to protein. It shouldn't be metabolized, and it should be easy to measure. So these concepts, while they're very simple, they're hard to find compounds that display all these traits. So going way back, this is from one of those places that you call a library that you had to scan it in. This is the work by Homer Smith and one of the early studies in inulin clearance. And what they found is the inulin was basically cleared 100% in the urine over 24 hours. And the way they looked at these inulin clearances is they would perform a continuous infusion and then look at its plasma and urine concentrations. But as everyone knows, likely on this talk, is historically inulin has served as this gold standard in determining GFR. And what inulin really is, I had a really hard problem with this right away because it's not really given in textbooks, but inulin is really not a single thing. It's a polymeric material. It's this fructose polymer specifically. And if you use cold inulin or analyze cold inulin techniques, you would look at, you'd use an enzyme, you'd cleave this polymer into the monomer subunits of fructose, and then you'd analyze the fructose. So this inulin hasn't really been available since I've been in this area. It was very expensive. You had to heat it up, is my understanding, talking to other people that did do these protocols, to have these polymeric subunits go into solution and then administer them into patients. One thing, looking at IV bolus versus continuous infusion, I found this is very interesting. When you look at, and here was a paper again going back into the library time. You look at inulin. If you give it IV, you will get a difference in your venous concentration and your arterial concentration. That difference is about 7.5% shown in this study. If you give another agent that's both secreted and filtered, you can see the difference between the venous and the arterial concentrations increases even more so. In this contrast, or this compound called diodras, which I'd never heard of until I read this paper, has a difference between the venous and arterial concentrations of about 30%. But if you perform a continuous infusion, you sort of normalize these sorts of things out. And that's why a lot of the older approaches to measuring GFR use these continuous infusion approaches. Again, here's this isn't inulin or anything like that, but just shows a drug. If you give a bolus IV infusion, the arterial concentration is typically higher right away, and then it gets eclipsed by the venous concentration over time. So, and again, that difference is going to depend on how fast that marker is cleared or not, where inulin is only cleared by GFR, and if you have secretory capacity as well, that'll increase even more so. So where do we stand commonly today? We can either measure like a urinary clearance, or we can do a plasma disappearance to measure GFR. So the renal or urinary clearance, we can perform a continuous infusion or do a subcutaneous administration. And really we're looking again, as has been covered, the urine divided by the plasma concentration during that test. One thing about it is you have to really pay attention to the pre-analytical things before you even get to my lab. You have to carefully collect the urine. You want to report that down to the milliliter. Whether you have a multiple or single collection period is important. And typically the urinary clearance methods have employed iothalamate contrast. Plasma disappearance, this is done with a single IV bolus of the filtration marker. You don't need urine in this case. But if you looked at the area under the curve, you would look at the fast and slow component and then compute that to get your GFR. The common equations, there are a couple of common equations. There's several equations, but a couple of common equations that are employed to calculate the GFR are the Brockner-Mortensen equation, which is a multi-point calculation, and then there's a Jacobson, which is a single point measurement for calculation. And so the protocol requires you to know the dose that you gave. And then the other thing that you should note is the blood collection time is dependent upon the patient's GFR. So if you want to look at somebody with a kidney donor versus end-stage kidney disease, you're going to have to likely have different protocols, and we'll go over that a little bit. Typically, we employ iohexol contrast in that. There is a review of different contrast markers that's kind of depicted here. So there's several. I'm just going to highlight a couple here. Iohexol plasma disappearance with respect to inulin clearance, and then iothalamate renal clearance with respect to inulin clearance here. And again, the level here was P30 with a criteria of greater than 80% in these studies. And they're showing the scientific evidence for this as a GFR marker, exogenous GFR marker. So again, looking at urine, the urine concentration of an analyte. Well, what does that mean? So what we find in the urine is can consist of the amount that's filtered, the amount that's secreted, and the amount that's reabsorbed. So the urine concentration is the filtered plus the secreted minus what's reabsorbed. And historically, when you read papers and things like this, any deviation you have from the inulin clearance, if you have an increase in your marker with respect to inulin clearance, it's generalized as secretion, and a decrease in clearance has been generalized generally as reabsorption. So some of the early iothalamate studies, again, they were infusing inulin while they were looking at clearance of these contrast dyes. And this is a radioactive study of iothalamate. And what they found was they're very tight correlated with inulin. And here's the simplified equation here, UV or P. This is where I got involved in measuring glomerular filtration rate using urinary clearance of iothalamate. And I thought this was really interesting, and it kind of speaks to something that was covered earlier with Dr. Kestenbaum. I thought it was really interesting as you went from a high GFR to a low GFR. And keep in mind, the creatinine in this case was collected at the same time under the same conditions in the same container, and it was analyzed basically simultaneously. And so at the high levels of GFR, they're basically distributed pretty evenly about the mean in this study. Again, the power's maybe a little bit low to discuss that. But as you go to lower GFR, you can see this trend going from, say 40 down to, end stage kidney disease here. And some of the, theories behind that is, the glomerular filtration rate mechanism, or the glomerular filtration is decreasing. And so maybe another mechanism is picking up, like secretion, is picking up that weight. So just to cover a quick protocol. So this is a subcutaneous protocol that I was with a few studies. And basically, you collect a quality control sample of blood and urine before you perform this contrast injection. You inject the contrast. You then wait for an equilibration period, and then you have the patient excrete the urine. You then collect blood at that time point, and then collect the urine. You wait another 40 to 60 minutes, and you collect the urine, and you bracket that urine collection with your final plasma, or you can do multiple periods after that as well too. And so what you do then is you take this urine, this U1 concentration, you divide it by the plasma, and you record how much urine was voided at that time to the milliliter. So the nice thing about the renal clearance approaches, in this case anyways, is the entire procedure was pretty quick. So about 2 hours or less than 2 hours in this case. Again, there's alternative approaches, continuous infusion and things like that, but this is a pretty quick and method to do this. So the benefits of the urinary approaches is you can complete these, in within a day for sure. You can also, the collection time doesn't depend on the patient's GFR, which you don't know anyway, because that's why you're measuring it. And then the calibration issues of dividing the urine divided by the plasma generally factors some of that out. I'm assuming that you can get both sample types on a single calibration curve. And then the fun thing that I always thought when you do the urine clearances is you see what's coming out of the kidneys. Some of the drawbacks that people may not always think about is if you have genitourinary issues such as urethral reflux, this may be invalid to collect urine. Young children or people that can't void on demand can have problems as well too. Generally, you want to employ a bladder scanner to make sure that the bladder is completely emptied. And then you want to collect the urine accurately. So a lot of times when people do urine collections, they'll collect it to the nearest 100 mil, nearest 10 mil. You want to collect it to the milliliter. There has been recent supply chain issues with iothalamate. I'm told that it has gone off the market. Cold iothalamate has gone off the market, but the radioactive glow-fill iothalamate is still on the market. So this brings me to what's the perception of urine collections? And so when you talk to staff and you talk to clinicians and things like that, here's an ED's physicians how they perceive urine collection. So they think a shoulder reduction is pretty easy, and intubation is pretty easy, a thoracotomy is easy. Collecting urine samples way harder. Okay, so these are things I don't see in the lab. So this comes back to us. But here in Minneapolis at mHealth Fairview, to qualify kidney donors, we perform a plasma disappearance protocol, and it's part of the criteria that they reach over 80 mils per minute in order to donate. And so we're not looking at the urine, we're just collecting the plasma, and we collect the blood at 2 and 4 hours. So we looked at the theoretical blood concentration of iohexol. In this case, you have this distribution phase, and then you have our sampling phase. So this is the constant elimination phase here. You then input this into an equation. And so this is the Brockner-Mortensen equation. So there's a correction factor as well that's employed, because if you just looked at the clearance of iohexol, you would overestimate the GFR. Another thing to keep in mind when we do the plasma disappearance approaches is the clearance is focused on, or you need to know the dose that you gave. So that's important. If you have any error in the dose, that can mess up your GFR calculation. And also it comes back to the laboratory. So if your laboratory is inaccurately measuring the specimens, you can have error. It's going to be directly inputted into your calculation. So again, I don't want to take too much time here. Just the basic protocol is giving, 5 mils of this contrast a certain time later. In our case, we have 2 hours later, we collect our first plasma, and then 4 hours later, we collect our next plasma, and the samples are sent to the lab, and then we analyze those in the lab, and then we calculate the iohexol clearance and put it in the medical record. Another approach, rather than the multiple collection, time point collection, is the single sample plasma disappearance approach that you can take. Now you need another additional information to do this protocol, the single sample protocol. So just like in the multiple sample protocol, you need the dose, but now you need to know the volume of distribution. And then you also need to know the appropriate sampling time. And the appropriate sampling time is sort of needs to triangulate that for the appropriate sampling time for your volume of distribution and your GFR level of your patient population as well too. This just kind of shows one study where they looked at the multiple component versus the single component here in a Bland-Altman analysis, which is in mils per minute. It's not a percentage, it's actually direct. So if you change this percent into percentage, you'd see the exact opposite sort of graph here. Just trying to frame this into what does this mean? What does all this stuff mean? So when you measure GFR by these different methods, if you did a single sample approach, a multi-sample approach, or you looked at renal clearance. The single sample approach, if you looked at it from 3 hours, in this case, or a patient that has end stage, you would get a level of 23, and then 24 hours later, it would suggest a level of 6 mils per minute. Whereas the multiple sample approach would be a little bit lower. So you can see if you sample earlier, you're going to overestimate the GFR, basically, is what this is showing. And so the multiple sample approach still sees that same sort of thing. If you go out longer periods, it's got to be set up, the protocol should be set up for your patient population. Now, renal clearance, it looks like in this case, was able to get the answer in a shorter period of time. And again, there was just showing another example in this study. So that's just, I think this study is kind of neat to show the different approaches that you can take in measuring GFR. So just to focus on the benefits and pros and cons of plasma disappearance is you don't need urine. It could be used in young children. So there's a study, CKID, that I'm involved with. If patients can't void on demand or have voiding difficulties, or maybe they have a genitourinary condition. From a laboratory standpoint, there's a proficiency program, a laboratory proficiency program for iohexol called Equalis. So that's nice. You can keep your laboratory on calibration. The drawbacks of the plasma disappearance is really the time that it can potentially take. If you have a low GFR, you may have to extend out almost 24 hours to get an accurate GFR determination. You have to have accurate doses. And then also there was a previous supply chain during the pandemic as well. One nice thing that's coming soon, and I've seen some of the collaborators on this paper that are in attendance today, is there's a consensus paper where they obtained input from internationally from a lot of experts all over the world. And this took a long time, over I think a year to complete. But the nice thing about this is providing a first step in sort of standardizing the approach to measuring GFR using iohexol. For a lot of these questions that I answer with collaborators and things like that, I can hopefully point them to this study in the future, talking about how many samples or what a sampling approach you want to take, how your infusion study, blood sampling, how to calculate it, how to measure it, etc. So this is currently unpublished, but it's in submission by Natalie Ebert and collaborators. Why does the laboratory matter? So this is when I didn't really appreciate this until I get involved with something. I was a fellow at the time We looked at this. So here's some data from my lab, University of Rochester, and another laboratory. And you can see the concentrations here of this round robin study, the differences that we saw in the laboratory. And so the University of Rochester at that time was off by about 15%. And so some of the equations needed to be amended because of this laboratory error. And so I gained a real appreciation for like how accurate you have to be with your iohexol calibration. And our laboratory at that time, when we made new calibrations, we needed to be within 2% of our previous calibration, but we didn't know about this Equalis. And as soon as we found out about this Equalis system, then we subscribed to that. And this is how we've been performing ever since then. And so I think I'm running a little bit over for Dr. Inker, but I'll transition over to her now.
Thank you. Okay. I think I might need to, are you seeing my screen or they got to change it, right? Okay, can you see the screen now?
Yeah,
Yeah, we got
difference
it.
in
That's
measured
it.
GFR versus true GFR.
Okay, perfect. All right. So Jesse and I collaborated on this talk, and so I'm going to continue on with the outline. And the next topic is the measured difference between measured GFR and true GFR. So this is a conceptual framework that Andy Levy and I developed to talk about these concepts. Of course, we measure GFR, and you heard a lot about from Jesse how we do that. But really what we're interested in is the underlying physiological parameter, which we can call true GFR. You can't really measure physiological function directly, or at least not in humans. And so one potential working definition for true GFR is the average GFR measured on at least 2 occasions using the same protocol, using similar conditions. And why do we talk a lot about the protocols? Well, just as Jesse talked to you about, there's a lot of different potential errors or variations in measured GFR. So filtration marker properties, the first systematic review showed from Dr. Severny, talked about the systematic error between one filtration marker to inulin. And this would be considered a bias in one protocol compared to what we were truly interested in, which is a measured GFR using an ideal filtration marker. We also learned a lot about other errors that can happen in particular procedure, errors related to clearance methods or assay errors. And these are, I would think, consider imprecision in the measured GFR. In well-controlled studies, the CV for one GFR and one time to another time is about estimated at 5 to 10% for repeated measures. However, these are under still ideal circumstances. And one of the questions that came to us in the introduction was, what about patients with different characteristics, such as edema, nephrotic syndrome? And I don't think we have good knowledge about the potential errors in such patient populations. What I'll be talking about, and I think this is the key point when we're talking about the difference between measured GFR and true GFR, is these issues of biological variability. We can think of GFR as related to the number of nephrons by the single nephron GFR, and factors that affect Starling forces are potential sources of biological variation. Exercise, obesity, level of protein intake, volume, blood pressure, all of these can change our GFR over the course of the day. And I think we understand this and we think about this to some extent. But wanted to focus here on something we probably less think about a lot, which is diurnal variation in GFR. And it's been documented now for many years, probably since the 1950s, maybe even earlier, that the kidney physiological functions display circadian rhythms driven by these intrinsic clock, which seem to be governed by different genetic factors. I think there's good evidence for diurnal variation GFR. The studies have been done predominantly in healthy individuals with highly controlled environments. I think there's less consistent evidence for diurnal variation in patients with CKD. And in fact, in some animal studies, it seems that when animals are given chronic kidney disease by different models, the circadian rhythm may disappear. There's been one study in patients in diabetes, which still document a diurnal variation, but I don't think we know as well across the full range of both acute and chronic disease what happens to the circadian rhythms. In my mind too, I was not as clear as to the extent to which our normal variation in diet and exercise disturbs these rhythms. I guess if I had to guess, I would say that the rhythms exist, but the magnitude may change. And I think that's just a relevant thing to think about when we think about how much do we have to worry about or attend to the diurnal variation when we're trying to understand GFR. And at the end of the talk, I'm going to try and give us some thoughts as to how we have to think about this, which may be good for the breakout groups tomorrow. So now let's talk about the impact and limitation of measured GFR on the derivation and evaluation of estimated GFR. Most, of course, are more strict circumstances we use estimated GFR. So now I've expanded the little figure I showed you earlier. We have true GFR again in the middle. I showed you this, which is the sources of variation in measured GFR and its relationship to true GFR. On the other side here, we have estimated GFR. I've drawn this ellipsis of eGFR about the same as measured GFR, because both E and M have some errors in it. Where here I've drawn our true filtration markers we use most commonly now, creatinine and cystatin C. Of course, if I had drawn just creatinine, the eGFR would be even smaller because of greater error. But the sources of error in the filtration markers are related to A, assay, E, extrarenal illumination, T, and E, tubular handling of filtration marker, or G, generation. And all of these factors have to be considered when we interpret an estimated GFR. This is from two different papers, one from our original report of the CKD epi equation 2009, and secondly, a more recent paper from Tarek Shafi and colleagues, and also looking at errors and individual errors in estimated GFR. What we drew here was this black lines, the bias or systematic error between measured and estimated GFR. But all the little dots and those dashed lines, which show the 30% line, show the overall variation or the imprecision in the error in the estimates compared to measured GFR. Dr. Shafi and colleagues described that error differently, but focused our attention on the implication of this error on individuals and individual decision making. So the question is, what are these sources of errors? This is a slide that we put together, a figure that we put together for a review article a few years ago, which summarized both the errors in estimated and measured GFR and the source of errors. We've first articulated the magnitude of the errors. So with estimated GFR, we generally talk about the percentage of estimates within 30% of measured GFR. With the best we can get so far is about 90%. And so what does that mean on an individual level? Well, if you're at eGFR that's presented as 30, then the 30% errors are from 21 to 39. If your GFR is 60, it would go from 42 to 78. But you have to remember that the measured GFR itself has errors. And if we translate that CV of about up to 10% that I showed you earlier, we can think of this as a percentage of the measured GFR within 50% of the second measured GFR, the truth. And that still has a range of variation. So if I have a level of measured GFR of 30, the 15% may say, maybe it's really 26 to 35. And so what are these sources of errors? Now, I think this can get complicated and it's hard to think about all this in one's mind. So I brought a little example. You're seeing a patient in clinic or you have a participant in a research study and you have a measured GFR and it's 30, but the estimate is 42. What are potential causes? I think our default brain is to blame the estimated GFR, and it's true, there are a lot of errors in it. But I think the point of this conversation too is that it could also be related to errors in measured GFR. So let's talk through these. So why could there be errors in measured GFR? Well, it may be that the true GFR is actually correct, but the true GFR is actually 42, but the measured GFR is 30 because of that we're only measuring the GFR of a very narrow period of time, and that was affected by the different measurement properties. There also could be non-ideal properties of exogenous filtration markers. So for example, that the inulin gives us the ideal filtration marker, which is not secreted or reabsorbed, but iothalamate is thought to be a little secreted. Or iohexol, there's some debate about it, but might be slightly reabsorbed, and so that would give a lower GFR. Or there's analytical variability, that there could be measurement error in the clearance procedure. And here I think is a really important thing for us to think about, is especially as there's going to be more plasma clearance, the timing of the last sample can affect the estimated, the assigned value for the measured GFR. Or as Jesse said, there could be potential for error in the iohexol values. And I have to tell you, I've seen a lot of variation in these assays from different studies that people send to me. So it's quite hard to measure this, and I think there has to be a lot of attention to it as we hopefully do some more measured GFR going forward. But it could be also this error that you see, this difference between the measured and estimated GFR, also could be in the eGFR. And it could be, again, conditions affecting the true GFR, that there's this that the estimated GFR is only reflecting a certain period of time, and this true GFR is over a longer period of time. This is less likely the case than in the measured GFR, which we ascertain over a shorter time frame, and that the estimates are more likely to have this average effect on the truth. It could be that there's conditions affecting non-GFR determinants of the serum concentration of endogenous filtration markers. And of course, we all know this is the big one that we're talking about, particularly when we talk about creatinine only, or even the combination of creatinine and cystatin C. And there's also potential error in the assay. And I think that this is something that's often overlooked, and it's really important to think about, less so in research studies, which are hopefully the assays are done over a short period of time, but are going to be bigger in clinical practice when we see a lot of variation in the assays. So let me just go through these a little bit to get them to understand, to help us think through them a little bit more. So this is a figure we drew a long time ago, which reminds us of the non-GFR determinants of the endogenous filtration markers. Of course, the generation, the difference is the biggest factor in determining variation among the filtration markers. That can come from our difference of our cells or from our diet. There's also some extra-renal elimination, which I think we don't think about at all, and I think are more, might explain some of the acute changes that we see. Particularly, for example, like antibiotics can change the bacterial flora and change the way creatinine is excreted through our gut. And we of course are thinking mostly about filtration, but we heard about earlier today, there are effects on secretion and tubular transport. And I think this is, again, something that's hard for us to measure, and so it's been hard for us to evaluate, but I think it's an important component. Why is this important? So for creatinine, I think we understand creatinine. And that's why I like creatinine, because I can problem solve through it. We bring in cystatin, it makes it a lot harder. We don't understand all of those non-GFR determinants. So what we did here with my research coordinator, Oge Adigapol, we did a systematic review of all of the studies that looked at the performance of cystatin-based equations compared to measured GFR in populations where we think creatinine is not going to be such a great marker. We categorized all the performance, both for our bias or the systematic error, as well as the P30, the percentage of estimates with a measured GFR, based on the magnitude of the error. And red is very bad, and so that's a large underestimate, greater than 10 in either direction, or very low accuracy, less than P30 of 80. With the orange being in the middle and green being what we considered reasonable, a bias of about 5 and a P30 a greater than 90. So you can see there's a lot of red. Overall, there's less, there's more green, so more good performance for bias for cystatin alone, as one might expect. But this goes away when you look for the large errors. And to me, this is, first of all, a path forward, as I'll come to at the end of the talk, that we need to move beyond both creatinine and cystatin C. But secondly, for the purpose of this discussion today, I think it also raises the question, is this because of very poor measured GFR, or is the measured GFR source of error? A lot of these studies are very small, and in populations who might have different bodily characteristics, where the protocol wasn't designed specifically to maximize accuracy of measured GFR in these populations. And we can't, I think it's a lot unknown, but I think this just emphasizes the importance of thinking about measured GFR when we're trying to understand how to move forward with our estimates. To highlight the importance of the assay, this is, back in 2003, when we started working with the CKD-FB equations in this development, we developed a 40 sample set that was the purpose of evaluating the stability of creatinine and and then cystatin and subsequently our other markers in the CKD-FB research lab. And we would measure these 40 samples every few months. And we compared these results to the QC samples that were done more frequently in the labs and to the NIST calibrators for creatinine and for ISCC for cystatin. We published this, Amy Carter published this, she's at University of Minnesota as well in Clinical Chemistry in 2020. And what we're showing here, this is for creatinine. This is over time, 2009, 2019. 2009 is when we started working with Minnesota. And this is the percent difference from our target. So overall, creatinine's pretty good. I mean, it's actually, I would say, excellent in terms of an assay. Here, the dashed lines at the 5% are the plus or minus 3 standard deviation, and that's at 5% for creatinine. Now, we think 5% is being a big deal for bias, and that's one of the reasons that we put in that green, that 5 mils, which is about, because you can have errors of that related to assay, but this is considered quite good. For cystatin, and this is the specific assays, the Genshin and the Roche, the 3 standard deviation was up to 10%, and there's just more variability you can see. But maybe it was okay, and I think for cystatin, this was thought to be quite good. We continue to do these samples, and so you can see what we have. Our latest measurement in 2003, creatinine is still about the same. Or for the cystatin C and the Genshin Roche methodology, I have to put the dashed line here. This is the last one in 2019. Here is where it is. But then it went way down, way back up. And actually, this allowed us to have the conversation with Amy Carter about how to potentially change the methodology from the Genshin on the Roche to the Roche reagents on the Genshin machine. So this is important conversations to have, and sometimes you can only do it in retrospect when you have data like this. Clearly, this is not something done by our clinical laboratories. And so I think you probably all have experiences like I do, where the cystatin just doesn't make sense. And is it that the creatinine's wrong and we just didn't understand it, or is it an assay issue? And to highlight just one more factor with the cystatin assay, sorry, I should have been clearer here, is that there are differences at 8 to 10%. And this is actually a vast improvement from where it was a decade ago. So another reason I think why we need to move beyond cystatin. I put this here because I probably like you all, I just love when I find out information about specific issues with my acute kidney injury, my patient in the hospital where the values don't work. It doesn't make sense, and it could be related to interference with the assay. And I think this is something we in medical school and our training do not think about sufficiently. And highlighted in red a paper from Jesse and his colleagues looking at the interference of dopamine and dobutamine with a certain creatinine assay. And so this is something that we as experts in GFR, when we're rounding and evaluating our patients, we should really be aware of. And when something doesn't make sense, or maybe there's a literature on the interferences with assays. So when we come to creatinine, I think, we've had a lot of conversations about the errors in measured GFR. And I think that those are really important. And I'm going to get to where I think we need to understand them better. When I think for creatinine, I think it might not have as much of an impact on how we develop our equations. And what I'm showing you here is a paper we put out in JSON recently, looking at the comparison of the CKD-EPI equation to the equation from the European Kidney Function Consortium. Convergence. Now, there's differences in how we measure GFR amongst these two collaborations to develop the equations. There's difference in the populations. There's differences in our method by which we develop the equation. But despite that, we have a lot of similarity of the estimates, 98% within the 15% of each other. And accuracy compared to measured GFR was also quite similar. And I think that's because creatinine itself, I'm actually a fan of creatinine. I think it has a lot of potential uses now and into the future, but it has, I think we could do better in certain circumstances. But creatinine itself, we know its limitations. And so that non-GFR impacted creatinine really dominates amongst all of the other errors. So the question is, when we go beyond creatinine and beyond cystatin, what do we need to do with our measured GFR? So this is like the third panel and the figure that we had developed. It says, well, what if we had multiple other markers? Here, the ellipsis for the eGFR is actually converging on the true GFR and bigger than the mGFR, because the idea that using multiple markers converge on the truth, the true GFR. I've drawn here in purple creatinine because our ultimate goal is to have some methods by which we would downweight markers that don't converge with others. So for example, an individual patient, you look at all the markers, creatinine's different, provides a different estimate. Can we not exclude it from the algorithm by which we provide a GFR estimate? And on this call here is one of our PhD statisticians working with Tom Green, Nora Fino, who's developing some methods for this. So this, I think, is extremely exciting. And what Nora also did was work is now in press at KI, where we together we had untargeted metabolomics across 7 studies, about 2,800 participants. And Nora developed models from 36 metabolites that had correlations that were strongly correlated with measured GFR, and it combined them in different ways. So across all of those metabolites, we had about 2,000 models ranging from 1 to 15 metabolites. So here on the x-axis here is the model size. This refers to the number of metabolites within each model. And each of these little, the bar there reflects the number of models. So for example, here would be a model that had 7 metabolites, and there's a range of, there's many, many different models there. And the range of the performance compared to measured GFR, as defined by the root mean square error, ranges from 0.18 to about 0.195. And here, by the way, is the model using just creatinine age and sex. So it's a much higher RMC. And what we then did is we selected metabolites across models with 5 to 10 metabolites and with low demographic coefficients. We don't want to have any changes by demographics. And we picked models with 5 to 10 number of metabolites to maximize the performance, maximize the root mean square error, and limit over optimism. And we from those, using that algorithm, we identified 17 metabolites, which are presented in this paper. With Jesse's help and University of Minnesota, we are doing final validation studies for these metabolites. And the final method is being derived to multiplex all selected biomarkers in a single mass spec assay injection. And I was really happy to see the description of the difficult nature of this standardization process presented earlier, because this has been a long process, but we are making progress. But this box here, I think, is the critical part. So why couldn't we get lower? Is it not because we don't have the right metabolites? Or is that there's error? Is it error due to all of those imprecision errors in measured GFR? Is it related to the bias of the different error? Or is it difference between true GFR? So it's possible we can't get lower than this, given that we can't measure true GFR and we can't just measure, and we're only measuring the GFR the clearance that we can measure. So where do we go with key clinical and scientific gaps? So I think ultimately our goal is to have an accurate, reliable assessment of true GFR that is easy, inexpensive with fast turnaround. I think this is probably never going to happen. Could we at least have an accurate, precise, reliable assessment of true GFR? Maybe. Or can we at least have an accurate, precise, reliable assessment of measured GFR? And I think we're still working on that here today. And I'm excited to see some of the new advances that we're going to hear at the end of the day, which might help us with this too. So why do we have to do this? Now, I could have probably talked for a long time on what are potential studies and what kind of measured GFR do we need to think about. So let's just give me a few examples, and hopefully we'll have the opportunity to talk more about this tomorrow. So if we're doing physiological studies, extremely important to have standardized environment and consideration of the time of the day. And this is, I think, for example, one of the things I read about was that if we're translating animal studies into human studies, animal studies actually have a diurnal variation, but it's different from ours. And you have to actually think about that. The example I would read was about phosphate excretion, where you have very limited phosphate excretion over the course of the day, and we might miss it if we don't pay attention to that. So clearly, this is extremely important. Let's go somewhere completely different. Let's think about large clinical research studies. And I wanted to give an example of an RCT that's done, obviously most RCTs are going to be estimated GFR. So we might do a measured GFR. And for example, with all of the new drugs that are affecting our body composition, our current GFR estimates may be limited, and there may be a desire to use a measured GFR. I don't think we could use a very prolonged measure for GFR in a large clinical trial. So we have to do something that could be done. But if one group has more of an acute decline in GFR or a progression in GFR, if we don't think about how we're measuring the GFR, that late plasma sample, if we're doing a plasma sample, we could lead to false errors and potentially systematic differences in the groups leading to a false assessment of treatment. We're thinking about developing of GFR equations. Now, I've spoken to some of these issues already, but the error in eGFR versus MGFR might be related to errors in the measured GFR or to diurnal variation in measured GFR, which might not be present for eGFR. And so we have to consider these issues. I obviously thought a lot about this, and I did put a plug that I think there is a balance for excellent rigorous measured GFR, but I also think there's a balance for extremely wide representation in our development populations due to the primary importance of non-GFR determinants of accuracy of GFR. And even with the panel, I don't know that until I evaluate it. And I think it's really important to have representation in these equations because they're used so broadly. For clinical decisions, varies by decision as well. For example, in deciding on a kidney donor candidate, we certainly look at the level of the GFR, but we also look at whether there's evidence of kidney damage, albuminuria. We look at their other risk factors. We look at their age and whether they've survived to have these risk factors for kidney disease. Unlike if we're doing drug dosing, then we are really using GFR. And I think it's an excellent point we're talking today about the tubular transportation. And hopefully we'll have a more refined version, being able to look at total kidney clearance when we're thinking about drugs. But for right now, we're thinking about GFR. And certainly if you have doing a GFR late in the day versus early in the day, that actually may affect the decisions. So what are some more realistic and immediate goals for GFR? Well, I think we have clear indications when to do measure GFR. And I think in the latest KDIGO guideline, we suggested some, but I think we need more work on that. Excellent start from the EKSC for development of standardized protocols with reliable data and accuracy and how accuracy varies by person characteristics. We need to ensure stable supply chains for filtration markers. It's really not acceptable that we don't have the filtration markers that to use across the population in all countries who want to do measure GFR. And I would suggest that payment systems to encourage more widespread use will also actually help ensure a supply chain. For a realistic and current goals for eGFR, for cystatin, we need to have more clear indications when to use creatinine or cystatin or creatinine basis or the combination. a better understanding of the non-GFR determined cystatin and a better assay for cystatin C. So conclusions, and I know we're running out of time, so I can just be very brief that I think standardized protocols and assays are really an excellent step, and having a system for monitoring the standardization will ensure optimal implementation. True GFR is an important concept, and I think we could think about it more. And for future, I hope we have better methods to assess GFR, new methods using exogenous filtration markers or panel of endogenous filtration markers, I think will help us move forward. Both Jesse and I have a great deal of thanks to all of our investigators, and particularly I always like to thank our collaborators who donated samples and data for us, which allowed us as a community to make a lot of progress in GFR estimation in the past 2 decades. And we are both open for questions.
Thank you,
Thank you.
Jesse.
Go ahead.
Oh, and thank you, Leslie. Also realize that we should not be US centric and acknowledge everybody else signing on in various time zones around the world. I would start off with a question for Jesse. I think this was in the chat. There's a comment about different equations, specifically the JBM equation. But could you talk more broadly? My superficial understanding of this is that often these equations are derived from relatively small sample sizes, and going back to Leslie's point, perhaps not the most representative of the range of body composition and comorbid conditions, which always makes me a little concerned about using them in a wide range of people or patients.
Yeah, that's a great point and a great question. I think, that just kind of highlights some of the limitations in those approaches. There's different, depending on your level of GFR as well too. Dr. Bjorstrand had brought up the Jodial equation that performs better at higher GFR. And so I think some of these models, as you allude to, were developed in, say, maybe a normal population, and with respect to the inulin clearance and things like that. So as you've looked at as people look at more and more different populations, those relationships may change somewhat. I personally am just a user of the equation, so I can't speak to the mathematics behind them and why there's a problem here or there. But I do try to point out the different approaches and what may be the appropriate equation for various studies.
I'll ask the next question for Leslie. Many studies get published highlighting how one particular eGFR outperforms another for some association or predicting some outcome. Would you say the goal is to optimally predict outcomes or to reflect the outcomes that would be associated with true GFR?
May I ask, I'm not sure I understand the question particularly with true GFR, since we don't know what true GFR is. How are you thinking about that?
So you might find 2 different equations that have similar association with measured GFR, similar R, correlation, P 30%, but one better predicts the outcome than the other. And however you would assess that outcome, it may be due to the non-GFR biology of those markers. It might be due to true GFR. So I'm asking more conceptually, and you bring up some good points about how we determine true GFR is challenging, and there's ways we can use measured GFR to try and get a better sense of that, but it still has error. So the question is, sometimes you see papers that'll say this is the best way of estimating GFR because it best predicts an outcome. And others would say, well, is it reflecting the true association with GFR?
Yeah, no, it's a great question. I think this has come up a lot in particular because we have 2 main markers now, creatinine and cystatin C, and cystatin has other things beyond its GFR component that might also be associated with the outcomes. And I think it's actually an important question because those other things, although we don't understand them now, may actually help us understand and prevent outcomes. So I'm hoping to, that's one of the reasons why I think it is important to understand cystatin, because there are other things it's capturing. And it's not our simple inflammatory biomarkers don't seem to be sufficient. So there might be this investigation might lead us to understand other risk factors or mechanistic markers for the development of those outcomes.
So question back to Jesse, building on a comment from Dr. Kevin Abbott here, and also a question, what about use of these iohexol measurements of AKI for acutely ill patients? It seems like you've talked mostly about CKD, and the literature is mostly about CKD. What do you think about the application of AKI where they're not in steady state, so a short measurement might be advantageous?
That's a great point. Just recently, I was involved in a case in my clinic where the provider didn't trust the cystatin C or the creatinine. They were disparate results. I think the creatinine was like around 5, and then the cystatin was about 0.6 or something like that. He wanted to do an iohexol plasma disappearance in clinic, which was very challenging because we don't have that protocol in place in our clinic as a routine type approach. So I think that would go, hand in hand with some protocol development on how to administer, going back to the standardization, paper that's in publication right now. So really the protocols are very important. The laboratory is only one aspect of it. I think the protocols really, as you see, there's a lot more error likely in the protocol than there's going to be at 3% CV in my laboratory for iohexol. So I think that if you can capture that, and really if we can lock those things down in our populations that we want to serve, that's going to be the most important part, I think, of this whole, getting to the bottom of this. And so when we did do that, though, we did see kind of the zebra where the iohexol GFR in that case, where the creatinine was 5, was the iohexol GFR was about 30 some, so the cystatin in that case was wrong, and we're still investigating it. I haven't found any answers to why that was the case, but there is, those unique opportunities, I think, to employ something like this in clinic when things just don't make sense.
I'll ask Leslie another question. You had a beautiful diagram about all the different sources of variability that contribute to eGFR and measured GFR and make it different than true GFR. And it seems like the goal is to try and get that error term as small as possible, and potentially using a panel of biomarkers can help with that. My question is, does it matter what the remaining error is? In other words, if that remaining error is random variability, where repeated measures can reduce it versus it's due to some sort of non-GFR biology that just remains. And how would that affect perhaps how you would use the panel for like a patient care where you're not comparing people, you're just looking at that individual versus an epidemiological study where, you might have some residual associations?
Yeah, it's a great question. I think the non-GFR determinants are important because we can't, if we're developing we had 7 populations, and they were not just our usual. So we had patients with cancer and some liver failure, but it's not going to be everybody. And so if I don't understand all of the factors, then how do we validate it? And is it related to that factor or not? But I think there is going to be a point where we can't quite do better. And we've done some statistical work where we say, okay, if we think the random error at least is 15% in the RMSE, then we can adjust, we can use regression techniques to account for that. And then we say, okay, then we think it's even lower. And then I think we might have to have a practical approach to understand, given all of the factors we're trying to deal with in developing our equations, that we're not going to go lower than that.
Afshin, we're on the 20-minute mark. Would you like us to, there's a number of questions that people.
Yeah, let's do another couple since we have lunch, and we can always just shorten that by a few minutes, but I think there's some good questions still.
And also time zone. centric view of lunch. I would go back to a question for Jesse. So there's a question from Dr. X and Dr. Frosch, which is sort of related, which is about this data on differences in MGFR using sub-Q by body mass, by edema, and sort of systematic delivery, and also a question about whether or not one size fits all is not a good idea, for example, for edematous patients and stuff.
No, that's a great point. And I think that's some of the limitations of the sub-Q approach and the IV plasma disappearance approach that gets invalidated by patients with, severe edema and things of that nature. So, and likely in those cases, you need the alternative of probably a continuous infusion with a certain equilibration time.
I'll ask the final question to Dr. Inker. This is combined from Dr. White and Dr. Starr. So with this biomarker 7+ blood marker panel, is this going to drive up the cost significantly above current EGFR? And analytically, would the coefficient of variation of such a test be such that it'd be hard to really make improvements on the 30% window?
Yeah, cost is really important. We've been really blessed because we have a very cheap analyte, creatinine, that is so easy, and really across the globe we can use it, and have been able to do studies using the same marker because it's inexpensive and so widely available with really good analytical properties. So I think cost is interesting, but it changes over time, and it can only change over time if you develop it, you study it, you make your case scenario, how you can improve benefit. I think so. I guess I could leave it at that, but I think those are important considerations. But I don't think the fear of cost should prevent forward progress, and that's certainly not in any field of medicine. And we should do the same in nephrology. I hear that a lot actually with cystatin, so I'm maybe a little sensitive to it. I think we have to make forward progress, and then there's a lot of costs in medicine, not just in nephrology. The CV is really interesting question. We have I don't know, Jesse, he just sent me the data. Actually, they just finished their analytical variation and analytical studies. Do you remember what it is? This is, so we have by the way, the KI had the results from the global metabolomics, which is raw relative quantification. So our absolute quantification was done in Jesse's lab, and I think he just sent it to me. Do you remember what it is?
You're muted, Jesse.
Sorry, no, but I can look it up.
So you're getting things hot off the press.
Yeah, this is hot off the press type
this
stuff.
This is really hopeful work. So we're not quite there yet. Testing it in different pockets where we think with creatinine is not sufficient, and hope we'll get improvement there. So
yeah, so like interassay CVs, and again, this is all manual type work on a mass spectrometer, not automated. You're going to range anywhere from less than 2% up to 10-12% kind of with some of these markers. Automation and things like that will obviously improve. Moving it to an automated platform that can be run on a clinical analyzer or something like that, that's likely the right pathway for some of these things, rather than running on laboratory developed type systems.
Great. Well, thank you so much for these great talks and questions. We're going to switch over now to a break. It was scheduled for 30 minutes. We'll make it 25 minutes instead. And we see I didn't call it lunch this time, G. So we'll come back. We can be in 25 minutes. We have a few more sessions and a lot of things that actually most of us at least know a little bit less of compared to glomerular and tubular function. So charge selectivity, which has always been there, but not discussed as much. And of course, reserve. And then at the end of that, lightning talks with some new cool technologies that we presented. So with that, you can either just shut off your camera, mute, and then log off, and we'll see you back in 25 minutes. Thanks. Okay, great. We're going to get started. Welcome back, everyone. Glad to have this next session called glomerular charge and size selectivity, something I always wish I knew more about. And I'm now going to turn it over to Denise Marciano and Petter as the moderators to kick this session off for us.
Thank you, Option. So I will start by introducing myself and Dr. Marciano. So I am Peter Bjornstad from University of Colorado, and I'm pretty sure I'm probably the only endocrinologist or pediatric endocrinologist at this workshop. My research focuses on molecular and hemodynamic mechanisms of obesity, diabetic kidney disease, and polycystic kidney disease. And I'm very honored to introduce my co-moderator, Dr. Denise Marciano, who's actually a real nephrologist and a physician scientist at UT Southwestern. Her research focuses on cellular and molecular mechanism of kidney development and regeneration. Dr. Marciano will introduce our two speakers, Drs. Lemley and Bensing.
Thanks. Today, I'm honored to introduce our two exceptional scientists, Dr. Kevin Lemley and Dr. Tomas Bensing. Dr. Lemley is a distinguished physician scientist. He is currently a professor emeritus at the University of Southern California Keck School of Medicine in Los Angeles, California, since his retirement in 2023. He obtained his MD PhD training at Stanford and then has held faculty positions in the Department of Pediatrics at USC and Stanford. He's been at USC since 2005, where he spent a number of years as the Fellowship Program Director of Pediatric Nephrology, and he's also previously been the Vice Chair for Faculty Development in the Department of Pediatrics. His research is primarily focused on glomerular disease, centered mainly on the podocyte. He's a principal author of the Heidelberg hypothesis, which attributes the progression of most glomerular disease to the loss of podocytes. And he's also contributed a great deal of work on the role of mechanical stress in podocyte loss. In recognition of his contributions, he's won several awards, including Distinguished Medical Honoree Award from NEFCure and the Extraordinary Achievement in Advancing the Frontiers of Renal Research from the University Kidney Research Organization. Dr. Tomas Bensing is equally distinguished in the field of medicine and research, currently a professor at the University of Cologne in Germany. He serves as the chairman of the Department of Internal Medicine and is the director of the Center for Molecular Medicine Cologne at the University of Cologne. He also holds the Vice Dean of Finance at the medical faculty. His research is also centered on podocytes. His work he's been recognized for pioneering the concept of signaling at the slit diaphragm of podocytes, as well as for estimating physical forces that drive podocyte detachment in albuminuria. He's also played a crucial role in developing the first experimentally validated model of glomerular ultrafiltration. In recognition of his outstanding contributions, he's received numerous awards, including the Ernst Young Prize in Medicine, the Young Investigator Award at the ASN, and the Volhard Prize from the German Society of Nephrology. And finally, he is an elected member of the German National Academy of Sciences. So please join me in welcoming both speakers. I guess, Dr. Lemley, you are off to start. Thank you.
So tell me if you're seeing the appropriate screen.
We are.
Okay. So I'm trying to be provocative, which starts out with the title. It probably would actually be more appropriate to say what once was forgotten is relevant again. Same idea, trying to predict kidney failure, at least in diabetes, if not more diseases. And it's really a pretty simple story. Tomas is going to get into the complicated parts. And it has a history. And this goes way back to actually the late 80s and 90s. I only was involved starting in the mid 90s. Of the Phoenix Epidemiology and Clinical Research Branch of NIDDK collaborated with the divisions of nephrology at Stanford under the leadership of Brian Myers, my mentor, Cleveland Clinic and Emory, to conduct a long-term study of American Indians living on the Gila River Indian community that aimed at understanding the evolution of type 2 diabetes and its kidney disease in this population. Along with clinical data with things as mundane as glucose tolerance tests every 2 years offered to people in the community from age 5 to research needle biopsies and studies of glomerular hemodynamics and glomerular perm selectivity. These were conducted in hundreds of research subjects over several decades. Because of this and the loyalty to the research team of the subjects, there was very long-term follow-up, which is important to understand development of kidney failure. And that was one of the outcomes of the study I'll describe. The body of research on the Pima Indians has really become a mainstay of our understanding of the development of diabetic nephropathy from a number of regards. So primer for those who haven't seen it, and a reminder for those who saw this years ago. Perm selectivity, and in this case, we're not talking about charge restriction. We're talking only about size restriction. That's what I concentrate on. Where study started in the laboratory of my PhD advisor, Channing Robertson, working with Barry Brenner and others, to look at the urinary clearances of polysaccharide dextrans covering a range of molecular sizes to understand the size-selective permeability of the glomerulus as a way of understanding the causes of proteinuria. As you can see from this paper by Chang, this was from the early 70s on. There's increasing restriction to the passage through the glomerular filter for increasing molecular size, not surprisingly. And an illustration of this is shown in the graph over to the right, which is called a dextran sieving curve. And I don't know if you can see my arrow here, but we normalize this to the urine to plasma concentration of inulin as an unrestricted marker. And it goes from dextrans with Stokes-Einstein radii of about 18 angstrom to from no restriction, forgetting these two different conditions for the rats, down to complete exclusion by about 44. Albumin is around 36 angstrom, but is not a linear molecule, so remember that. So working within the Department of Chemical Engineering with Bill Dean and Channing Robertson, mathematical models were developed that explain this increasing restriction of larger dextrans to permeation based on a population of restrictive pores in the glomerular filter. This was not meant to represent physically the existence of pores in the filter. This was mathematical modeling. And the model that was most often used, although several of them were about equivalent in their ability to explain the sieving curve, is the heteroporous model, in which the majority of pores are small and restrictive, and then there's a much smaller number of pores that are so big that they essentially do not restrict the passage of dextrans or test macromolecules of any size. The amount of filtrate going through this pathway is called the shunt parameter, and this is called the shunt part of the pathway. The model was eventually applied not just to rats, but to dextran clearance studies in humans, including individuals from the Gila River community. So the log normal plus shunt model is a fit model, mathematical model based on hindered glomerular transport that can be characterized in terms of 3 parameters. So that's what it's fit to. And one of the parameters, whoops, that you can see down in the lower right-hand corner shows the majority of the pores, which are small, and follow a log normal distribution. So they have a mean to the radius here. And if you log transform them, you can get the equivalent of a standard deviation for the variance in there. And then you notice way out to the right, this little population that is unrestrictive, and that's the so-called shunt. So reminding you, the heteroporous model is, as developed on uncharged dextrans, is a way of looking at size selectivity and does not reflect charge, although many people believe that some amount of charge selectivity defects are a part of the development of proteinuria in disease. So looking at some fairly old data, I'll have you concentrate on box B because the x-axis there is albumin to creatinine ratio, which it means a lot more to most of us than the fractional clearance of albumin does. So in the boxes, the horizontal dashed lines represent the 25th and 75th percentiles of the shunt size in normal albuminuric subjects. So that's the normal range showing there across in those. The open circles to the left are what is now called moderate albuminuria. We referred to it as microalbuminuria at the time. That's the 30 to 299 range. And the closed triangles are severe albuminuria, which we used to call macro, and that is over 300. So notice in B, in fact, that if you look at all the way up to 2 or maybe even 3,000 albumin to creatinine ratio, there's really, the shunt size is basically normal. So there's no evidence that this lower amount of albuminuria is due to the shunt. But then when you get to the higher levels, there's a very strong relationship between shunt size and albumin to creatinine ratio, albuminuria that is. And this suggests, at least to me, that there are probably at least 2 distinct mechanisms that explain diabetic albuminuria, one relevant at the lower levels, and then another that's shunt dependent that's only at higher levels, so well into the abnormal range. So last year, Pierre Saulnier and colleagues published long-term follow-up of 185 American Indians that were originally studied in Phoenix at the NIDDK branch that included having dextran-sivine studies so that these model parameters could be calculated. Their baseline mean age was 43 years, which is actually a fairly typical age for the beginning of significant diabetic nephropathy in Pima Indians. Median albumin to creatinine ratio was only 41, so they were sitting median-wise in the micro range. Mean GFR was 147, and they were followed for a median of 17 years, so very long follow-up. Because of this duration of follow-up, 67 developed kidney failure or death, which were the outcomes of interest out of 185. So that's considered a good percentage to be able to understand why people have that outcome. Cox proportional hazards analysis, which adjusted for baseline age, sex, blood pressure, hemoglobin A1C, GFR, and albumin to creatinine ratio, showed that for each 1 standard deviation increment in the shunt magnitude, the hazard ratio of developing either kidney failure or death was 1.53, including accounting for death as a competing risk. So this is a pretty strong factor to predict the outcome. And in fact, because of the Cox corrections, the shunt magnitude is predictive of failure independent of its effects on albuminuria. So if you look at it in a slightly different way, rather than in terms of hazard ratios, break the shunt magnitudes into tertiles, then the lowest tertile had about an 18% risk of kidney failure or death over follow-up, middle one 37, and the highest tertile 53, so quite a spread there. So what are the practical implications of this study that was, I would say, only possible with a population that had been studied this intensively and followed this long? The dextran clearances were performed before most of the subjects had developed either severe albuminuria or abnormal GFRs. So this was early in the course. If one could distinguish on the basis of the shunt magnitude, since it seems to predict the risk of outcome, subjects either at high or low risk over the next 17 years of developing kidney failure, then they might have been more targeted in terms of their caregiver for treatment intensity or follow-up for the higher risk and less intense for the lower risk. On the other hand, this theoretical advantage would hardly justify for most people conducting very technically demanding urinary dextran clearance studies on all patients with type 2 diabetes mellitus, even though it is a very good predictor of outcome not enough so that people would probably want to do this outside of a research setting. So he says provocatively, if only there were a less involved and invasive way to get similar information. I will say as an aside that going outside of diabetic nephropathy, in the Neptune study, in response to treatment, John Trost and his colleagues found that if you reduce the protein to creatinine ratio to less than 1.5, which is nobody's idea of a complete remission, that was essentially as protective against kidney failure as complete remission. And interestingly, that value is just about where the ACR is when the shunt magnitude tends to take off in the diabetic Pima Indians, which suggests that if there are multiple mechanisms and more than just diabetes, then maybe there's only one mechanism out of them that you actually need to effectively treat. So we're going to take a deviation just because I'm turning from a nephrologist into a historian and try to find that hidden way of doing this easier. So in the 1960s, steroid therapy, first described by my teacher, John Lucier, and Elizabeth Farnsworth, had changed the landscape of outcomes in nephrotic syndrome. And anybody who wants to do some nice history, go back and look at like what used to happen to kids and adults with nephrotic syndrome before we had effective treatments. It was not pretty. So many people responded well, but it didn't work for everybody. And a number of investigators, I think stimulated largely by Pappenheimer's work in basic physiology, giving some reason we should pay attention to that, found a very surprising relationship between the relative glomerular perm selectivity to various endogenous proteins and the responsiveness to steroid therapy, and indeed even the kidney pathology when biopsies were done. So in this case, perm selectivity wasn't in terms of dextran-sieving curves. It was a selectivity of proteinuria of endogenous proteins defined from the urine, serum, or plasma to protein ratios for protein molecules of various sizes, for a range of sizes. And the relative urine to serum protein ratios of these endogenous things were compared in general to transferrin. So there was a normalization. So if transferrin is considered 100, it was how their UP ratio varied in comparison to that. So here is an example of a selectivity curve shown off to the right, and it shows two patterns of protein selectivity. And you'll notice that both the Y and the X axis are on a logarithmic scale. So that's something that you need to pay attention to. And done again, relative to transferrin being 100% on this scale. So the line B has a greater slope, it is steeper, which represents higher protein selectivity and therefore a lower protein clearance for such high molecular weight proteins as gamma globulin. So you can see the two X's that are sitting over gamma globulin for the highly selective curve are down around 10% or so of the transferrin clearance, whereas the ones for the less selective that make up the less selective curve are between 80 and 100% of transferrin. So there's a pretty big difference. So of 48 nephrotic patients that Joachim and colleagues studied that were mostly nephrotic, not all, 58-degree angle from the horizontal on this type of a scale log-log was the mean, and high selectivity was considered anything greater than 67 and low was anything under 54. And what they found was that the higher selectivity was associated with a better response to oral steroids. And in fact, from the earliest of these studies, that if you repeated a urine blood test in the same patient, they tended to give the same amount of selectivity over time. So it seemed to be a stable characteristic of these patients' proteinuria. So here are more examples. The left one by Stuart Cameron and colleagues showing one thing best in this, that you can see on this log-log scale that it's pretty tight fit to a linear fit on log-log, that this is not a cloud here. The oldest study, interestingly, they did biopsies on 21 patients, and so they could break them down into minimal change, membranous, and proliferative. And if you look at this selectivity scale, that basically the steepest of them was the minimal change, which of course tends to be responsive to steroids. Proliferative is in the middle, and membranous had the lowest slope and therefore the worst outcomes. Broken up another way in a study of about 20 kids by lines. You can see if you even just look at the left, there's an absolute distinction if you do the selectivity angle, where if it's 50 degrees or under, the children are non-responsive to corticosteroids, and it was over that they're responsive. So that we don't have very many predictive tests for steroids responsiveness that work quite that well, not even a biopsy. So looping back around again, what is the relationship between our shunt magnitude, which is what we've shown in type 2 diabetes, is a good predictor of long-term kidney failure outcome, and this kind of older, forgotten, never disproved, never said to be irrelevant, just forgotten, protein selectivity. So as the selectivity angle decreases, so there's lower selectivity, there's relatively more of larger proteins that pass through the glomerular barrier. And this is what you might expect if they were going through a shunt with a greater magnitude. I suspect, in fact, there may be an inverse relationship between the selectivity angle done from endogenous proteins and the shunt magnitude. And if this relationship is strong enough, it may give us our easier way to estimate shunt magnitude and therefore the risk of future kidney failure than is offered by dextrans sieving studies, which, although good predictors, are not something very easy to do. So the relationship between the shunt magnitude and selectivity angle alone, although not the predictive power of the selectivity, could be tested by measuring concentrations from urine and plasma proteins of various molecular weights, maybe by multiplex ELISA, from stored specimens from the Gila River subjects, or if anybody happened to be doing ongoing dextrans sieving studies now, you could do them simultaneously with as few as 4 proteins of a spread of molecular size seems to be good. So what is getting very speculative now, because this was meant to be a provocative talk, which maybe you've noticed, I hope anyway. What's the shunt magnitude physically or biologically, and why does it matter? Why does its magnitude matter in terms of predicting kidney failure? So you remember that old study from 2000 where there's no change up to about 2,000 albumin to creatinine ratio in the shunt magnitude, and then it just takes off and seems to explain all of the albuminuria after that. So I interpreted that as a 2-mechanism interpretation for the shunt magnitude versus ACR curve. My simple model is that the higher level permeation of larger proteins or test macromolecules through the glomerular barrier is restricted primarily by podocytes, the processes, and the filtration slit. Lower levels of albuminuria may be due to defects at the level of the endothelium, for example, or other things, but certainly it doesn't look like anything to do with a shunt, which we think of as a good way of characterizing size selectivity. That seems to only talk about the higher ones. I suspect that foot processes or parts of them periodically pull in their nephrin and other slit diaphragm proteins, detach themselves from the GBM briefly, possibly as a part of keeping the filter clean, before then reestablishing their connection to neighboring foot processes. And this can probably happen relatively fast and probably happens all the time. It's why we have a finite shunt magnitude even in subjects without kidney disease, that it's a normal part of keeping up the foot process architecture, if you will. In this model, the areas of the transient and partial detachment are the shunts through which large proteins escape into the glomerular filtrate. And I hypothesize that with relative podocyte insufficiency in the Wiggins sense, meaning either low number of podocytes or high filtration surface to cover with an inadequate number of podocytes, the frequency of these detachment episodes increases the size of the shunt, so that in fact, the shunt magnitude may be a functional measure of podocyte loss, which would be a good reason for it to predict eventual kidney failure. So what are the next steps that this speculative way of seeing things suggests we should look into? Well, even though Peter and I probably have to agree that the Solier study is very good, it's big, carefully done, and long follow-up. It's going to be hard to match it, but I don't think there'd be any reason not to try to match it because it has pretty strong implications. And also to see, can we, by looking at some index of endogenous protein selectivity, find a way to get the same information that's hidden inside the shunt magnitude developed from dextransiving. Does the same approach apply to things other than diabetic nephropathy, like IgA nephropathy or FSGS? And then finally, if you could say there's a change in the shunt magnitude or whatever its easy to do analog is, will this tell you whether or not therapy is going to be effective in preventing kidney failure? And that's where I will leave it.
Thank you. We'll move on to the next speaker, Dr. Bensing, and we'll do questions at the end.
So Kevin, thanks very much for your beautiful presentation. I love it. I try to match it with some of the recent experimental data. And I wanted to present to you an experimentally proven models that we recently generated regarding the question, how does the kidney filtration work on a mechanistic level? And this may shed some light on what factors contribute to the development of albuminuria. So let's first start again very briefly. So everybody knows the filter consists of 3 layers: the endothelium, the glomerular basement membrane, and these podocytes. The podocytes are very, very special cells. These cells have primary processes, secondary processes, and these cells cannot self-renew, at least not sufficiently. And that's a problem. So people have to live with their podocytes for the entire life of the organism, and the podocytes have to maintain a stable proteome and metabolome over this entire period. So these podocytes are connected by a specialized cell junction, as you know, the slit diaphragm. And we've been working for more than 2 decades now on the function of podocytes and the role of slit diaphragm signaling in keeping a healthy kidney filtration barrier. And the question has been studied in many groups over decades. So how does the kidney filter work? Is it in the GBM? Is it in the slits? What's the role of the endothelium? And the problem was not solved. And we recently could provide an experimentally proven model of glomerular filtration that I will share. And then we will go in some experimental or some details of the results that may shed light on Kevin's beautiful presentation. So the starting point to generate such a model was to develop an animal model which displays basically human disease. So far, all the available animal models with podocyte that affect podocytes in all these animal models. These animals are born basically with a congenital proteinuria. So disease occurs very early, and this basically prevented everybody from studying what happens prior to the development of albuminuria. And we used CRISPR-Cas technologies to mimic a human disease, a late onset disease, a mutation in a protein called podocin, NPHS2 gene, that when children are born with this mutation, they are healthy, they develop albuminuria later in life, late childhood, basically adolescence. And we introduced the same point mutations, just one single base pair change in one allele and another base pair change in another allele in mice, without leaving a scar, without doing a knockout, without doing anything. And these mice now develop a disease very, very identical to the human. So they have no albuminuria, not in the beginning, and they develop disease in adolescence. Okay, and that allowed us to study what happens on a ultramorphological level prior to the development of albuminuria. We used novel imaging technologies to do that at high resolution. This is ultra-resolution stat microscopy and other techniques. And here you can see, for example, a representation of the filtration slit, and stained are here the proteins nephrin, so the extracellular domain of nephrin in red, and in green podocin, and you can appreciate the high resolution. Okay, what happens before the development of albuminuria? So before the development of albuminuria, the slit diaphragm gets shorter and shorter. So the filtration slit gets shorter, and it was extremely surprising to see in the very, very early stage, even in healthy animals, the amount of albumin leakage is a negative linearly correlated to ACR. So slit diaphragm length is inversely correlated to ACR, which was very surprising. This suggested that in the early course of albuminuria may occur through intact slit diaphragms, yet shortened filtration slits. That was very surprising. And we did then massive image collections, and with using machine learning algorithms and computational power, and teamed up with mathematicians and bioengineers to develop the first experimentally validated model of glomerular ultrafiltration. And a model turned out to be true that was suggested many years ago, that I will briefly present to you. And this is basically the work of Linus Butt and David Unachoy, yes, two postdocs in my laboratory. So what we could show and then experimentally prove is that in the normal situation, the enormous blood pressure here in red in glomerular capillaries there is a buttress force by podocytes here in green with the green arrows, and the buttressing force together with the blood pressure compresses the glomerular basement membrane. And the glomerular basement membrane is basically like a gel, and the compressed gel is in a compressed gel, the diffusion of albumin molecules and of bigger molecules is prevented. So in a normal situation, the perm selective filter is based on the fact that the glomerular basement membrane is compressed through the forces of the GBM, and the forces that can be generated are correlated with the length of the filtration slit, the length of the slit diaphragm. In disease, there is podocyte injury, and podocytes cannot counteract the forces as much, and this leads to a slight decompression of compression of the GBM, and increased basically an increased diffusion of proteins, and that explains albuminuria. So fourth generation, and that's important to remember, is dependent on the structure of the podocytes and the length of the slit diaphragm, and podocytes provide the buttressing force to compress the GBM. And now all of a sudden it's clear why there was this debate. Is it in the GBM or is it in the slit? Marilyn Farquhar in the 60s and already showed that injecting ferritin molecules in rats, these injected ferritin molecules would not cross the GBM. Yeah, because the GBM is compressed and the diffusion of these molecules, or the penetration of these molecules, is prevented. Whereas in a disease situation where the podocytes are injured, the molecules can cross the GBM. Okay, that's the model. But let's look deeper into the experimental data, and then we can probably shed some light on what Kevin very nicely presented. When we looked into this, and this is now a linear representation, not an exponential or not on a logarithmic scale, we see that there's an initial phase of albuminuria development, what you can see here. And at this first phase, there's a clear negative, and I don't have all, due to time limitations, I will not show all the data. At first, there is a clear negative linear correlation between the length of the slit diaphragm and albumin-creatinine ratio. And this is explained by the decompressing of the GBM. But then there is a second phase, and maybe this is the inflection point. This is Kevin's inflection point here for bad outcome. Then there is a second phase where the albuminuria in this model goes off. And we've been working on this now for the last several years. So initially there is a shortening of the slit diaphragm, and therefore a decompression of the GBM, and this leads to this albuminuria. In Kevin's terms, I would call it the not shunt dependent proteinuria. This is the early phase. And then in the second phase, what happens in the second phase? And we found that in the second phase, this might be due to, as Kevin suggested, a detachment, which can be irreversible or reversible, of podocytes. And I will briefly explain what we believe that happens. So GFR goes down, but GFR is maintained, is almost maintained over quite some time, but the slit diaphragm length is massively decreased. So the filtration is maintained over a massively shortened filtration slit, and that here, what you can see here, and that leads to a massive increase of forces exerted, stress exerted by a filtration, and a massive increase in filtration over a shorter filtration slit. And we could actually calculate and estimate the forces, and the forces are massive. And the data derived from this in vivo measurements from the in vivo models suggest that these shear forces can contribute to reversible or irreversible loss of podocyte attachment to the GBM. That would raise the hypothesis that over time podocytes get lost through shear forces, and that would imply that at this particular stage of the disease, we first see podocyte loss. So do we first see podocyte loss from 2 to 4 weeks in these animals? And in fact, this is what we see. When you go from 2 to 4 weeks, we see a 15% reduction in podocyte number in this model. So this is the starting loss of podocytes, and explains some of the bad outcome. So Kevin's second phase seems to be driven by the loss of podocytes, and this determines a bad outcome. And it also may explain that this proteinuria is now a shunt dependent proteinuria, and maybe also an unselective proteinuria. And it's very clear, because the podocytes cannot self-renew, this is the starting point of really bad outcome. And it also implies that these patients have to be treated with agents that decrease the intraglomerular pressure. Now, in my view, the future steps should be to really show that the shunt magnitude is a measure of podocyte loss. I have a question: how can podocyte depletion shunt magnitude best be measured? That would be important for us, and it's really crucial to highlight that the glomerular filtration rate and we measured glomerular filtration in these mice by using FITS labeled sinistrin measurements, sinistrin clearing, and that the GFR is maintained while the slit length is massively decreased, and that exerts some stress, and probably the GFR underestimates the extent of damage, at least in this model. So with that, I'm done, and thank you very much for your attention. I hope it makes sense for you, and I'm very happy to discuss.
Thank you so much for 2 fantastic talks. I will start with some questions for Dr. Lemley, and then after that, Dr. Marciano will ask some questions for Dr. Benzig based on what's been in the Zoom chat. Dr. Lemley, there's been several questions regarding the assumptions of the modeling based on dextran and fical sieving. One of the questions, and I can do these in order, relate to the data you show that the shunt sizes in different patients was calculated based on the assumption that the normal pores were the same size between all patients. Would it be possible to model so that the non-shunt pores are different in size to account for the difference in perm selectivity?
In the heteroporous model, there is a place for the restrictive pores to have different radii. Again, so you're fitting to all 3 of those things. So shunt is one thing, and there's even Bengt has said that he thinks it's not even fully unrestrictive, it's just really very little restrictive. So there's lots of little things one can do, but it is built into both the isoporous and heteroporous that the pores have a distribution of sizes. And so that could theoretically change, you know, depending upon what you think those may represent in the barrier function in terms of the GBM or the Karnofsky grid or whatever. You know, you can make arguments about whether they should or should not change, but it is built in that they can be fit differently depending upon what your sieving curve looks like.
And what about
that answered the question?
Yeah, thank you. That was great. And what about selective reabsorption of proteins by the tubules? You know, how could they affect the calculation of the shunt magnitude?
Sounds like that's Andrew's question. It's, you know, in terms of proteins, the nice thing is if you're going to look at the selectivity angle, it works, right? So yeah, we all hypothesize that a lot of the albumin that normally gets across into the proximal tubule does not make it into the urine, that under normal circumstances, and unless you're a Wayne Comper fan, you know, 90% is of the filtered albumin is reabsorbed before you're going to get to it in the urine. So there is a certain amount, depending upon whether you have dense disease or not, of protein that is not making it into the urine. And yet, if you look at the UP ratio, and you saw again how well on a log-log scale that fits to a linear fit. It, practically speaking, and as a retired person, I'm very practical now, it works. And so there's lots of things that kind of seem like they could be problems, but they don't end up in practice being great problems.
Thank you. That's great. One last question regarding the assumption. What about the ultrafiltration coefficient? You know, if I recall, I believe they're assumed to be constant in these models, but we know in biology they're probably not constant and change quite frequently.
Well, it depends to what degree. Again, you're talking now about convective versus other forms of transport across, which is not like pore base necessarily, but the flow rate, and Thomas has used some of these parameters in his model. There is an influence on proteinuria just from the localized ultrafiltration of fluid across the capillary wall. And so that is another factor that goes in that is not per se modeled in the simplified, I'll put it that way, heteroporous model.
Thanks, Dr. Lemon. That's great. One last question before I hand it over to Dr. Marciano. What about the shrunken pore syndrome? There were a couple of questions regarding that. Are you aware of any physiological or ultrastructural studies that support this hypothesis?
I'm sorry, I did not pick which syndrome.
Shrunken pore syndrome.
Shrunken pore syndrome, I'm not familiar enough with to be able to make any useful contribution.
Okay, fair enough. Thank you.
Okay, some questions now for Tomas. This is from Owen Richfield. He asks you to explain your own investigation on the relationship between slit diaphragm length and the ability of podocytes to generate force to compress the GBM. Is this change generated by a change in the cytoskeletal structure of the podocytes, or is it the loss of slit diaphragm that alters the ability to generate constrictive forces?
It's a very important question, and we've also been working on this, and maybe I can share one slide with you. Is that possible? Can I share a slide with you?
Yes.
So there has been the thought, and this is now also Willem's and Kevin's very, very beautiful work, but there has been the thought that there is no predominant direction of podocyte processes, and Kevin once suggested that there may be, and then the data didn't show it. And of course, with force generation, we were very much interested in this. And this is technically extremely demanding and was recently solved by David Unacher in my lab. He's actually from Sweden, and he explains how this imaging works to the Prince Daniel in Stockholm. There is one thought starting with this: the forces generated by pressure in a tube is transmitted into stress, and this stress is not identical in the axial and in the circumferential. The circumferential stress is double the size of the axial stress, and you can easily calculate this. This is why a Coke bursts always in the longitudinal direction. And so the question is there a preferential direction to increase generational forces? So are podocytes preferentially aligned? And that is very difficult. So what we did is we wrote computer programs to deconvolute the capillaries, and then the axis of the processes were put as a vector, and then the vector was calculated, the resulting vector. And I can tell you, yes, there is a preferential orientation. And this is not something you can do with electron microscopy. This is really, you need computers. So there is a preferential direction. And this is the favored direction of the slit. And this is the less favored direction of the slit. And that may explain why a podocyte needs a preferential orientation of a slit. And when the slit and a long slit diaphragm to generate this optimized force. And we believe that cytoskeletal changes result in the shortening of the slit when podocytes are damaged. This decreases the ability to generate force, and this decompresses the GBM in the early stage, in the very early stage of albuminuria development.
Okay, great. There's another question by Anna Reznichenko, who wonders, what is the relationship between the glomeruli number, the nephron number per kidney? Larger glomeruli would have a different surface area to volume ratio versus the cortical ones. And what are the implications there for the slit diaphragm length and the other parameters?
We just don't know it. This is now possible to study because we and others have developed tools for automated image segmentation based on AI technologies, because you can't do that with hand picking and drawing and measuring. And now we are going into this to try and understand whether this influences the chance to develop disease or not.
Do we have time for one more, or are we out of time?
Yeah, I think we're out of time. So
We can do that in break.
these are truly fascinating talks. I could listen to it without exaggeration for several hours, but we do need to move on. But I'm certainly think from my plan to read more about this, I'm definitely going to read more about it. Anyways, moving along now, we're going to move to another session before a short break. This one is going to be regarding measuring glomerular capacity and renal reserve. Another very interesting topic that has not necessarily got as much attention as I feel it deserves. And now I'm going to turn it over to Sus and Ragnar Paulson to moderate this session.
Great, thank you very much. I hope you can hear me. So this next session will be a little bit shorter than the others. There will be one presenter who I'll introduce in a moment. So my name is Ragnar Paulson. I'm a nephrologist at the University of Iceland and at the National University Hospital here in Reykjavik. I also work part-time at Massachusetts General Hospital in Boston as a transplant nephrologist. Don't plan to waste any time on my own introduction, but I would like to give Sus a moment to introduce himself also.
Thanks, Ragnar. My name is Sus Waikar. I'm a professor of medicine at the Boston University Chobani and ABDC and School of Medicine and chief of nephrology at Boston Medical Center. My research is focused on kidney biomarkers and diagnostic testing in AKI and CKD, and today's sessions have been really fascinating. Our next talk will continue to work out some of the themes that we heard during the morning session related to assessment of kidney function beyond just static GFR. And I'll have Ragnar to introduce our speaker.
All right, yes, thank you. It's my pleasure to introduce the next speaker, who is Dr. Dana Fuhrman. Dr. Fuhrman is an associate professor at the University of Pittsburgh in the Department of Critical Care Medicine and Pediatrics. She is trained not only as a pediatric nephrologist, but also as a critical care physician, combination that's not that common in the US, but is actually more common in some countries in Europe. So she works also at the Children's Hospital of Pittsburgh as both a pediatric nephrologist and a critical care physician. Her research focuses on renal reserve and urine biomarkers for detection and prevention of early acute kidney injury. She's active in this field and has a K23 grant from the NIH, and I believe she'll be presenting some of her data today. So we look forward to your talk. Dr. Furman, you can take over from here.
Wonderful. Thank you so much. Can everyone see my screen? Great. Well, thank you for the kind introduction, and really just honored to be here. I'm looking through the list of people listening and just in awe of how many of your papers I've read and kind of grown up on. So really incredible talks this morning. Yes, I am a proud recipient of a K23 from the NIDDK, which I credit with so much of the time I've had for my academic growth and some of what I'm going to share with you today. I disclose that I am a pediatric, as I call, nephrensivist, nephrologist first before I did my critical care fellowship. But this will be applicable to those of you who take care or think about adults and children in your work. So really my goals for the next 15-20 minutes is to hopefully bring an understanding of this concept of glomerular reserve capacity. You'll hear me interchangeably say renal functional reserve, glomerular reserve throughout the talk. Hope that people leave today being familiar with different approaches to quantifying glomerular reserve capacity and thinking about it from a clinical perspective. Importantly, we're going to talk about the clinical relevance of objective measures to capture glomerular capacity and reserve, which is really what led me into choosing to do the dual training, wanting to be able to think about this early in my patient's care. So I think not uncommonly in taking care of patients when you're at the bedside, we frequently might see patient A, for example, that patient that undergoes, unfortunately, a cardiac arrest. They come into the ICU and they have a normal serum creatinine, a normal blood pressure, and no proteinuria. And that patient gets exposed to, as we do, nephrotoxins. They may unfortunately suffer another cardiac arrest. They may be exposed to contrast agents in terms of imaging throughout their stay and things that could cause hits to the kidneys. But then they emerge victoriously. They have a normal creatinine still when we measure it at the bedside, a normal blood pressure, and no proteinuria. Unfortunately, maybe more commonly, we might see patient B who maybe comes in with a pneumonia, maybe not as sick as our patient A on arrival, with the normal values that we frequently measure in our patients at bedside. And this patient gets some vancomycin, as I say here in Pittsburgh Children's, and maybe your hospitals too. I think people worry a lot about vancomycin-apnea when you come into the ICU and they get that medication pretty readily, and they may end up with AKI. And what is it about that patient that maybe seemingly had a less of a hit, if you will, compared to patient A, that they ended up having a rapid rise in their serum creatinine? And so as a nephrologist, we might get consulted on patient B, and we frequently might write in our notes that Mr. Jones has acute kidney injury. The etiology, we use the term multifactorial quite a bit in nephrology, as I'm sure all of you do, as a result of sepsis and nephrotoxin exposure. And then we may say that he may have decreased renal functional reserve, but do we have a way to really measure this at the bedside, or to even think about this and quantify this? As we've heard, and what a great setup for the morning talks in terms of thinking about GFR and the changes that can occur with GFR due to changes in the time of day and diet and things. What do we mean by renal capacity or kidney capacity or glomerular reserve? Again, we talked about how GFR is not static, but rather a very dynamic process. And this concept of renal functional reserve is not new. In 1932, H.W. Smith and colleagues observed a 100% increase in GFR in dogs fed a raw meat meal. And investigators have found that black bears reduce their GFR by 70% when they hibernate, and harbor seals increase their GFR by threefold after a fish meal. So a lot out there in terms of what our animals do with their kidney function. GFR is less dynamic in humans, but does display a variability in response to physiologic and pathologic stimuli. Those this morning have eloquently discussed, different determinants of GFR, pathologic or physiological demand. Certainly we know medications can do this, as we've heard about today. I'm going to get into some more on diet, disease processes, and certainly nephron mass can play a role in the changes that we see in GFR. So the idea is kidneys have a functional reserve. We know that we talked about serum creatinine and how we love it and how we have to be careful, though, to treat creatinine amongst the ways that creatinine or accept the things that creatinine can and cannot do. Dysfunction, when defined as an alteration in glomerular filtration, only becomes evident really when more than 50% of our kidney mass is compromised. And so the idea here, looking at that blue line, your changes in serum creatinine, you won't see until you lose a proportion or a good proportion of your functioning nephron mass. That idea that your baseline GFR may stay stable. However, at the same time, thinking about this idea of a stress GFR, which is really important in this concept of renal functional reserve, that difference between your stress and your baseline GFR is what defines that idea of a renal functional reserve. And what does that mean? Up until very recently, despite actually in hearing these talks, I brought out the big folder of papers that I had copied over my years of training and beyond on renal functional reserve. And it wasn't until very recently that we have investigations looking at how renal functional reserve can predict outcomes like acute kidney injury and CKD. These investigators conceptually show here that over time, renal functional reserve may remain stable or intact. And when you think about episodes of acute kidney injury, or what they term here as kidney attack, you can develop a deficient renal functional reserve. And the idea being multiple events might be additive. And you worry, of course, and what we worry about is partial recovery. And how can we prevent that is at the core of certainly what we do. So importantly, how can we quantify glomerular reserve? And that's going to be the focus of the final part of the talk here. When you read the literature on glomerular reserve or renal functional reserve, investigators talk about using a dietary protein. There's been studies using a meat protein load, non-meat-based protein loads, and differences that might be found around there. Amino acid infusions have been used. And getting into the physiology that's occurring here is absolutely fascinating. And for the sake of time, I'm going to have to keep this limited, but excited to talk about this more potentially in the session tomorrow. The idea that's pretty consistent among studies that have investigated this in the lab or with animals is this resetting of tubular glomerular feedback, and how consistent studies have shown this increase in renal plasma blood flow as a result, and then an increase in GFR. Also consistently, we see different investigators have looked at humoral or vasoactive mediators in this process, and it's pretty obvious that this isn't one mechanism. This is likely a multifactorial effect that's going on that contributes to this change that is seen after a stimulus such as a protein load. So different methods have been used for quantifying renal functional reserve, and we'll get into this a bit in terms of stimulating that GFR at the clinical research level. Investigators have used dopamine, as I mentioned, amino acids, oral and meat protein loads. I'll say in my residency at training and beyond, working with my mentor, Dr. Schwartz, we used iohexol to quantify, looking at using a meat versus a animal-based protein versus a more protein shake. And we actually found a more robust change with the meat protein load, which may not be surprising, and have some ideas around that. Importantly, how you quantify GFR before and after a protein load varies based on studies. And you can see the different methods that have been used here, with the most common method being using a creatinine clearance. And that's what I'm using now in the current study we're doing here in Pittsburgh, looking at arresting GFR, providing a subject with a meat protein load, and then quite simply looking at a stress GFR. And right now I am quantifying this in a patient population that I think is pretty vulnerable from a kidney standpoint. These are young adults with congenital heart disease, which is a very growing group that we treat here actually at our children's hospital. Patients up to their 80s actually come here to our children's hospital for this. Importantly, I'm looking at young adults, which we're capping at age 40, and we're bringing patients in before they're exposed to cardiopulmonary bypass. And we basically put them through a creatinine clearance method. We are very careful, and we had to, again, happy to get in more of this offline, how we give fluids to the patient and really trying to standardize this method. And happy to report with some control subjects, and through the subjects we brought in so far. I think important in anyone who's doing clinical research, you need to make the study obviously doable and practical. I bring in subjects the day before their bypass surgery, when they have their pre-op visit with the surgeon. Importantly, I provide a hamburger not only to the subject, but also to the surgeon, which has really helped with my recruitment. I get their preoperative labs during the visit, which has also helped make the patient's life easier. And then the patient gets an honorarium. But as you can see here, it's a 6.5-hour study. So we can talk a bit more about how practically in your clinical life, how this might be extrapolated in terms of bringing patients in, and really have to make that study feasible. And I think importantly, not just looking at a creatinine clearance method for quantifying GFR or quantifying renal functional reserve. I do want to mention there are other methods out there before I show you some details on what we're finding in our study. This is a really interesting study, really recently published, looking at renal functional response in terms of birth weight and kidney volume. So as a pediatrician, certainly we are encountered a lot with babies that are born prematurely. And these investigators looked at men, 57 men and 48 men, either born with low birth weight or normal birth weight, and looked at them as they had aged. And they looked at renal functional reserve using a protein powder and iohexol before and after the protein powder. And interestingly, they quantified kidney volume from MRI images. And strikingly, they found that as your kidney volume, increased kidney volume was certainly correlated with renal functional reserve. And then similarly, they found a decrease in renal functional reserve with this alteration in your what they termed as a kidney utilization ratio, using this really interesting formula on MRI. So this also, may be a framework for a future way to study this more efficiently in our patients. Similarly, investigators have looked at using something called an interparenchymal renal resistive index variation. Interesting studies using the idea of an external compression. A lot of investigators have used a IV bag on the patient's abdomen, causing an increase in intra-abdominal pressure and a decrease in renal perfusion, and then resulting afferent vasodilation, and calculating the renal resistive index as you see here, and looking at predetermined renal vessels and get a mean value, and then basically quantify the difference before and after that compression. So, certainly could be much more efficient and faster than the use of a meat protein or any kind of oral protein load. And the investigators have published some data on this, and did find a correlation of this method with the protein loading test for quantifying renal functional reserve. They looked at it in 31 cardiac patients, and as you see here, it was correlated. And certainly further investigations, I think, are warranted in this area in ways that we could think about this for our patients. And really big picture, how might knowledge of this help us in guiding clinical practice? We certainly have patient groups that come in that are at high risk for kidney insult. I've heard some investigator friends comment that in cardiopulmonary bypass, we're we're scheduling their acute kidney injury. We know it's coming. Radio contrast administration, certainly before maybe chemotherapy, transplant, in particular, a kidney transplant cohort, and then also looking at level of recovery after an episode of AKI. And I think none of us would argue that prevention is key in all of this. And then helping us when we're making decisions at the bedside about these important decisions, when to consult nephrology, when to think about targeted therapeutic interventions. Importantly, as we get more therapeutic interventions in the world of acute kidney injury, this can be very helpful. And so this idea and this concept that I got really excited about in my K is kidney fitness. So looking at patients, not once they're in the hospital already exposed to things, but at a time of wellness before their surgery. How can we risk stratify these patients? How can we look at those patients that maybe, for example, have an eGFR or a measured GFR of 75? That patient who has good renal reserve, in theory, we would expect to do better likely than the individual who doesn't. And as I mentioned, we're honored Dr. Hussain Saeed is actually here listening today. And this is his study that, along with his colleagues, they looked at individuals before cardiac surgery, adult patients before bypass, and found patients with preoperative renal functional reserve. They used the meat protein load and creatinine clearance, as I'm doing with my current study. And they found patients with a preoperative renal functional reserve less than 15 were about 12 times more likely to develop AKI. So showing an association with this. No patients with a renal functional reserve, or all patients with a renal functional reserve less than 10 got AKI. And then all patients with a renal functional reserve over 40 did not get AKI. And so really interesting, striking results, and certainly motivated me in my research. So in looking at these young adults with congenital heart disease, importantly, I brought in healthy young adults. I had no trouble recruiting young college-age students to come in and eat a hamburger and pay them a nice honorarium. And so what we found in those young adults without congenital heart disease, which I compared to the cohort that we had brought in the first 25 subjects with, and did find a difference in glomerular or renal functional reserve in these individuals, being certainly higher in those individuals without congenital heart disease. And then in terms of the cohort that we're looking at before bypass, our CT surgeon said, cool study, happy to have you use our patients, but they're not getting acute kidney injury. And unfortunately for the patients, kind of fortunately for my study, they are getting AKI, 30% to be exact. This data is not yet published because I'm happy to report in the last 2 weeks, we've enrolled 6 more patients. And so we're really having a nice surge in enrollment. But this is looking at just simply comparing those renal reserve values, again, before surgery, and those patients that got AKI versus those that did not so far. And I will say, interestingly, on Monday of last week, I enrolled a subject, has tetralogy of Fallot, and had his surgery on Wednesday. And I'm also doing some urine biomarker testing afterwards in these patients. Came to bedside to find one of my nephrology colleagues there because this individual had a creatinine at 0.8 on presentation for the study, up to 1.3 post-op, and oligouric, and pretty profound AKI at that point. So nephrology had been consulted. Said, it'd be interesting if you knew his renal functional reserve, which happened to be 4. And so, of course, the cardiology CICU attending said, no one told me he had kidney issues. So his creatinine was normal. He had no proteinuria. He had no hypertension. Hence, why he was enrolled in our study. So despite this excitement right now, there's obviously barriers, and I've alluded to these. It's time consuming, has not been rigorously studied, which we're hoping to change. We don't have a standard method. There's a lot of different methods out there if you go into the research, and it makes it difficult to extrapolate across studies. But I think we have shown, or investigators have shown, and we're showing that baseline GFR is not a fixed function. The capacity of increasing GFR into a protein load certainly describes the presence of renal functional reserve. We know that returning to baseline after kidney injury to normal may not mean full kidney recovery, and we certainly need more research to look at. And I really emphasize practical methods to quantify renal reserve so that we can actually use this at the bedside and use it on our patients. And certainly want to say thank you. I've had the gold mine of mentors, as you see here. John Kellum, George Schwartz, Carl Bates, and Doug Lancetto have been pivotal in helping me with this and certainly mentoring me. The NIDDK, grateful for my funding and the support that I've been given there. The groups that I work with in critical care, pediatric critical nephrology research. And so thank you.
All right, thank you, Dr. Foreman, for a very interesting talk. I think we only have a few minutes, so I'm just going to go straight to some questions from the audience here. So first, there is, a question, I guess, regarding the patient population that you are studying. If you have someone who's going into cardiac surgery and turns out to have a low renal functional reserve, how does that help you manage that patient, since probably you would want to avoid nephrotoxic medicines and so on for all of these patients? So how do you see this being used in those patients?
Yeah, that's exactly such a great question. Yes, so what I hope to achieve is that in having this knowledge base for these patients, just like the CICU attending who looked at me like he wished he would have known this. And of note, this patient did get some antibiotic exposures and some Toradol after surgery. So really thinking about how we can stratify these patients, really close attention to fluid management. One would argue we should do this for all of our patients, but I do think when we have this knowledge, we treat these patients differently. Again, close monitoring of fluid status, avoiding nephrotoxic agents as we can. And then, importantly, as we think about therapies, people talked, and I was taking feverish notes this morning about different agents around, not, ACE inhibitors. Do we think about how we would, maybe do a furosemide stress test on these patients sooner? I think there's a lot of ways that we could treat these patients differently in the immediate post-op period when I think they really are just so vulnerable. This is a group of patients that gets a lot of kidney hits in their lifetime due to repeat repairs after their initial repair, usually as a young infant. So I think we can really hopefully help their kidney health in the future with these streamlined pathways with this knowledge.
We have a couple of other interesting questions in the chat. One from Josephine Forbes. She asks whether in your youth patients, you believe that their decline in renal reserve is caused by the heart disease for which they're having surgery. Any thoughts about that?
Yeah, no, that's a great question too. I do think there is a contributor. I think importantly, I'm not enrolling anyone with cyanotic heart disease. I think that would be a whole nother cohort to study, and certainly probably would be much more at risk due to the chronic hypoxia and exposure that they have. But yes, I do think that that's a contributing factor to why the decline is probably faster in those individuals. Importantly, I stopped, I had the cutoff, although I would argue you're still a young adult in your 40s, maybe 50s, but we cut off at 40, the idea that actually, Dr. Levy, I was pulling up one of the papers that you had, this is from 1992, and you talk about how your GFR starts to decline after age 30, which is, an unfortunate milestone when you turn 30, by 10 every decade. And so importantly, I think when we look at renal functional reserve and when we study it, we want to think about the cohort of patients in which we're studying it and make that group homogeneous, because again, there could be differences in GFR within that cohort. And so the heart population is a unique niche for that.
Yeah, I think we probably have time for one more question. So there's a question here from Dr. Andrew Rule. He's wondering whether you're aware of any data on the association between renal functional reserve and kidney histology. I do believe this is something that's being looked at through the KPMP, but are you aware of any data that's been published?
Not that's been published, but every time we're a site for the KPMP here in Pittsburgh, and that would be fascinating. I'm not aware of any published data, but that would be really fascinating to link those together for sure.
Great. Well, thanks again for another great talk and provocative. I'm going to use this to also remind people that tomorrow we have the breakout sessions. There'll be a lot of time to really delve deep into all of these great topics and talk about things and questions that we have and try to come up with ways moving forward. So again, I know it's always hard to make time, but I think it'll be worth it. Anyways, we're back on schedule now. It's 2:10. We're going to take a 10-minute bio break and then resume after that with the last session of the day, which will be the new technologies lightning talks, covering a lot of issues from MRIs, nanoparticles, new ways to protect your GFR and stem cells. So see you in 10 minutes. Great, welcome back, everyone. We're now waiting for our final session. And I'm going to turn it over to our two moderators, Dr. Berman and Gary Friedman, to take on the next session.
Thank you very much. I guess I can start. I hope you can hear me.
Yes.
Good. So just by way of a very short introduction, my name is Laila Klerman. I'm a career scientist in the Division of Nephrology and Hypertension at Mayo Clinic, where I run a lab that focuses on renovascular disease, renal imaging, regenerative medicine, and some other aspects of the effects of cardiovascular risk factors on the kidney. It's a great pleasure and an honor for me to moderate these sessions. And as you know, the goal of this workshop is to really scrutinize some existing estimates of various kidney function. And this session specifically aims to introduce some novel tools that are available to phenotype the full spectrum of kidney disease, and also to discover some new functional attributes of the kidney that might serve to develop some new tools to management of kidney disease. We have some great speakers. These talks are going to be very brief, and 8-minute talks followed by 5 minutes for questions. And let me turn it over to my co-moderator, Dr. Gary Friedman, to introduce himself. And I hope he's online.
I can't see him online, so Gary might be missing in action. I hope he's okay, but we can't see him here.
So I guess I can proceed in the meantime. Maybe we'll join us a little later. The first speaker is Dr. Kevin Bennett. It's a great honor to have Dr. Bennett here. Dr. Bennett is a biophysicist and imaging scientist in radiology at Washington University in St. Louis. His lab is focused on developing new imaging techniques to evaluate kidney structure and function. And we know that Dr. Bennett has made important contributions to our understanding of glomerular structure, density, and function. So we're looking forward to his talk. Dr. Bennett, please take control, and we'll look forward to your talk.
Can you see that?
Yes.
Great. Thank you, Lilac, and also thank you to the organizers for allowing me to speak. It's a really great opportunity. So I'm going to be talking about a new technique that we've been developing to try to detect mechanisms of autoregulation in the kidney. Autoregulation is critical, as you know, for several different reasons. Some of them are trying to protect the glomerulus from damage due to natural variations in blood pressure. And in addition to that, in the presence of the same variations in pressure, to be able to maintain single nephron glomerular filtration rates constant to maintain homeostasis. And that's performed by monitoring sodium chloride concentrations inside the tubule. So the two main mechanisms that I'll talk about today are the myogenic response and the tubular glomerular feedback, both of which we're aiming to measure non-invasively. If you go back, for a long time, people have been looking at both at the level of the single nephron and also at the level of the entire kidney, looking at autoregulation from the standpoint of just bulk measurements, average measurements across the kidney or average measurements inside of the tubule. And so this is an example using laser Doppler scanning where you can see changes in flow. And it turns out that each of the mechanisms that have been identified has a characteristic frequency because they represent feedback mechanisms, and feedback usually results in some type of oscillation. And so these frequencies under normal circumstances, at least for the TGF and the myogenic response, the myogenic happens at about 100 millihertz to 200 millihertz. And then the TGF typically happens around 50 millihertz. So very slow varying oscillations, think about over, up to a couple of minutes per cycle. So very slow oscillations to maintain these functions. And so our goal was to see whether we could not only detect it using non-invasive tools, but also map it inside the kidney and get a better understanding of single nephron function. And so we use a technique called resting state MRI, and it's really not very complicated. It's been around for a long time for brain imaging. And the idea is that you basically just take an image of the kidney over and over and over. And in this case, we do it every 150 milliseconds. And our problem here, of course, is that the kidney moves during respiration. So we spent a lot of time dealing with trying to overcome motion. I won't show all the details here, but we were able to do that. And to capture the frequencies that we're interested in, we had to image over about 10 minutes. So it's a 10-minute non-invasive scan, no contrast, but collected every 150 milliseconds. And so this is an example of what we see. You can see here that this is an individual voxel inside of the image, and this is a time course over the duration of that experiment where we're just scanning over and over and over. And when you look at this, you can see these oscillations in the MRI signal, and it varies by up to 20%. So sometimes you get oscillations that are plus or minus 20%, sometimes plus or minus 15. You compare that to like fMRI in the brain, these are way bigger. So there's a lot more power here. And then we can go in and look at the frequencies of these oscillations, and we've seen frequencies all over the range, but they tend to be clustered around either about 50 millihertz or about 150 millihertz. In this case, it's 50 millihertz in this experiment. Now, if you look at the entire kidney, these are voxels from this region of interest right here, and you can see each voxel has its own time series. So it's sort of its own a picture of what's going on during the experiment. You can see some of them have oscillations. Sometimes the oscillations in one voxel are next to similar oscillations in another, but they're variable in space. And so this is characteristic of a system where you have local modulation of something like perfusion, but there could be other mechanisms. So then you can take these time series from each voxel and create a power spectrum, and you can look at what those frequencies are. And so this is an example where we show that in cortex, you get frequencies that are consistent with the tubular glomerular feedback at around 50 millihertz, what we call band 1. There is also sometimes power at lower frequencies, which there are other mechanisms that we haven't explored yet. And then we also see higher frequencies that are similar to what you'd expect from myogenic. So we wanted to see whether these characteristic frequencies could track disease progression. And so we studied a Zucker diabetic model of, a Zucker diabetic Sprague-Dawley model of diabetic nephropathy, and we tracked them over about 30 weeks. And we wanted to see whether the frequencies that we saw in each of these compartments, the cortex, medulla, and the pelvis, could track differences between the strains. And in fact, we saw that. Nice thing was this is a very heterogeneous model. And what we showed, what you see down here is that so this red represents high correlation. So the changes, the reduction in the power over time correlated very specifically with tubular injury based on histology, but not so much with, glomerular injury based on histology, not so much with tubular injury. So it was very specific to glomerular pathology in this model. Now the question is, can you do this in humans? Again, as I said, this is completely non-invasive. This is a human subject where we show exactly the same thing. If you map these voxels, you can see very different spectra, very different time series in different locations in the kidney, and then you can map these spectra and get very similar frequency ranges that are still consistent. And they're also variable depending on tissue compartment. And this is one of the really interesting things that's come out of this that might lead to sort of a new type of phenotype is that you can look at the correlation in either the spectrum or the time series at one location relative to everywhere else in the kidney. And you can see that if I pick one location here, then I look at how does this voxel here correlated to every other voxel in the kidney? And you find some very interesting things. Like if I pick a vessel here, only vessels are correlated with other vessels. If I pick the ureter, only ureters correlate with ureter. Correlations in cortex are local. So there's all sorts of things to explore here. And so what could you do with this? We think it represents a new phenotype, type of functional characterization. You could imagine combining this with a targeted therapy and then some kind of ability to manipulate it pharmacologically or physiologically to give you some type of measure of functional reserve. And then, this could be used combined with a type of challenge to try to give you some way to stratify patients or to be able to classify stages of response to therapies. So I think I've demonstrated that we can see spontaneous physiological fluctuations that you detect with MRI in both the human and the rodent kidney. It's a 10-minute scan, non-contrast and practical for clinical studies. Frequencies are consistent with autoregulation, including the myogenic and the TGF response. And this provides a new physiological phenotype that could identify new pathways for disease and targeted therapies. Thank you.
Thank you very much, Dr. Bennett. This was a great talk. I don't see yet any questions in the chat room, in the chat. So let me ask you, maybe just start off with a couple of questions. Do you think that the fluctuations might be related to perfusion or filtration function? Is there a way to decipher that?
Yeah, it's something we're definitely working on. I mean, as you know, getting to the biophysical mechanisms of a change in MR can be a little tricky. So one way we're starting to address that is to go in and use basically just a different pulse sequence where we can weigh it more toward things like oxygenation versus things like flow. At the moment, it appears that it depends on where you are on the spectrum. So some features of the spectrum are more sensitive to flow, some features are more sensitive to oxygen. And it looks like that band 1 fluctuation is both. So it contains components of both of those. The changes in flow, those oscillations have been observed both in the tubules and in the vessels, which is nice for us because it acts as sort of like an amplifier. So you may be able to distinguish those, but we'd have to play around with ways to do it. So.
Great, thank you. There are a couple of questions from the chat now. Firstly, just a second. We have a question from Owen Richfield. Do changes in autoregulatory frequency cause glomerular damage, or is it the other way around?
So I don't know about changes in frequency. I think it's a matter of, at least for the TGF, it's a matter of whether it's autoregulating or not. So the whole point is to control intraglomerular pressure to prevent hypertension. So for example, in SGLT2 inhibition, in diabetics, you have overexpression of SGLT2 receptors, which causes an increase in the glucose that's coming out. And so you essentially get deactivation of the TGF, and the idea of an SGLT2 inhibitor is to restore that. And so it kind of depends, but I'm not sure about, does a shift in the frequency cause the damage itself? Because these are very low frequencies. Again, this is not high power at some high frequency. So it's not, I don't think that it's causing its damage on its own.
Excellent. We have a question from Bidan Bandi.
We probably need to now move on to the next talk.
Okay, so we will move on to the next talk. So thank you, Dr. Bennett, and I believe that we have the co-moderator joining the meeting. Is that correct, Dr. Friedman? I think I saw him joining, but in the meantime, perhaps we should proceed.
Yeah, I just saw.
Yes, Lilak, it's Gary Friedman. Sorry, I'm running a little bit late. Had an emergency with my wife.
No problem. This is always important to take care of. So we have started the session. So are you ready to introduce Dr. Goldstein, or would you like me to do it?
No, please go right ahead.
Sure. So it's a pleasure to introduce to you Dr. Stuart Goldstein from Cincinnati Children's Hospital and MediBeacon, who is a pediatric kidney specialist. Dr. Goldstein is the Clark D. West Endowed Chair and Director of the Center for Acute Care Nephrology. He's also the Medical Director of the Ferezi Service, co-director of the Heart Institute Research Core, and a professor at the University of Cincinnati Department of Pediatrics. So it's a great pleasure to have him talk about his subject that is here displayed. Please go ahead.
Great. Thank you so much, Dr. Lerman and Dr. Friedman, and to the organizers. And I'm presenting this on behalf of MediBeacon, and my disclosures is I am a stockholder of MediBeacon, but an employee of Cincinnati Children's Hospital. So, and I see my good friend Dr. Levy is on the call today and taking this from the CKD EPI paper. We all understand that while the equation is very good for population health, and which is depicted by the dark line here, that an individual patient's estimated GFR, if it's measured at 59, could be really anywhere from 89 or 90 down to CKD stage 4. And you've heard a lot today already about different techniques, all of which are invasive to get a true GFR. So, and even Dr. Levy in the paper said bias is improved, especially at higher estimated GFRs, and this was compared to MDRD, although precision remains suboptimal. So I'm going to talk to you about a compound called relmapyrazine, which is the MediBeacon compound. And I won't go through all of its physicochemical properties, but importantly, it has no protein binding. There is no metabolism. And what Dr. Dorshow and his group took advantage of was that it has a large Stokes shift, meaning that the excitation wavelength and the emission wavelength of this molecule is very, very different. 445 nanometers to 560 nanometers. So you can excite relmapyrazine with blue light and it'll emit green light, and this can be detected on the skin. So the MediBeacon system utilizes relmapyrazine, and the sensor I'm showing you here is a first generation sensor, which is placed on the skin, generally on the sternum, but has also been placed on the occiput. And relmapyrazine is injected intravenously, a 7 milliliter injection. And then after equilibration, which takes about 15 minutes before the injection in order to get the background fluorescence, after the injection, it peaks at about 1 hour, and then it starts to be removed solely by glomerular filtration. This change in concentration on the blood side of relmapyrazine can be detected as a decrease in fluorescent signal on the skin. So there were a number of objectives which I'll go through, but the first was to demonstrate that relmapyrazine is a GFR agent by comparing it to iohexol. The second is to demonstrate that the transdermal system worked for a range of GFR, with half of the GFRs below 60 and half above 60. And then given the important recognition of the race modifier and potential bias, that since this is a transdermal methodology, that this should work across all of the skin tones that exist in humans. And these are categorized as the Fitzpatrick skin scale, light to dark, 1 to 6. Here you can see this is measured GFR with relmapyrazine, and it demonstrates first a 2-compartment model, and you can see with a normal GFR, a relatively steep slope on the left, with CKD stage 2, a less steep slope, and then with CKD stage 4, an even more shallow slope. Again, this is blood side measurement, but just to prove that this is affected by GFR. In the phase 1 and phase 2 studies comparing GFR by iohexol to blood side GFR by ralmopirazine, you can see nearly a perfect R squared, and the FDA has deemed ralmopirazine to be a GFR agent in man. Importantly, again, as I mentioned, we looked at the correlation between GFRs greater than 60 and less than 60, and you can see there's a near perfect correlation between iohexol and ralmopirazine. So objective 1 was achieved. What we also needed to demonstrate was that this could be detected or recovered in the urine, and you can see that it's normal kidney function, stage 1, 90 to 120, 60 to 89, that almost all of the ralmopirazine and iohexol are recovered in the urine. You'll see in stage 3 and 4, we did not go out to the 24 hours to collect all of the ralmopirazine, but this demonstrates that ralmopirazine, like iohexol, is not metabolized. So now let's get to the transdermal technology. And once again, this is showing the transdermal detection, and again, a 2-compartment model. And this is in a patient with normal kidney function. And here you can see in a patient with impaired kidney function that the transdermal decay of the fluorescence has a slope that is much more shallow than somebody with normal kidney function. And when we look at our pilot groups 1 and 2, between blood side measured ralmopirazine on the x-axis and transdermal measurement on the y-axis, we see a very good correlation. And importantly, most of the dispersion or the lack of correlation happens at higher GFRs, which are of less clinical significance. You can see a much tighter correlation at below 60, below CKD stage 3. Now, these are data from the pre-pivotal, not from the data that I've shown you, but you can see from our pre-pivotal data with the first generation sensor, when we overlay this over the CKD epigraph, while it's not 100% perfect, the confidence intervals are absolutely shrunk, and we have a much less of an over or underestimate of GFR. Importantly, again, in looking at the pilot 1 and 2, we saw no difference in the correlation between transdermal GFR on the x-axis and measured GFR with ralmopirazine on the y-axis with the different skin tones. And so did not matter how light or dark skin is. And in the pivotal phase 3 trial, we are ensuring that all skin tones are represented. I want to change just and finish up with an interesting study we did with Dr. Humes. One of the benefits of this technology is even in patients with normal kidney function, there is enough signal to noise ratio transdermally for about 6 to 8 hours. So not only would this be a diagnostic in stable kidney function, but could be a theragnostic in patients with decreased kidney function. And listening to Dr. Furman's lecture earlier, could be of benefit in renal functional reserve assessment. Now, this is work we did with Dr. Humes, not with necessarily acute kidney injury, but this is a porcine model, and we published this in a SIO last year. And Dr. Humes performed bilateral nephrectomy on the pigs, so they have 0 GFR, put the pigs on CRT, and then injected ralmopirazine and meropenem, which has very similar physicochemical properties to ralmopirazine, and measured transdermally changes in clearance associated with changes in the prescription on CRT. Ralmopirazine has a diffusion coefficient of 1 and a sieving coefficient of 1. It is a very small molecule, only 382 Daltons. And what you can see here in graph A and graph B, graph A just looks at the change in transdermal fluorescence on the pig during CRT. And from the light blue to the red, there was an increase in clearance, and immediately we saw an increase in transdermal clearance of relmapirrazine. Then in green, we slowed the clearance, we slowed the effluent rate, and you can see that clearance decreased. And then we increased it again in the brown, and you can see immediately we saw a change in clearance. On the B graph, we're just showing the blood side relmapirrazine concentration, showing that the transdermal concentrations fit quite well with that. And then finally, when we compared the clearance of relmapirrazine transdermally to the blood side measurement of meropenem with these 4 different CRT prescriptions, we found a very tight correlation. So potentially in the future, we could use this technology for accurate drug dosing in patients on CRT, which was one of the first priorities of the Kidney Health Initiative way back when the Kidney Health Initiative started. So there were a number of PIs who assisted with the work that you've seen in terms of the pilot 1 and 2 studies. And then Dr. Bonventry, Miller, Nally, Nolan, and Solomon are advisors and helped us with the interpretation of these data. Thank you so much.
Thank you very much, Stuart. Do we shall we start with questions right now?
Yeah, we can maybe do one question or 2 at most.
Okay, I see there are a couple of questions in the chat, and the first one came from Dr. Levy regarding iohexol and extrarenal clearance. Is this information also known for relmapirrazine?
Yes, there is no extrarenal clearance, Dr. Levy.
Thank you very much. And secondly, does subcutaneous or pulmonary edema affect the TGFR with relmapirrazine? As far as you know?
That's a great question. We don't know yet about pulmonary edema. We've only tested this in patients with stable CKD. We also have had patients, like I can't say much about edema, but we have had patients who were on the overweight or obese category, and it seems to work just fine, but we'll have to determine that. However, we like to use it on the sternum. So as long as the sternum or the occiput are accessible, those tend to be places where there's less edema.
I'm going to sneak in one additional one because it relates to this regarding the Fitzpatrick skin type. So going all the way from 1 up to 6 in terms of Fitzpatrick skin type, what are the impacts?
There was no impact. So, and again, we're looking at that even more assiduously in the pivotal phase 3, where we're also biasing towards the darker skin types to make sure, but at least in our preliminary pilot 1 and pilot 2 data, the R-squareds were 0.9 with both.
Not a question, but just a comment, and I'm speaking from the industry side as a director at Pfizer. So that fact that this is utile across the Fitzpatrick skin type is very, very meaningful. Secondly, in terms of the CRRT information that you showed, this is extremely relevant for emergency use authorization medications as well as non-emergency use authorization medications in order to help with approval for dosing for CKDs 4 and 5. And we could perhaps discuss that later on.
Yeah, I'd be happy to, Dr. Friedman.
Outstanding.
And since you're so efficient with those responses, we'll just put in one more because there are 2 related ones from the audience. What might subcutaneous fat or edema or any other factors affect the readings?
I don't think so. As I mentioned before, we did have patients in the overweight and obese BMI categories seem to work quite well. Do not know about edema yet. Again, as we're attaching this hopefully to the sternum, but again, somebody with open heart surgery, we may not be able to do that. So we would try the occiput. That's where we've tended to do where there's less edema and less subcutaneous fat, but something we would need to look for in patients who are, say, in the ICU who were very fluid overloaded.
Great, thank you for that. And there's some other questions. Please feel free to respond to those in the chat.
So we will move forward to the next presentation. And it's my honor to present to you Dr. Adam Bush, who is an assistant professor in the Department of Biomedical Engineering at the University of Texas in Austin since 2022. Dr. Bush develops, validates, and applies novel MRI methods to explore human pathophysiology and make imaging safer, particularly for children. His lab combines engineering, physiology, and medicine to pursue novel blood flow and oximetry methods in disease. Dr. Bush, I believe you have control now, so it will be a pleasure listening to your talk about quantifying renal hemodynamics using non-contrast deoxyhemoglobin dynamics, susceptibility, contrast MRI.
Awesome. Well, can you guys hear me? Okay, great.
Yes.
Well, thank you for that introduction. This has really been an eye-opening webinar, learning a tremendous amount. So thank you for this kind invitation to speak to y'all today. So as stated, I'll be talking about quantifying renal hemodynamics using non-contrast DSC MRI. These are my disclosures. As stated, I'm a new assistant professor in the Department of Biomedical Engineering here at the University of Texas at Austin. And if I start with my thank yous first, I would like to thank my relatively newly formed group of grad students, in particular a second year PhD student, Tian Nguyen, who's really been carrying much of this early work so far. So as a general outline for the things that I'll briefly discuss today, we'll talk about renal function and imaging, and then move on to dynamic susceptibility contrast imaging. So as you guys all know, we've talked a lot today about the different assays for kidney evaluation, mainly spot and collection techniques. However, this talk will predominantly talk about imaging. So imaging is used a tremendous amount in clinical nephrology as well as body radiology. And there's a number of different imaging modalities, including MRI, CT, X-ray, as well as ultrasound. However, almost all of these modalities, it's used for structural evaluation, meaning we're looking at the shape and size of the kidneys. And this can be both with contrast agents as well as without contrast agents. However, when it comes to kidney function, the main or predominant kidney assay here is scintigraphy, which of course is a 50-year-old form of technology and uses radiation as well as takes a long time to acquire. And of course, gives you relatively grainy images like the one seen on the right. Okay, so there are a number of drawbacks to that form of imaging. So the new kid on the block, I think, is MRI. It's not really that new. It's been around for 30 years. However, it's not predominantly used for assessment of function. There are a number of advantages to MRI, including it's non-ionizing, as well as it doesn't necessarily involve contrast. However, it hasn't really been developed as much as it should be, especially for the kidney. However, when we think of MRI and functional MRI, there's actually a tremendous amount of functional evaluation, pulse sequences and techniques that have been developed predominantly for the brain and the heart. Here's just a collection of some of the gorgeous images that MRI can create for clinical evaluation of different pathophysiologies. However, if the goal here is to think about how can we create new GFR or renal function assays, of course, renal hemodynamics comes to mind. So GFR, we all know, is merely the product of renal blood flow times the plasma fraction, and then multiplying that times the filtration fraction. So it's clear that if we're able to quantify renal blood flow, this would be an extremely important parameter for evaluating renal function. And it turns out that MRI is actually extraordinarily good at quantifying blood flow, and there are a number of different modalities to do this. There's ones that involve both exogenous contrast agents, and then there's also a non-contrast agent techniques as well. So for this talk, we'll talk about one called dynamic susceptibility contrast imaging, which of course uses a contrast agent. And the advantage of dynamic susceptibility contrast imaging is that it allows us to quantitatively evaluate several different renal hemodynamic parameters non-invasively. And this is with, this includes blood volume, blood flow, transit time. And of course, this involves the use of a gadolinium contrast agent, which is a paramagnetic injected contrast agent. So typically this works by injecting this contrast agent into the vein of a patient. As that contrast agent passes through the circulatory system, and in particular the microvasculature, this leads to local susceptibility gradients that it calls spin dephasing. And this results in a loss of signal. We can measure that signal loss in time using rapid imaging strategies, very similar to the ones that Dr. Bennett described. Except in this case, we're interested in quantifying this parameter called R2 star or T2 star, which is related or is a relaxation parameter in MRI. Using that relaxation parameter in the time course of this increase in that relaxation parameter, R2 star, we can get these summary parameters spatially. So in this case, we're looking at the summary parameters for someone that has a stroke as that contrast agent kind of washes in and washes out of the brain. And what you can see is we can derive different parameters, including the peak signal, the full width half max, a bolus arrival time, and these are used clinically to assess areas that have been infarcted. However, we can also go a step further and use kinetic tracer modeling, and this is where we can model quantitative hemodynamic parameters, things like blood volume and blood flow, based on a signal model. So we can start with a very simple signal model here. We can convert that into a quantitative parameter known as R2 star, this relaxation constant. And then we know that this relaxation parameter, R2 star, is directly proportional to the concentration of your contrast agent. So in this case, gadolinium. And then we can use some math. So if we know the inflow of that concentration, contrast concentration, sorry, that's a mouthful, in the artery, we can then deconvolve that with the tissue response and get parameters like kidney blood flow or brain blood flow, as well as so that's the kind of the background for how that technique works. So recently, my group has developed a technique using deoxyhemoglobin instead of gadolinium to perform this operation. And of course, since we're using deoxyhemoglobin instead of gadolinium, we use nitrogen gas in this case, and this means that we're contrast free. It's easily repeatable. There's no risk of allergic reactions because no one's allergic to nitrogen. And then of course it's cheap because it doesn't involve an actual contrast agent. So what we do is we give a patient or subject 5 breaths of nitrogen, 100% nitrogen to breathe. This causes a desat in their arterial saturation. Similar to gadolinium, this causes a bolus of arterialized deoxyhemoglobin to enter the arterial side. And then we can map that response or increase in relaxation or decrease in signal in order to extract these hemodynamic parameters. And of course, this leverages the famous blood oxygen level dependent signal or BOLD signal, in that deoxyhemoglobin is paramagnetic, just simply meaning that it increases the local magnetic field. And this is the kind of what underpins fMRI, and which has revolutionized neuroscience. So here are some example images in the brain. Whoops. So here are some example images of the brain using this technique called DDSC for short, where we use deoxyhemoglobin as a contrast agent. And in this case, we're showing that you can clearly see in the difference in blood flow from the gray matter versus white matter, as well as in this case, this was a study looking at sickle cell disease or an anemic population. We see that the anemic population has a much higher brain blood flow as well as blood volume and shorter transit time. So it matches our intuition of what should be happening. So recently, we've been doing this for probably the last 6 months or so. We've are beginning to translate this into the kidney. So we can acquire very rapid images. In this case, EPI images of the kidney, of course, after some simple corrections for motion. We can then give someone 5 breaths of nitrogen to breathe. This causes a local drop in the signal. And then, of course, we can look at the increase in this relaxation parameter known as R2 star. Now by using a very simple algorithm here, where we just integrate that signal, we can get a map of blood volume as seen on the right. Now we have in this case, it would be a qualitative map, but this could easily be converted into quantitative parameters. But this is a qualitative map of blood volume in the abdomen, but mainly what the focus here is the kidney. So things to notice, we see that there's a very low blood volume in the collecting system, as we would expect, but then it looks like the intralobular veins have the highest blood volume, which isn't surprising, as well as the spleen here seems to have a higher blood volume than the liver, which all matches our intuition. So as a kind of preliminary study, this seems to be a promising modality for getting hemodynamics in the kidney, non-invasively and without contrast. So in summary, we've been able to show that at least this technique is feasible. In the future, we would like to include a more rigorous motion model by using novel acquisition strategies, which will take some novel pulse sequence design. And then, of course, if we can combine our blood flow measurements with a measure of filtration fraction, we can get at GFR in a quantitative sense spatially. So I would like to thank my collaborators, students, and of course, funding. Thanks.
Thank you very much for the excellent talk, Dr. Bush. That was very, very interesting. Let me start off just with some simple questions. Is this method, I guess, susceptible to the same limitations of bold MRI? For example, the dependence on microvascular density. You mentioned actually the dependence on hemoglobin in the patients with sickle cell. How does that affect the measurement that you try to get in the kidney?
So that's actually a really great question. So in order to get quantitative parameters for blood volume and mainly blood flow, you do need to include a model of the microvasculature, so like where the signal is coming from. Oftentimes that's just, it's included as like a constant value. However, because we're in a new organ, we can't use constants that were derived in the brain, or this technique has really only ever been done in the brain. So this is something that we'd have to interrogate in order to get true quantitative values. But the relative map should work quite well.
Lilak, it's Gary Friedman. Can I take executive privilege here and follow up with a question before we go to Dr. Richfield? Dr. Bush, really, really fascinating. And your discussion about sickle cell disease brought up two spectacular failures that I've witnessed in drug development for sickle cell disease. And it's in large part because of what you're describing here and what Dr. Richfield is asking about. So we know that looking at urine and blood biomarkers just gives us an overall integrated picture. It really does not give that segmental view of what is going on in a segment or in a patchy fashion as opposed to homogeneous fashion. So really following up on that in terms of the clinical correlation and the value that that might have in terms of drug discovery and drug development. Just really want to move to Dr. Richfield's question here is, can you comment on the spatial distribution of renal blood flow, knowing that you're still working in that direction?
Yeah, I think it's a great question. I have some history doing research in sickle cell disease, and every time you look, they're different. And if you don't include that difference, you're going to get spurious results. This has been well characterized in the brain, and honestly, the kidney is just, not only is it new frontier to just general MRI, but now we start talking about unique pathophysiology. It's just wide open spaces. So in terms of quantifying the microvascular disease and sickle cell disease with techniques like this, I think it provides both a technical opportunity as well as a pathophysiological opportunity, which definitely needs to be explored.
Really appreciate that comment. And I see that there are additional questions coming in regarding advantage of this is a lack of T1 leakage, making things a bit easier, perhaps. Can you comment on how this technique compares to what's listed here?
Right. So in standard DSC imaging using gadolinium in DSC imaging requires that the contrast agent stays within the blood pool. So in the kidney, the contrast agent doesn't likely stay in the blood pool. It gets filtered out into the urine. But of course, hopefully your hemoglobin is not leaking into your urine. So therefore, we can have a much more accurate model using deoxyhemoglobin as your contrast agent than gadolinium. That's one of the reasons why this is primarily only used in the brain, because the blood-brain barrier prevents it from extravaganting outside of the blood pool. So this really opens the door for doing this non-contrast, repeatable, safe method in pretty much any organ in the body. So I think it's going to be big in the future.
Thank you. And there is one question regarding safety from Dr. Rule regarding hypoxia. Any comments on that?
So certainly, well, of course, in the extreme case, it could be lethal, but 5 breaths are extraordinarily safe. We've done this not only in healthy subjects, but like I mentioned earlier, we've done this in over 100 patients with sickle cell disease who would be likely to have a risk of hypoxic injury if there was truly something here. It's analogous to a momentary apneic event for those that have sleep apnea. And if you have, I think it's up to 4 apneic events per hour, it's considered normal at night. So this is a largely safe technology that I don't see having any adverse events, or at least for people that are fully saturated. Maybe as the congenital the cyanotic heart disease that was discussed earlier, that might be a population where you'd have to think about whether to do it or not.
I think perhaps we should move on to the next presentation. If there are any other questions, please reach out to Dr. Bush and you can discuss it offline or tomorrow in the breakout sessions. The next presentation will be by Dr. Ji Zheng and Dr. Mengxiao Yu. Just a brief introduction. Dr. Ji Zheng is a distinguished chair and professor at the University of Texas, Dallas, and holds an adjunct appointment in the urology department at UT Southwestern Medical Center. Dr. Mengxiao Yu is a research associate in the chemistry department at UT Dallas. And in the upcoming talk, Dr. Zheng will present on nanoparticle transport and interactions in the normal kidney at the fundamental levels. And this will be followed by a short talk by Dr. Yu on how to use renal clearable gold nanoparticle for non-invasive detection of kidney injury in the preclinical setting. So thank you very much, and we're looking forward to this talk. Dr. Zheng, please.
We don't hear the audio quite yet.
Yeah, sorry about that. I just unmuted. Can you hear me now?
Yes.
Yes.
Okay, great. Thank you so much for the introduction, and it's also a great pleasure for us to be here. And we're a group of chemists. And 15 years ago, we just find out a class of gold nanoparticle that can be eliminated through the kidney. So since then, we have been working on 2 directions. One is we're trying to understand how exactly nanoparticle transport and interact in the kidney. And today we'll focus on discussing the size independency. And another mechanism, we just figure out that how the proximal tubular handle the nanoparticle. And after this, Dr. Mengxiao Yu will discuss about how to use this nanoparticle for different applications in the kidney. And because of the limited times, we cannot discuss in details, but if you are interested, we just have a paper will come out in the Nature Review of Nephrology. Hopefully, in the coming years, this nanoparticle, renal clearable nanomedicines can help to contribute to this field in the clinical in the future. And the nanoparticle I mentioned is a gold nanoparticle. This nanoparticle are tiny, really just about 2 nanometer, 2-3 nanometer. And the surface of gold nanoparticle is coated by the glutathione and the amino acid peptide. The one thing is different is this nanoparticle, if you put in the blood, and they are not bind to albumin, and they're highly resistant to certain protein absorption. So they stay in the same hydrodynamic radius in the circulation. And another feature of this nanoparticle actually is fluorescence. And without any organic dye conjugation on nanoparticle itself can keep the light and the light excitation. That's actually the reason how we find out our nanoparticle can clear out through the kidney, as you see from these pictures. And another advantage of gold nanoparticle over the many other probe is it have very large X-ray absorption. So later when we got some additional fund, I don't know. Yeah, we used X-ray to imaging the transport of nanoparticles through the kidney. As you can see, right after injections, nanoparticles pass through the kidney and eventually end up in the bladder. And we can see the well-defined the transport stage through the nanoparticles. And this is understandable because based on the textbook that as long as a nanoparticle are smaller than kidney filtration threshold, often 6 to 8 nanometer, nanoparticle can be cleared out through the kidney like a dextran, right? Small dextrans. And a few years ago, we actually asked a very naive question because we are chemists. And so what happened if nanoparticle continue to become smaller? Is that the filtration faster, right? The glomerular filtration faster. So we went extreme and we make 3 different nanoparticle. We often in our field we call nanocluster. One is gold 25 on your right, and the other is gold 18 and the gold 10. The 25 means there's 25 gold atoms in the composed of the nanoparticle. 18 gold atoms, 10 gold atoms. So their size is only 7 atoms different. And the gold 25 is about 1.1, 1.2 nanometer. Gold 18 is 0.9 nanometer, and gold 10, 11 is about 0.6 nanometer. So they're extremely small and close or below 1 nanometer. So if you pay attention on the particles when we introduce them into the body, gold 25 was rapidly filtered through the kidney and you can see the bladder accumulation. But gold 18 compared to gold 25 is starting to slow down. And the gold 11 even slower. This is really against our intuition, right? The small particles supposed to filter out faster. And so it's turned out to actually we later used the biological EM to study the tissue slides of the kidney, and we find gold 25 this is glomerular filtration. As you can see the 3 layers, the podocyte, the GBM, and the glomerular endothelial cell layer. And the gold part 25 have no accumulation or bindings when they pass through this glomerulus. But gold 18, if you pay attention, you can see that a lot of particles actually were trapped in the glycocalyx layer. And so that is the part of reasons why particles, smaller particle, gold 18 and gold 10 can be filtered through the glomerulus, but in a much slower rate. This is very similar for us is the size-dependent exclusive column, right? And for the size-exclusive columns, the smaller particles always filter out slowly is because we're temporarily trapped in the kidney, in the columns. And so we use these particles to build a more comprehensive picture about how the gold nanoparticle filters through the glomerulus. And once the particle size below 1 nanometer, we actually see the dramatically decrease in the glomerular filtrations. And after this, we ask another, also a very naive questions, because in our field, the renal cerebral nanomedicines, people often consider kidney as a passive organs, have little interaction with nanoparticles after we filter out the glomerulus. And but we did notice that when particle pass through the glomerulus and they have some interaction with proximal tubular, Okay, so these two nanoparticle, one is negative charged and the other is positive charged. As you can see, both of them filter out through glomerulus, but the nanoparticle do taken up by the proximal tubule. And for the positive charge one, it's taken up, if uptake efficiency is much higher, you can see the actually is inside of proximal tubular cells. But given time, after 30 days, you can see there's no particle left in the proximal tubule anymore. And you can see a little particles, some particle actually still stay the glomerulus, but in general, there's no particle accumulation in the proximal tubular, even after they are taken up by the proximal tubules. Right. So what happened? We used the biological EM. Look what happened. And as you can see, it's inside the lumen, and we see a lot of vesicle with size about 5 micron. And this dark points actually is a nanoparticle aggregates after taken up by the proximal tubular, this capsulate in the lysosomes. And outside this is, in addition to, you can also see the mitochondria and the ER in this 5 micron vesicles inside the proximal tubule. Actually, it's nanoparticles was extruded into the lumens. And this pictures, in addition, this picture also show you the intermediate process. This is a proximal tubule, and the membrane starting to be pushed out. And together with this particle capsulated in the endosome, mitochondria and ER all push out. And so that's why we figure out the reason nanoparticle re-eliminate into the urine even after proximal tubular uptake is because they have this so-called the self-renewal process to push the nanoparticle out of proximal tubular. And so follow this discovery, we'll ask a very simple question. Is that because your gold nanoparticle activate some specific biological or physiological process of proximal tubular? Actually, it's not. It's nothing to do with nanoparticle uptake. This is the proximal tubular under control. We only inject the PBS. You can still see this extruded vesicle with the mitochondria, ER, and other intracellular organelles. So in summary, there's one, using the gold nanoparticle, we also identified a new mechanism how the proximal tubular cell keep itself healthy. And for nanoparticle is taken up and transformed inside the cells and become aggregate, and then they follow up extruded out back to the urine later. And but this is the native physiological function of proximal tubular cell. Is nothing to do with whatever nanoparticle they uptake. In the injury stage, once we use this cisplatin induce some injury, this process again is decreased dramatically. Eventually, in the severe injury stage, this process disappeared. And I will give this talk to Mengxiang, and she will discuss how we use nanoparticle for the application earlier diagnosis of kidney disease.
So because our nanoparticles give the signal under the X-ray and also have the bright near-infrared imaging, so we're interested whether the nanoparticle clearance from the kidney can reflect the clearance function in the disease model. So UUO model is the first model we learn. And in this model, as you can see, after the ligation, the left kidney was damaged. However, the fluorescent, the control kidney still will keep the kidney function very well. So the biomarkers actually return the same as normal. So after we inject the nanoparticles to the UUO model, very interesting, we can still see the particles clear out from the healthy kidney. But we do notice that a lot of particles actually accumulate in the damaged kidney. So more interesting is we see the specific selective nanoparticle accumulation in the medulla area. So the pathology analysis confirm that. So after the particle get filtered by the glomerular, so the particle can selectively accumulate in the tubular in the medulla area. So because our nanoparticle also give the near infrared fluorescence, so we can use the low cost fluorescent imaging to track the nanoparticle out from the kidney. So the right kidney is a healthy kidney, and the left kidney is obstructed because of the blood perfusion change. So the diseased kidney will give much lower contrast under the fluorescence imaging. So the challenge for the fluorescence imaging is the fluorescence imaging only capture the surface area, so lack of the depth resolution. So we also try another optical imaging technology. So it's called the photoacoustic imaging. So because the particles also give the photoacoustic signal, so you can see after the particle injection, so the retinal artery become the fluorescent. So because the photoacoustic imaging can capture the image within just 1 second. So after that, we can see the particle accumulate in the cortex because of the clearance pathway. And later, the particle will be concentrated by the kidney and clear out through the papilla into the urine. So based on the spatial information and also temporal information provided by the photoacoustic imaging, so we can calculate the GFR based using the gold nanoparticle as the marker. So these GFR values are consistent with the FITC inulin, the plasma clearance measurements. So in the UU model, and then we later found out, so the healthy kidney still maintain the GFR, and the obstructed kidney has GFR dropped by more than 0.5%. To conclude, and we found that the engineered particle can actually serve as a very powerful tool for advancing our understanding of the nephrology in a nano regime, and also provide some technologies for early diagnosis of a kidney disease. So either based on the higher signal output of the nanoparticles, or because of the specific interaction of the nanoparticle and the kidney. We greatly appreciate NIDDK support. Thank you very much. And we're looking forward to advice on how to apply the nanoparticle to understanding the kidney disease better, and also to tackle the challenge in the clinical. Thank you very much.
Thank you both very much. Absolutely fascinating talk. And it's so interesting how there's a certain complementarity as we go from one speaker to the next A question that readily comes to mind from a drug development point of view and an endpoint point of view is not only are you talking here about the possibility of the onset of the disease, but do you see this a value for looking at recovery from disease after intervention?
Yeah, we think it's possible, and we actually is pushing using the nanoparticles to study the rescue the kidney functions, and we do feel that's the potential directions we can do in the future with our nanoparticle.
Well, fascinating, because it would be very interesting to see with standard, blood or urine biomarkers to see if this does indeed predict when you're going to see an improvement in those. And I see there are two follow-on questions here that are very much related in terms of one, can you conjugate the nanoparticles to various surface structures within the kidney? And then also, do you envision that these would be possible to utilize as a way to deliver a therapeutic more locally?
Yeah, that's is also the direction we push forward, and so far we're able to use the anti-cancer drug as a model system to carry drug, to deliver drug to the cancer site. And the interesting is we find for example, doxorubicin, after conjugate to the nanoparticle, the doxorubicin toxicity to the kidney was significantly reduced. And in the meantime, we are also, it just proof concept how we conjugate the load drug to the nanoparticle. But I think in the coming years, we're trying to use this to the different kidney disease. And so far, the difference between kidney disease and cancer is normal and the injured or diseased kidney proximal tubular, for example, mixed together. So it's even bigger challenging for the drug delivery, how exactly deliver drug into the diseased proximal tubular, well, without the accumulation in the healthy tissue. Yeah, but this definitely is the direction we're actually working on that. Yeah.
Okay, great. I hate to cut this short, but we are running behind schedule. Please also feel free, there's more questions if you want to answer them in the chat. I think that would be helpful in keeping the momentum going.
Yeah, sorry about it, take too long.
That's okay, it was a great talk.
Okay, we will move on then. The next speaker is Dr. Zhang. And just by way of introduction, Dr. Zhang is an associate professor at the Wake Forest Institute for Regenerative Medicine at the Wake Forest University School of Medicine, where his research focuses on the use of patients' urine-derived renal stem cells to improve renal biomarkers. Through this innovative work, Dr. Zhang has made significant contribution to our understanding of renal diseases associated with aging. His expertise in stem cell biology, diabetic nephropathy, and precision medicine, combined with his passion for developing biomarkers for age-related kidney disease, make him a valuable asset for our session. So thank you very much. We're looking forward to your presentation, Dr. Zhang.
And I think we're having some audio challenges. Dr. Zhang, we can't quite hear you yet.
Sorry, I mean.
We can now hear you. Thank you, sir.
Oh, okay. Thank you. Thank you, Dr. Naaman. And so the talk, thank you for the organized for this workshop. What I would like to share with you and recently our data use human stem cells as a potential marker for kidney disease and the aging and kidney aging and nephrotoxicities. So this talk will address the two questions. Are there really stem cells in the urine? Because urine is waste material, people think about us as unsterile. How are stem cells there? This first question we need to address. Second, can we use these cells as the early marker for the kidney disease and other? So I would like to talk about the stem cells in the urine. Cells in the urine is nothing new. However, we find three kinds of stem cells in the urine. Number one is we call this fully differentiated cells. That's urethrium cells from bladder. 99%, most of the cells. Those cells cannot culture, just fold in the area, but the cells didn't die. Second, we call the differentiating the cells. These cells can grow in the culture, but only one passage cannot go further. However, another cells, very interesting. They can stick on the culture condition, they can grow very rapidly. So that's the imaging what we want to show. That's what we're looking for. Usually we can see the majority of cells is the urethrium cells. See the cells is still alive, but these cells, after typhoid brew, this cells pick up the brood cells there, but these cells are alive. The cells cannot be alive. Have another type of cells that can stick for culture for only one passage, no more. These cells, we call this interesting cells. This start one single cells and form a colony that can go for many passages. So these cells are doing well, can generate a lot of passages. These cells can express the very interesting marker. They can express the mesenchymal stem cells marker. All these mesenchymal stem cells is positive, particularly CD24 and CD133. That's the kidney progenitor cells. We'll talk about it if we have time. But these cells are not expressed the proteomic, the hemopoietic stem cells. This means not come from blood. The third marker expressed the polypotency cell marker, but it's low level. then make these cells can differentiate, can reprogramming iPS cells very efficiently in a period of time. If we have time, we can talk. We have several publications for that. Another thing is these cells can differentiate to the osteocyte, chondrocyte, and the myocyte. This way they can form that, we put in the neural mice, they form that the chondrocyte adipose cells, but no teratoma formation. These cells also can form the renal tubular structure. AQP1 is the renal proximal tubular cell marker. These cells can express this can form that tubular structure in the 3D culture, in the organoids. But also these cells can differentiate, if we add the growth factor, the cells can differentiate the podocyte marker. This renal cells was positive with these organoids, just show that the marker. This ultra structure, we can see this surface of the urine dressing cells have microvilli for that. That's 3D culture. Interestingly, these cells express the telomerase activity. See, they're interesting. We can see this term, the number of the cells express the telomerase activity decrease with age. See, that's the 20 years old young people, that's 50 years old. There's one individual we can collect nearly 20 colony, but majority of cells, 16 colonies show telomerase activity, which means the cells show telomerase activity is pretty high, 70%, 75%, but there's keep until 40, then dropped as the 50. Also, these cells, the telomerase activity decrease with culture. Through the timing, the telomerase activity dropped, then making the cells safe to use. If not dropped, they will like cancer cells, right? So, but these cells is much longer than the regular stem cells, like bone marrow stem cells, that only can maintain passenger A, but we can double. But for the aging cells, they just end up the telomerase activities earlier, about 10. Also, these cells, interestingly, the cells can express telomerase activity in the low level in the diabetes nephropathy patient, but the age matched is pretty high. So make us to thinking, can we use these cells or use as the marker to predicate the kidney aging or kidney disease, because these cells come from diabetes nephropathy. So I would like to quickly summarize what we did before. So the question I address is are there stem cells in the urine? The answer maybe you will tell me this is yes. And this data is not, it's first discovered in our lab. Right now, they have more than 500 papers about urine stem cells in the many labs globally. So they repeat as a result. We consistently show these cells show the telomerase activity. Actually, these cells show telomerase activity, the CD24 positive, CD133 positive. Why we need to emphasize that? Because this is a renal progenitor cells marker. Also, these cells, they have they can differentiate the different cell lineage, like we said, osteocyte, chondrocyte, myocyte, right? But also the cells have the mitochondrial the function. Then we'll talk about later. We can use this for the mitochondrial toxicity test. Also, these cells they express the trophic factor for the immune modulate. Also, these cells even express the telomerase activity, but there is no teratoma formation. It's safe for use, particularly for cell therapy. And like we said, the cells express low level of the ES cells, the marker, making the cells easy or more efficiently differentiate the iPS cells within the 2 weeks. But usually, skin cells takes the 3 to 4 weeks. Our efficiency for the iPS cells more efficiently. Yeah, but also the cell shows that the surface marker, mesenchymal stem cells marker, and the cells have proliferation and degeneration rapidly. So you may ask how many stem cells in the urine for 24 hours. We can generate about 100 to 150 cell colonies within the 24 hours. One urine sample, we can get about 3 to 7 cell colony in the 100 cc urine. So since we discovered this cells, it's more than 15 years. First 10 years, we worked on the use these cells for cell therapy. Then we working on use these cell induced iPS cells that form the disease modeling. And now we use these cells, try to use for predicating kidney disease or aging, kidney aging. Also, we recently, yes, we use these cells for drug testing, particularly nephrotoxicity. Now we talk about can we use these cells for the marker, and why we should need to go to the this US cells for biomarker. As we know well, so far we use the biomarker based on the renal somatic cells, means the cells is mature, right? They represent the currently renal function and the histology. They can recover, these cells can recover after injury, right? But stem cells are different. The stem cells, they represent the renal repair potential. Once these cells get injury, the kidney may suffer the irreversible renal function. So this is a serious problem. So this maybe is important for us to looking for use these cells looking for the renal function. Also, the cells we can get for in non-invasive, we say liquid biopsy versus the tissue biopsy. That's the reason we done this study about 5 years ago before COVID-19. So there's a big study, but I summarize what we found. We get the urine derived cells from diabetes nephropathy for 10 patients, and we use age-matched healthy people as control. What do we see? We see these cells, the patient cells, majority of cells still express the mesenchymal stem cells marker, which means mesenchymal stem cells marker cannot become the marker to see this cells good or bad, right? So what do we see? Generally speaking, we see generation capacity of these cells decrease and pathogenic factor go up. What's the generation capacity? There's Perkin factor, the plasticity, differentiation, proliferation, all this related to this growth factor, we checked that all go down, autophagy as well. This all, but the pathogenic factors like the inflammation, the cytokines and ROS and the apoptosis, that's increase. But recently, yes, we do the cell synthesis and mitochondria. We see that this is a young healthy donor, this is an older healthy donor, but this diabetes patient. Interesting, we can see at earlier passage, the cells in the before passage 4, Three type of cells is going well, it's fine. But if we culture cells longer, and they show different. Older cells, you can see the cells express the beta gear. Beta gear means the cells turn the synthesis. That's expressed. Also, the cells go slowly. That's a doubling time. The cells, both type of cells go slowly after 70 P7. This means the cells cannot generate too much. That's old patient cell, old healthy donor, and patient cells.
We're
Also,
running over time. Can you please try to wrap up? Sorry.
Okay. Yeah. Yeah, we done in the drug testing. We also found the PGC1 alpha is decreased. And we try to find is this PGF alpha the same pathway played a role. And take home message: this urine germ cells is the urine genetic come from the kidney. Also, we can get the cells from invasive way. Also, the cells they show the mitochondrial function mitochondrial dysfunction, telomerase activity go down, and also increase synthesis. Of course, then maybe we need to collaborate with urals to demonstrate to make sure these cells can use the earlier detection for the kidney disease and predicate the renal function. I stop here. Thank you. I appreciate this. My collaborator I also found. Thank you for NIDDK, particularly for NIDDK support this study. Thank you.
Great. Thanks for your talk. And then I think there isn't time for questions. So if the moderators can take us to the last speaker.
Sure. The last speaker of this session is Dr. Jane Wang. Dr. Jane Wang is a radiologist and the chief of abdominal imaging at the University of California at San Francisco. Her research program focuses on the translation of novel imaging techniques for evaluating abdominal diseases, with a particular focus on metabolic imaging of the kidney and the pancreas. So please, Doctor, please let's move on. Dr. Wang.
Great, thank you very much for the introduction, and thank you to the organizers for the invitation to speak here. So today I want to talk about our initial experience of hypopolarized carbon pyruvate MRI in kidney transplant patients. And we choose kidney transplant as our initial target investigation of hypopolarized MRI for energy metabolism and kidney injury because of this inadequacy of available imaging for detecting allograft injury. And here, just very briefly, we see two MRI images of the allograft. One is normal functioning and the other has rejection, and they both look normal on anatomic imaging. Allograft biopsy is the standard of care, and this includes surveillance biopsy for detecting subclinical injury, but it is not benign. It's associated with about 2% major complication and greater than 10% minor complication. And here just shows a big hematoma following allograft biopsy. So really, there's an unmet need for early identification of kidney injury, especially subclinical injury, to guide appropriate biopsy and hopefully to permit timely intervention. So this audience is familiar that the kidney is a highly energetic organ, and a pyruvate is a critical substrate in kidney energy metabolism. So here you can see that the pyruvate is metabolized to downstream products, including lactate in the cytosol via the enzyme LDH, or the lactate dehydrogenase. Pyruvate is also shuttled into the mitochondria and converted to acetyl-CoA via the mitochondrial enzyme pyruvate dehydrogenase complex in this first step of oxidative metabolism. And alteration in energy metabolism with a shift from oxidative phosphorylation to glycolysis and lactate production has been noted in native kidney diseases, such as the acute kidney injury and a chronic kidney disease.
And there's also evidence from molecular profiling of kidney transplant biopsy that there is a decrease in that PDH expression and associated inflammation, which mediates progressive kidney injuries. So this shifting metabolism actually can be ideally interrogated by hypopolarized carbon MRI. So carbon MRI is actually very attractive for metabolic imaging because carbon really serves as a backbone of nearly all organic molecules, and that allows the investigation of these biochemical processes relevant to kidney disease. And using a specialized technique called the dynamic nuclear polarization, or DNP, this C13 signal can be dramatically, though temporarily, increased to greater than 10,000-fold. And during this hyperpolarization process, there's this transfer of polarization from electron to the carbon nucleus, and then the hyperpolarized molecules can then be generated in solution for IV injection. And this dramatic increase in the C13 signal, as you can see here, this essentially a very small little blip, which is the C13 signal prior to hyperpolarization. And following the hyperpolarization, you can see this a huge signal. And this actually has been analogous to compare to turning a penny to a $100 bill, though it is temporary. And this does allow the rapid assessment of these physiologic and metabolic processes that are relevant in cancer, diabetes, and other diseases. So there are actually numerous hyperpolarized probes that have been investigated to date, and these are non-radioactive, and many of these are endogenous biomolecules that can provide these readouts, biological readouts, such as pH, necrosis, redox state. The most commonly or the most widely studied probe to date is pyruvate, which as we talked about, lies at this critical branch point of these metabolic pathways, and it has been applied to study cancer, ischemia, inflammation. So a number of years ago, we did this preclinical study in a murine model of ischemic reperfusion injury. And what we have seen is that in the injured kidney, we see increased hypopolarized pyruvate to lactate metabolism. And you see this increased lactate and concomitant reduction in bicarbonate, which is consistent with this shift from oxidative metabolism to glycolysis. And this corresponds to a significant reduction in the PDH activity in the injured kidney, and there is also higher staining for reactive oxygen species consistent with increased stress and oxidative stress and inflammation. So this motivated us to conduct our first hypopolarized pyruvate MRI in kidney transplant patients, which is funded by an R21 from the NIDDK. And we enrolled subjects with stable allograft function prior to their biopsy and their image on clinical 3T scanner with multinuclear capability. And we also compared to the imaging findings, compared to their biopsy, imaging findings to their biopsy findings. So here's just an example of a dynamic metabolic metabolite images. It is at a temporal resolution of about 3.5 seconds. You can see here the uptake of pyruvate by the allograft, the real-time conversion to lactate and bicarbonate. And in this initial pilot study, the spatial resolution is relatively coarse. It is, at 1 centimeter in-plane resolution for pyruvate and lactate, and about 2 centimeter in-plane resolution but for bicarbonate, just because the lower level of bicarbonate. And here are some examples of the area under the curve images of metabolites and metabolic ratio images in one patient with 2 repeated injection. And just as an example, that from these repeated injection, we do see similar lactate to pyruvate and bicarbonate to pyruvate ratio, suggesting repeatability. Again, of course, it's very preliminary. So far we have imaged 6 patients with kidney allograft. 3 patients had stable renal function. And normal findings on biopsy, one patient had stable renal function and moderate microvascular inflammation. One patient has stable renal function and a low grade IFTA, fibrosis, and another patient actually, unfortunately, did not end up getting a biopsy due to a concurrent illness when he was scheduled for the biopsy, but this patient did have a delayed graft function and a relatively lower EGFR at the time of the MRI. So here are examples of the lactate to pyruvate map in the 6 allografts, as well as from a native kidney from a healthy volunteer from a separate study, but they're acquired with the same imaging technique. And we can see here for the allograft 4 and 5 with biopsy finding of inflammation and fibrosis, the lactate to pyruvate ratio do appear slightly higher than the allografts with normal biopsy. And the highest lactate to pyruvate ratio is in this patient allograft 3 with a history of delayed graft function. And unfortunately, again, this patient did not undergo biopsy due to he contracted COVID. And this table shows the numerical data for the lactate to pyruvate ratio in the 6 kidney allografts and in 5 native kidneys from a healthy volunteer. And we can see that the pyruvate metabolism to lactate in these patients with well-functioning allografts and normal biopsies are actually in the range of healthy native kidneys. And the lactate to pyruvate ratio from the 2 allografts with abnormal biopsy are higher than the allografts with a normal biopsy. And again, the ones with delayed graft function has the highest lactate to pyruvate ratio. Again, very preliminary result, but we do see that this imaging is feasible in kidney allograft patients. And we are doing a lot of ongoing technical development to further improve spatial resolution so that we can more confidently distinguish between cortex and the medulla. Initial data do show well-functioning allografts with normal biopsy had metabolism that's similar to the healthy native kidneys. And of course, we're looking at more patients to establish that range of normal metabolism and correlate the metabolism to biopsy findings. So I want to end here and just, again, thank the funding agency and acknowledge the very large team of investigators here at UCSF at our center. Thank you.
Thank you very much, Dr. Wang. We're really out of time. I don't know, Dr. Prasa, do we have time for a question or would you like to?
We could do a quick question. I had put in a 10-minute buffer, really aiming to end at 4, which I think we'll do with the wrap up. So just if there's a quick question or two.
So there was a question online with regards to comparison to C11 metabolite tracers with PET MRI. How does the HP MRI resolution compare to C11 metabolite tracers?
So the question is, how does it compare to PET MRI? Yeah, so the PET definitely has much higher spatial resolution at this time point on the order of millimeter, where right now for hypopolarized MRI is on the order of centimeter. The advantage of hypopolarized MRI is that you can look at dynamic metabolic conversion. So for the PET tracer, what you're looking at, for example, FDG PET, what you're looking at is the trapping of the substrate in the tissue. And you don't see the downstream metabolism, which is what that information is available with hypopolarized MRI. And so I don't know if that answers the question. Certainly the spatial resolution for PET is higher compared to hypopolarized MRI at this point, but it is through technical development, especially in some diseases where we actually have gotten the resolution, for example, for prostate hypopolarized MRI down to the order of millimeter, 4 or 5 millimeter resolution.
Right.
This, yeah, fits the last question maybe. How long does it take to get the results?
So the imaging, so the preparation for the pyruvate, the hyperpolarization process does take some time. It takes about a couple hours, 2 to 3 hours. And the imaging, actually, these are very rapid imaging. So we've developed the process where the imaging takes about a minute. And then the processing right now, we do have more automated processing that takes about on the order of, I would say probably 10 to 15 minutes, but it does require, specifically written scripts to do the processing. The idea is really to make the processing much more automated so that it could be more readily done by people who don't, have the expertise. And we have these processing scripts that are actually freely available at our site for people who are doing these type of studies. And right now there are about, I believe, 15 or 16 centers around the world who are doing clinical studies with this technology. Most of those are in oncological cases, but there are more applications in non-oncological cases, such as kidney disease. Heart disease is another main one.
Okay,
Thank you very much.
With that, we're going to have to close the session. Again, thanks to everyone for this. And now I'm going to turn it over to Petter for a wrap up of the day. Petter, you're up. Oh, so you're not allowed to unmute. John, I think, oh, there we go.
I think now
Yeah.
they made, yeah, sorry about that. Let's see. All right, so thanks everyone for really an excellent first day with really fantastic talks and really great discussion. So really look forward to tomorrow. So I've been tasked with wrapping up the first day. This should not take more than 5 minutes. All right, so I wanted to recap the objective of this workshop, which is really to broaden our understanding of kidney function beyond GFR and proteinuria. And this is to address the need for a comprehensive approach to assess kidney function and dysfunction. And the workshop's goal was ambitious, to initiate a paradigm shift in renal assessment. And I saw that Jay was smiling because I did copy his picture and quote from SUS, which I think is really elegant. We need tests as elegant as the kidney itself to understand how the kidney is and is not working. And I think that perfectly sums it up. So I wanted to briefly mention the agenda for day 2. So day 2 is really going to be focused on group discussions. And there's going to be 4 concurrent breakout sessions. 1, glomerular filtration, 2, tubular function, 3, perm selectivity, and then 4, renal reserve capacity. So really aligned with these sessions we had on day 1. The objective for each group is to identify next steps, developing new techniques, and finding novel biomarkers. And we strongly encourage participation and collaboration in these breakout sessions. We also kindly ask that you may consider joining perm selectivity and or renal reserve, as we anticipate fewer participants in these breakout sessions compared to glomerular and tubular function. This is a brief overview of the agenda. So we'll start at 10 a.m. Eastern Time. It will be a brief recap by Susbaikar and myself, and then we'll go into the concurrent breakout sessions. And you can see here, again, Group 1, glomerular filtration, Group 2, glomerular perm selectivity, Group 3, tubular function, and then Group 4, renal reserve, after which there will be a lunch, and then a summary of individual breakout sessions and questions and answers by the moderators from the breakout sessions. And then Dr. Starr will put it all together and we will adjourn. Some closing remarks and call to actions. So we encourage all to reflect on the great talks and the critical insights provided during day 1, the urgent need for enhanced kidney function assessment methods, And then we urge everyone to actively participate in Days 2 sessions. We really need collaborative efforts to bridge the gaps and tackle challenges identified throughout the first day of the workshop. And then I'd like to end by thanking all the speakers, moderators, attendees, and organizing committee, NIH, and the scientific consulting group for logistics. And I look forward to seeing you all tomorrow.
All right, well, welcome back, everyone, and thanks for joining us on day 2. I think the first day was a great success. Sus and Petter are going to offer us a nice recap before we enter the concurrent breakout sessions. Today, even more than yesterday, everyone, please, as much as you can, have your cameras on. This is where we really want to get broad input from everyone. Questions, thoughts, opinions, and the goals of the breakout sessions there. So I will now turn it over to Sus and Petter for our recap.
Thanks, Afshin. Everyone can see the screen okay and hear me? Welcome back to those of you who are joining us for day 2 of the NIDDK workshop on reimagining kidney function assessment. And to those of you who are here for the first time, welcome. Today we'll be breaking out into smaller groups to delve more deeply into some of the topics that were brought up during yesterday's talks by our fantastic speakers. What I will do is begin with a recap, just to remind us about what we heard yesterday, and for those who weren't able to attend all the sessions, just to hit on some of the highlights.
Sus, the next slide is showing up on this. I don't know if that was intentional or...
Sorry about that. Let me just see.
Yeah, just swap your displays up in the top middle.
Okay, is that any better?
Yes.
Yep.
Okay, great. So we began the day with Dr. Parsa, who had an ode to our amazing kidneys and all the functions that they do. He challenged us to broaden our understanding of kidney function beyond just GFR and proteinuria, emphasized the need for a more comprehensive approach to kidney function testing, tests that are as elegant as the kidney function itself. And Dr. Starr challenged us to think about what does the future renal diagnostics cart look like when we bring in a diagnostic cart to our patients in the future. What all tests are going to be part of that? And this workshop's ambitious goals are to initiate a real paradigm shift in renal function assessment. And to do that, we invited outstanding speakers to talk about various aspects of kidney function and disease. Our session, the first session, was on measuring tubular function by Drs. Jay Coyner and Brian Kestenbaum. They reviewed the kidney tubules' role in solute secretion, implications for drug clearance and protein-bound solutes. Dr. Kestenbaum talked about tubular function biomarkers as a way to improve risk stratification, and also to talk about kidney drug clearance and how it may relate to tubular secretory capacity in addition to just GFR. Dr. Coyner brought us an update on the furosemide stress test. This is a pharmacological challenge that incorporates and tests the renal blood flow and tubular secretion. This is primarily used in acute kidney injury. Dr. Coyner also talked about how biomarkers may play a role in addition to the furosemide stress test for risk prediction in acute kidney injury. Our next session was by Drs. Jesse Siegmiller and Leslie Inker, experts in glomerular filtration assessment. We began the session with a historical dive back into one of the original papers on inulin clearance by Homer Smith. Dr. Inker talked to us about the concept of true GFR versus measured GFR versus estimated GFR. We reviewed biological variation and the need for standardized assessment in GFR assessment. We also talked about limitations of our current GFR measurement techniques and the push for innovation and the need for enhanced assessment of measurement accuracy. For example, there's an iohexol consensus paper that will be published soon that we were treated to a sneak peek of. And then in general, they talked about key clinical and scientific gaps in GFR assessment. Our next session was a very interesting session on glomerular charge and size selectivity, led by doctors Kevin Lemley and Thomas Benzing. They reviewed the old literature as well as more recent literature on perm selectivity and evidence for the possibility of two distinct mechanisms for albuminuria. Dr. Benzing in particular talked about the molecular architecture of the kidney filtration barrier, the role of podocytes, and the predictive value potentially of GFR, assessing GFR filtration permeability on CKD beyond just albuminuria. And both talks underscored the complexity of the filtration barrier, the need to understand why people develop albuminuria early versus later in the disease course. Are there distinct mechanisms? What governs the appearance of albuminuria? And they called for research into novel biomarkers and technologies to better understand and estimate and measure glomerular perm selectivity for early disease detection and potentially treatment optimization. Our next talk was by Dr. Dana Furman, who talked about glomerular filtration rate, capacity, and reserve. She introduced us to the idea that GFR is not a static phenomenon. It's a measure, it's a physiological parameter that can change in response to metabolic demands. So this concept of stressed GFR versus resting GFR and the difference being the renal reserve has been a topic of interest in her research. She introduced us to the concept of it, talked about some of the methodological challenges in measuring renal functional reserve, and discussed her current project involving protein meal prior to cardiac surgery for assessing the kidney's ability to respond to physiological stress, in this case, cardiovascular surgery, and how the renal reserve might be a window into that. She also talked about the possibility that it could work as a biomarker to predict risk, and also talked about emerging technologies that might be able to assess renal functional reserve in a more simplified manner. So this is an example of a paper on ultrasonography and renal resistive index for assessing renal reserve. So all in all, we had tremendously exciting talks. They were scholarly, they were clinically relevant, and they really challenged us to think creatively about the future of diagnostic testing. I'm going to turn this over now to Dr. Bjornstad to talk a little bit about the technologies lightning talk and what we are going to do for the rest of the day. And Petter, I can move the slides ahead for you.
Perfect. Yeah, I was just going to ask you, Sas. Thank you. So in addition to the larger talks, we also had some fantastic lightning talks that I think spawned a lot of interests and really showcased innovation. And they included novel data, reviewing MRI autoregulation, that non-contrast 10-minute MRIs could really map kidney fluctuations, as well as data on transdermal GFR measurements, which are real-time, non-invasive GFR assessment using fluorescent tracers, and also really convincing data independent of skin tones, which is important, and data quantifying renal hemodynamics, novel MRI methods for assessing renal blood flow and function, enhancing safety for patients with kidney impairment, and then really some novel chemistry with nanoparticles for kidney function, utilizing gold nanoparticles for non-invasive imaging and diagnostics, and also stem cells as potential biomarkers, exploring the use of urine stem cells in chronic kidney disease diagnosis and management as sort of a liquid renal biopsy. And then also hyperpolarized 13C MRI as a way to investigate renal allograft metabolism, especially pyruvate metabolism, for non-invasive monitoring of kidney health. And next slide. All right, so today we are going to have the breakout sessions, which has been mentioned a few times. They will focus on glomerular filtration, tubular function, perm selectivity, and renal reserve capacity. And the task for each group during these breakout sessions is to identify next steps, develop new technologies or techniques to address the gaps, and also finding novel biomarkers. As mentioned yesterday, we really encourage participation and collaboration in the breakout sessions. And then we also have a call out that some individuals please try to join the perm selectivity and renal reserve, as we do anticipate slightly fewer participants in those sessions. Next slide. The breakout sessions will be 90 minutes in duration. And again, we really encourage verbal participation and also having the cameras on. Participants are free to choose whichever group they're most interested in or feel they can contribute most meaningfully. There's a Google document link, which will be shared for real-time input. And then moderators will guide the discussion, with one moderator primarily directing each question while the other capture comments for the reporting back at the end of the day. Next slide, please. So this is the groups. So group 1 is glomerular filtration. As you can see here, group 2 is glomerular perm selectivity. Group 3 is tubular function. Next slide. Group 4 is renal reserve. And then after the group sessions or breakout sessions, there will be lunch. And then we will summarize the individual breakout sessions and have a Q&A from 12:20 to 1:30 p.m. Eastern. And after that, Dr. Starr will be putting it all together, and then we'll adjourn. Next slide. So in terms of the reporting back, as mentioned, they're scheduled after lunch, which will allow time for preparation. Each breakout session will have 10 minutes for presentation and then 10 minutes for a Q&A. Moderators can decide whether to have one person report back or split responsibilities. And we also encourage previous day speakers to contribute during the reporting back to address any audience questions, since these are the topic experts. Next slide. So some closing remarks and call to action. Again, the nice summary provided by Saswai Kar. Please reflect on some of the critical insights and teachings from yesterday and the urgent need for enhanced kidney function assessment methods. Again, I want to stress that we encourage everyone to actively participate. We really need collaborative efforts to bridge the gap and tackle challenges identified throughout the workshop. And we encourage contribution towards achieving a paradigm shift in the classification and treatment of kidney diseases, aiming for more precise and patient-specific approaches. Next slide. And then, as always, we thank everyone.
Great. Well, thank you, Stas and Petter, for a really outstanding recap. You really hit it on with all the key points. Never an easy thing to do. Okay, so it's 12:21, meaning we're 1 minute late, fashionably so. Thanks again for everyone who's been sticking around. I know it's been a long 2 days, but hopefully you've been having as much fun as I have. At this point, we're going to now turn over to the breakout reports. Each group will have a 10-minute allocated time for the report, and then 10 minutes we have for questions. Everyone, again, please turn on your camera, especially for these interactive groups. It makes it more helpful. As opposed to earlier, everyone can has the ability to speak. So raise your hand, ask questions. Again, the goal of this is really to solicit input from everyone, which is you. So don't be shy. And with that, I'll turn it over now to group 1, which was glomerular filtration. So Andrew and Chi, you're on.
Thank you. Yeah, I think that I would be mostly responsible giving the report back to everyone. I think we had a great session. So I think everybody agrees that GFR or eGFR and albumin are sort of central important parameters. I think that, as I understand, when Afshin and I spoke, one of the purposes of this conference is to go beyond sort of current state of affairs, and that includes beyond GFR to look at tubular function or reserves, but our group still focus mostly on GFR. And when we start, I think one way to start this is to look at the state of the art in terms of measured GFR, right? Because measured GFR is the thing that we do to be used as a gold standard to derive equations, for example. And I think with the GFR, I think it breaks down into 2 parts, which I will separate out. One is the conceptual bits and one is sort of the practical bits. So let's start with the practical bits first. I think the practical bit, there was a general feeling that the current state of affairs is unsatisfactory because we have many different ways of measuring GFR and they don't give the same answer. This is because we have, urinary clearance or plasma disappearance. We have different filtration markers, exogenous filtration markers, and they have different assumptions. For example, volume distribution, there's trouble with collecting the urine consistently. And so the protocols vary. The emphasis was made that it was a protocol variation that varies more than the analytic variation, for example, measuring creatinine or vitamin. And also time of day. This is a big point that was brought up and emphasized that because it's known diurnal variation, currently the measured GFR is measured over, different time periods, some more UV over peak collection than others, and doesn't really handle time of the day. So, and then I think the other piece of it is a conceptual one, which is that we know that we want to measure true GFR, ideally, which is not observable. We have measured GFR, and perhaps measured GFR is better recognized as a reference standard and not some sort of gold standard. I think a minority, so we not sure we come up with complete consensus, but I think there was general agreement there was things which can be improved upon. We can improve standardization more. I think there's some disagreement about how much work this would take and whether the juice is worth the squeeze, so to speak. But I think the general consensus, and others can please chime in, so my own bias don't creep in here, that better standardization is possible and desirable. Then I think we talked about potential new steps about what do we do about this. And I think that there were some very innovative techniques and ideas that came up. One was to take advantage of people who are getting 24-hour infusions, for example, Flowland, and they're getting the infusion anyway. Maybe we can put in an exogenous filtration marker and measure kidney function that way. There was in whom maybe particularly important, or children in whom it would be difficult to get time urine collections, and idea about people with different body compositions. Conceptual breakout wise, there was other feeling that maybe instead of using measured GFR as a gold standard, we should use sort of outcome like drug level dosing or adverse consequences of kidney disease as the outcome, but this was acknowledged to be very difficult to do. I should highlight that everybody should be able to see our Google document that summarizes a lot of these concepts in it. And we ultimately, I don't think, and Andrew, you can chime in, I don't think we came up with an obvious consensus. There was more consensus about the problems that exist and less consensus about how to move forward. Because obviously we are in the situation we are in for a good reason, because of various practical limitations about how to move things better. We thought that new techniques such as that from NIDDK sounds promising, and then the things mentioned in the subsequent sessions. But a lot of thought and effort has gone into GFR measurement estimation. So in a way, this is a more mature field compared with some of the other breakout sessions. Others, my co-moderator, Andrew, do you have anything to add? Or certainly other members of the group who were there, including Afshin and others.
Gee, that was a nice summary. The only thing I'd add is that we were discussing standardization, and there's the European Kidney Function Consortium, this past year worked on a consensus document for plasma clearance of iohexol, and even in that single test, there's some challenging issues and different approaches that are still ongoing challenges, but at least we have tried to put these all into one document with some recommendations. And it's viewed as a place to start. One of the challenges is it doesn't seem like there's one approach to measuring GFR that works well in all settings. The gold standard markers that are being used, like inulin, are not available readily. IELTH elements off the market. So there's a number of challenges that were brought up, but I think the thought was that we need something for urinary clearance because it's fast and it's clinically convenient. We need something that works well in children, and so there's some starting work in it that maybe can be built on, but it's not by no means the end. And trying to come up with some consensus approaches to measuring GFR for a variety of purposes, but trying to figure out how to make them as standardized as possible seemed to be the general gist of what I thought we could agree on.
Yes, Andy. Levy, sorry.
Hi. Nice summary, Chi, and thank you, Andrew. I wanted to make a conceptual comment. There were a couple of times during our breakout meeting that the question was posed, should accuracy regarding measured GFR be what's most important, or should it be how well it predicts outcomes? And I wanted to make the point that predicting outcomes goes beyond kidney, right? Predicting who's going to get hyperkalemia has a lot to do with dietary intake, right? It has a lot to do with other drugs. Predicting mortality has to do a lot with non-kidney conditions. When we talk about kidney function, GFR is really good because it's a kidney function, right? And so bypassing GFR accuracy and going on to how well do different filtration markers predict outcomes, I think is ignores a step that we can actually do better with. And I just wanted to make this conceptual point that once you start to predict outcomes, you've gone beyond the kidney. And although clinically, the clinician wants to be able to predict outcomes, but if you want to assess the role of the kidney, then you have to look at something that's affected only by the kidney. And GFR fills the bill for that. It's not the only kidney function, as we've talked about, but I just wanted to make the point that I would not go to the paradigm to use prediction of outcomes as the only way to evaluate a biomarker.
Thank you. Yeah, I think the context for this was a discussion that, which partly I brought up would be, why do we care to know this parameter, which is a really important parameter, I think. And a point that I made was that you don't need to know someone's cardiac output exactly to the mils per minute to do a lot of things, right? And whether or not, is it more important, was the question I raised, whether or not you know someone's kidney function so you can predict the risk of kidney failure or hyperkalemia, all which are influenced by other things, certainly. But how accurate does one need to do to get to that point is, I think, the context in which we discuss this. So Gary, you had your hands up?
Yes, thanks very much. And really appreciate all the comments that have been made. I think that from a drug development point of view, it's very, very challenging currently, as we all know. And so whatever pieces do come together out of these types of discussions, obviously we're going to have to be discussing these closely with FDA and EMA to make sure that they're validatable endpoints. And so that's the kind of the lens that I'm looking at all this information through. And not coincidentally, I see Eliza Thompson has her hand up. So thank you.
Yes, Elisa, please.
Yeah, and I very much enjoyed hearing the discussion and overview. I think fundamentally, when, as relates to Andy's comment about sort of what's the goal here? I mean, from a drug standpoint, often what we're trying to use the assessments of kidney function to do is for renally clear drugs to figure out how to estimate, and figure out sort of what dose of a drug to give, which becomes very critical when you're dealing with drugs with narrow therapeutic windows. So from our perspective, often what we really want to understand, and we understand GFR may not always answer everything. There could be tubular secretion, but we're not looking for something that's an estimate of how you're going to do. We want something that's the best estimate of how the drug's going to be cleared, which, would be more akin to measured GFR than predicting your course of the disease.
Right, that actually certainly came up, the drug dosing. The discussion comment was made, I think it's in our Google document where we actually deleted the names, we decided, was that, as we learned in the other session, like tubular secretion is very important for drug clearance more than filtration. And a suggestion was made whether or not we should look at the drug level. And that is another way of approaching what to define renal function, right? There was a mention that cystatin C eGFR may predict vancomycin troughs better. And that would be an argument that that's a better capture of quote unquote kidney function than eGFR creatinine because it predicts drug levels better. And can we use drug levels as a way of getting to almost use the drugs as a exogenous filtration marker or marker of clearance in some way, right? As a out of the box different way of thinking about this. Because if what we really care about is how do I dose a drug? Kidney function, which is more than filtration, shouldn't we just go there? Which then came to this other aspect of our discussion, which is the fit for purpose kind of idea, right? Is that do we have different concepts of kidney function or different measures of kidney function, different reference standards, depending on what the purpose is? Is the purpose to predict outcomes or to dose drugs? And these might require different answers rather than a important physiological parameter of glomerular filtration, which we all agree is central, right? As the question is, should we think about it in a more multifaceted manner? Natalie, please. You had your hand up.
Yes, just to follow up on what Andy said, because I think that's a crucially important point. We tend to mix up prediction of disease with prediction of GFR, and many people who've been working in this field still, I think, mix it up. And Andrew put it very nicely. And I think if we have the means, and we're convinced we have the means to reduce error in the way we measure GFR, why not do it? I think there's no reason not to do it, to use the standard. I mean, we need some kind of gold standard to look at, and we know what we use right now has many flaws, and we can fix those flaws. Why not do it? I don't really see why not.
Joe?
Yeah, I put in the chat 5 points, but I'll maybe emphasize one. I completely agree that this whole tenet that kidney function has many functions and we need to look well beyond GFR is completely valid. But I also would challenge us that too often some of our best markers that are sort of novel and new are incredibly correlated with what we estimate to be GFR, like the soluble TNF receptors, et cetera. So I think having better estimates of GFR, particularly in the multi-omic panels, et cetera, will help us not go down rabbit holes. And then I think we'll need causal experiments to sort out this idea of filtration markers versus things that mark filtration but are also toxic and maybe called uremic toxins. So I think we need to distinguish those two. And then the final point is, right, I think estimated GFR from creatinine we've spent decades on, that may be the best we can do with a 10-cent test. I think the idea that we want to stop at a 10-cent test for a key parameter, I think we need all the other parameters, but this one is worthy of optimizing as well.
Thank you. I think we have 2 minutes left for those who were in the group or not in the group to chime in.
Following up on Joe's point, it's always about trade-offs. And, you know, again, for what purpose? How much more are we willing to pay to be better than creatinine-based estimated GFR? And, you know, I think someone said yesterday, I think it was Leslie Inker, I think she landed on she's comfortable with it. We know what the limitations are. And I kind of agree with that. I don't think that, you know, getting to a different, more accurate estimation equation for GFR, when also, again, measured GFR or creatinine clearance is prone to error as it is. So it's a very problematic gold standard. I'm just not convinced that, you know, for the cost and convenience and the standardization of creatinine, that is it, you know, how much is it worth trying to get a more accurate estimate of measured GFR through estimated GFR?
Yeah, well, you can tell we completely, if I had to take a toxic medication and I knew that because of my weight loss, the estimates are off by 50%, I'd definitely pay more than 10 cents.
And
there are plenty of diagnostic tests that are in the $100 range that are done with a lot less value.
And also conceptually, one question we've been asking is really not just how to, or so much improving eGFR based on current measured GFRs, but it's really better capture of GFR, which means getting measured GFR closer to true GFR in any ways that we can, and what are next steps and what are gaps and how we might be able to reasonably improve upon that. And I think a lot of folks in the group and other places have felt that there is room for improvement.
But Joe, back to your point though, maybe different drugs are cleared differently. And maybe GFR, which is this absolute physiological parameter, only accounts for 10% of variation. And most of the variation comes from your OAT2 genetic variation. And therefore, getting a better measure of measured GFR may only minorly contribute to improved drug dosing. Maybe you're better off trying to spend money measuring the level of the drug, rather than indirectly inferring what the drug level would be by measuring a parameter which may only have a minor contribution to the actual clearance of the drug. Because as we heard from Brian Kestenbaum and others, and I think we'll talk about this, a lot of drug clearance is tubular secretion, right, and not filtration. There is a correlation, of course. Leslie and Alicia, and I think we should finish.
Yeah.
Let's go over this.
I'm just thinking about Joe's point from 2 comments ago. I mean, it's just interesting, the idea that, you know, the more accurately you can measure a parameter, the more correlation you're going to get with its functional other measurements. I mean, it could be true in other organs too. If you could measure ejection fraction, I suppose, you know, truly accurately with the best Dopplers, you know, to the 3rd digit, you would infer in there, you would infer information about other cardiac functions as well. I'm just not sure if that's the goal. It does certainly happen. It's just interesting to think about that. I mean, it's true, as you measure GFR better and better, you are going to, you know, pick up some of these other functions, but I'm not sure are we trying to do that?
So Leslie and Alicia, and then I think we can move on to the other group.
Yeah, I just wanted to, you know, you asked the question. I think these are good questions, which we should, as a research community, address. You know, drug levels are not easy. There's all the variability we're talking about in iohexol. What happened to drug? And there are many different drugs in many different labs. So I don't know necessarily that is there, but it's a research question. And I just want to acknowledge that some of the things we're going to talk about we can implement, and some of them are really a research agenda, and we shouldn't decide, but we should ask the questions.
Alicia, and then sorry, we're running over.
Yeah, and maybe just from a drug dosing perspective, would agree that we have imperfect tools. And I think it goes back to sort of Joe and his comment about sort of, if you're someone in whom sort of the estimating equations don't work well, I would say we just don't have really a good toolkit, that most people don't live near centers of excellence where they can get a measured GFR, you know, and so I would say that there's very much unmet need, and would also say that therapeutic drug monitoring, meaning you have to pull someone into clinic and have a PK test that can be run and rapidly turn around and tell you what level they are. I would say that's not sort of where I think most people want to go with drugs that are developed or is really practical for the vast majority of people who have disease and have to take drugs. But thank you and great job.
Thank you. Afshin, we should move on.
Yes, thank you. Thanks again for a great discussion. I know we could go on for quite a bit longer, but unfortunately we have to keep to our time. So now we're going to shift it over to the glomerular perm selectivity session, and I'll let Denise and Petter take over.
Thanks. Okay, so Petter and I put together a couple of slides. We had a really great and interactive discussion on this topic. Petter, do you want to go to the next slide? Okay, so the first point, identify conceptual next steps to assess size and charge selectivity. I think one of the points which is not represented actually in this slide is that there's actually still a lot that's unknown biologically. So to the extent that probably more basic research on animal models is required, and what models we would use, that sort of thing was a part of our discussion. But in terms of this discussion, it's a very complex thing that basically it's multimodal. There are mechanical forces at play, the role of partial or full podocyte detachment, the role of the GBM, and the fact that there's going to be variation over time due to hemodynamic stresses. So in that sense, it's a complex problem. We discussed the idea of using dextrans, which are linear molecules. We've all, and this was brought up during Kevin's talk, it's a very cumbersome process. So it likely would have very little clinical application, and it might be more appropriate for clinical research application right now, just in terms of, again, going back to gaining more mechanistic insight into the biology. We also mentioned FICOL, which is more spherical, but still at this point has limited application in clinical research due to safety concerns. I think the one sort of possible next step that we spent a lot of time discussing was gold nanoparticles. Dr. Zhang joined our conversation for this, and it has a lot of potential because it can be used to address a lot of different research questions in addition to just the size selectivity. And there's the ability to use different sizes, different charges, the fact that different sizes have different endogenous fluorescence, so you could potentially use bandpass filters to detect the different particles. If, for example, you're injecting multiple different particles at once, you could then use that endogenous fluorescence and try to quantify relative fractional excretion. So we thought this one has potential. The toxicity, based on the talk we heard, is low, but again, probably more would need to be done on that as well. Okay, next slide. Okay, so proposed next steps to develop established practical techniques to assess integrity. And so for this one, we focus more on talking about Tomas's recently published papers using ultra resolution. So pretty much any fluorescence microscopy based technology we think would be preferred over transmission EM or other EM modalities at this point, just due to the fact that you can sample larger size and that there's potentially better quality of the actual samples that you would be examining. Then you could use those ultra resolution images to perform machine learning, get various parameters like the length of the filtration slit, the number of podocytes, the thickness of the GBM. All of this can be extracted from that data. We also talked about potentially using the role of transcriptomics, proteomics, metabolomics for further mechanistic insight. And we focused a bit on talking about urine proteomics, what the limitations were in terms of intra person variability, the variation that that all of these urine proteomics studies basically have had until now. And with all of these, we thought that because they're even if you have semi-automated or automated assessment of these parameters, for example, with machine learning, it's going to be very labor intensive. And we thought they were potentially more useful for research studies. So for example, protocol research biopsies than for clinical use, at least at this time. Okay, so the next one, propose how to identify novel biomarkers. We talked a little bit just about using, for example, the clearances of different size proteins, endogenous proteins, for example, as one potential. And then using paired blood and urine, you could calculate the clearances and potentially use that. But again, that gets back to the highly variable nature of using urine from different individuals as a measure. We thought that capturing glomerular receiving coefficient, that right now there's a lot of limitations to the current modeling, and it's not quite clear how much they represent physiology. So we don't think at that point, at this point, that would be our best option. And then again, so the promising novel approach, I think that our group felt that the gold nanoparticles were the most promising, and that they may actually have clinical application in the near future for the reasons that we discussed previously. Thanks, Peter.
Denise.
Okay. So, do you want to, Peter, stop sharing?
Sure.
So that way we can see. And we can field questions or comments, if anybody has any.
Anyone else from the group wants to comment or put in their perspective, this would be a great time.
Less popular than GFR.
Or it might be that similar to me, less knowledgeable about a topic.
I think we have a question from Sus.
Oh,
Yeah,
Seth.
thanks for that overview, Denise and Peter. I wonder, did the group talk about, what are the downstream clinical applications for knowledge about perm selectivity? Like if you had a super resolution window into someone's GBM and their foot process effacement, what would you do with that information on an individual level or even on a population level?
We didn't actually address that, but I guess the idea would be whether it could be predictive in early stages of kidney disease, for example, before you have other parameters that may be indicative. But yeah, that was not something we talked about. Peter, do you have any thoughts on that?
Yeah, or Sus, or could it potentially delineators identify a distinct mechanism that could be druggable or more for precision-based medicine, and but again, we didn't discuss that, unfortunately. I think it's a great question. We just ran out of time.
Gary?
Anyone from the group wants to answer that question, even if it wasn't discussed?
Yeah.
So I would like to point one thing we discussed before. Currently, we majorly urine protein and serum creatinine. And there's a few studies looking for the cellular level. And we found that from the urine from diabetes nephropathy, now more podocytes shift off. But usually the podocytes is old, dead in the healthy condition. But in the diabetes nephropathy, those cells are alive, they can culture. So more cells there. So maybe we can think about that number of the podocytes, the live podocytes, maybe it's injury, not dead yet. Maybe it's represent the glomerular integrity, one of the issues we can looking for from the cellular level. Of course, we can use this for proteomics and other omics, but for this cellular levels, it's easy to identify it. Just on the microscope, do some staining, then we can see number of stem cells, number of the podocytes there.
Right.
Option, it's Gary. Can you hear me okay?
Yes.
Yeah, following on the comments of what Denise shared and what Yuan just shared and others, it feels very often that, GFR to us is looking at a giant black box. And getting down to the granular level, there's something about seeing, and the imaging that was discussed and just re-raised here, looking to see if there is a change over time, meaning during the period of acute treatment, between 1 and say 6 weeks with any agent, whether it be corticosteroids or something more sophisticated. Having more and more of these tools, and then looking at what was just mentioned, the shedding of cells, and seeing if there is something regarding those cells in the secretome coming out of them. There needs to be this more than just a black box GFR look. We need to be able to look segmentally at the kidney. We need to be able to see from the cells being shed what the secretome is doing. And yes, this is going to be more work, but fortunately we do have better techniques right now in terms of data digestion, that this can happen in essentially real time as we look in a concentrated fashion at all of these aspects on a small group of patients to see if we can begin to discern a pattern. Thank you.
Agreed. Other questions?
Kevin has a question, I believe, or a comment.
A comment, and it's in terms of shedding cells. Masanari Hara, from whom I learned to look at urinary podocytes, he started in the 90s, had very good study, basically looking at, and they were kind of more a semi-quantitative podocyte shedding in IgA and HSP, and having it predict outcomes. And that was from decades ago with fairly primitive methods, but just the number of podocytes that show up. And again, our model would suggest that's completely to be expected, but he has actual data from a specific disease. And I think he showed difference in sclerosis on dual biopsies in HSP that was explainable by the amount of longitudinal podocyte shedding that went on between the biopsies. So something's been done before actually on that.
And there's lots being done on that now, we know from various researchers all over the planet. So thanks for that comment.
Owen, do you have a comment? Question?
I just wanted to bring up the conversation around proteins of different size, different charge, and the gold nanoparticles, or really any marker that could potentially be used not just to determine level of glomerular, gross function like GFR, but to actually get into, what if there was a way where based on a certain marker, you could say, oh, the glycocalyx is messed up versus, oh, the podocytes are at partial foot process effacement, or the GBM, certain components of the GBM have broken down based on what comes out of the glomerulus. So whether that's an endogenous or exogenous product, I think what's really important is the function of the tubule in reuptake, because for each of those proteins, let's say, the tubule is going to take them up in a different manner, and so you're not just looking at what comes through the barrier, you're also looking at how it gets taken up. And so I think, especially like when we are talking about renal reserve, and I don't mean to, jump the boat here or jump the bus, but like there's you do a protein challenge and that increases GFR very significantly. So the question that arises to me is, okay, so proteins are, you have increased GFR, you might have increased protein leakage. What are you, there's a lot of different factors that are going on, but likely the tubule is taking it up, it's taking it back. So I'm merely just sort of trying to build connections between these different aspects, because I think as a mathematical modeler, which is, my background, we assume that protein doesn't ever leak through the glomerular capillary wall. That's one of the primary assumptions when you do mathematical modeling. But of course, there's proteinuric conditions, but then, there are some proteins that are going through the wall and they're getting taken up by the tubules, even in health, from what I've heard. But then there are people that disagree. So I wanted to kind of bring this up in the context of glomerular perm selectivity.
Thanks, Owen.
Yes.
It was mentioned briefly yesterday in one of the talks. Might there be more thoughts about the potential of other either endogenous biomarkers being studied via the studies that was already mentioned, like KPMP, that are doing biopsies to come up with biomarkers, if you will, of perm selectivity, and like EGFR that might not be perfect, but still provide a window into an area that's of relevance, as we saw by the nice data that Dr. Lemley showed yesterday. Any?
We talk about it a lot here where the KPMP is based, but we talk a lot about, the idea of a physiology version. And the KPMP is really the genetic and cellular encyclopedia. But there's, there are all these physiologic challenge tests being discussed here, from pore size to secretory capacity, to osmolarity regulation, and that area of phenotyping, combining that with KPMP would be pretty incredible.
So in the single cell transcriptomic data sets in KPMP, there definitely seems to be in the disease state groups enhanced predicted activity of reuptake, like protein reuptake, vesicle reuptake. There are pathways that are enriched that are showing up clearly in some proximal tubule cell subtypes, probably a little bit in TAL as well. So yes, as we sort of do this, we'll keep an eye on to see what kind of reuptake processes are upregulated in disease state. Sort of this is ongoing, but it's starting to show up, those markers.
I would just comment that we can worry about new markers and trying to sort all this out, but we ought to sort out what's happening to albumin, since albumin's being reabsorbed by the proximal tubule also, and we have no sense really of how to actually measure the absorption of versus the filtration of albumin. And albumin's a very, very sensitive biomarker for proximal tubule injury. So before we try to then venture into some new, more exotic markers and how they're going to give us information, I think if we understood albumin, it would be a good starting point.
There have been studies, and now I'm forgetting the investigator's name, but that where they did image protein transport, and they imaged protein transport from glomeruli to tubules and back. And I'm forgetting the name.
That was in Indiana, yeah. But the issue there is, those are mice or rats, and there's a lot of controversy as to how much that carries over to humans. We can't do the micropuncture, although they were done in the past, in the distant past. It's not very easy to do micropuncture experiments on humans these days.
So the lab.
Rob, they were done, Rob.
That's Bruce Molitoris, and sometimes working with Wayne Comper, but Japanese people have also looked within the glomerulus, this idea of podocyte albumin transport. So there are lots of them, but those are all kind of experimental animal type of things.
A possibility.
Question, sure, we're going to have to move on. If it's a short question, we'll let you have the last one and then move to the next section.
Yeah, your question was about other markers that are being investigated. At Prime CKD Consortium, we're now looking into clustering and EGF. It's more based towards the treatment of patients, but it at least can provide some information on the inflammation and so on. I don't know what your thoughts are about that.
I think the EGF is tubular origin when it shows up in the urine, and so it's not a selectivity thing, but it's a damn good predictor of outcome.
And clusterin is also, we think, produced in the tubule, at least to some extent. So it makes it more complicated.
Right, well, thanks. Okay, now we're gonna move to group 3, tubular function, Brian Kestenbaum, and I think Susan was helping along as well. Turn it over to you.
Thanks. I have this document here, but okay. So this was the tubular function group. Discussion went into many different directions. The first thing was identify conceptual next steps to capture various tubular functions. The group, of course, brought up lots of concepts in terms of distinguishing markers of the different functions in injury. One thing that we thought might be helpful is to distinguish markers of injury or damage with markers of function, and that markers of function should ideally quantify the ability of a tubular segment to perform some specific physiological function for health. Right, so we could talk about KIM1 as being maybe a marker of damage, although it is actually actively made by the cell, whereas something like the reabsorption of albumin might consider to be a physiologic function. We could ask the group if that's a reasonable way of classifying these. People talked about whether or not, once these markers were in place, can we use them to create a timeline of injury in various disease processes to assess the natural history. And then different clinical settings and timings for their use were discussed. Many different topics or clinical scenarios were raised as to when to apply these: acute kidney injury, sometimes diabetic kidney disease, transplant, advanced CKD, after cancer therapies. Basically, diseases where there may be more tubular involvement than glomerular involvement, or where distinguishing among the tubular functions might provide important information. It was also brought up that, we're in actual life, we're starting people on all these different drugs that affect tubular function. They are sort of a natural experiment, or they're getting an SGLT2 stress test, an MRA stress test every day, and they could potentially be an important source of research. Okay, so next steps to establish practical techniques to capture the various tubular functions, starting at the proximal tubule, and just echoing what Joe said. I mean, if we could ever figure out a way to distinguish sort of glomerular versus tubular albuminuria, it would be very helpful to know, right, how much of, or what of the albuminuria that's present, is it coming from a problem with the glomerulus, leakage, pore size problem, podocyte shrinkage, all these different things, versus a problem of the tubule itself? Is there a way that we could improve our ability to distinguish that? The secretion side, the furosemide stress test may be the best marker of organic anion secretion. It's completely protein bound, minimally filtered, entirely pumped into the urine by the O13 system. And so that is, one of the many tests that can be done for secretion. We didn't talk about synthesis, but I just added it here at the end. The tubules produce a lot of things, and they also metabolize amino acids and do things like that. And so those are other aspects of tubular function tests that could be explored. We kind of briefly played around with the idea of a distal tubular stress test, and then tests of the collecting duct. That there's been studies recently looking at sort of like a first morning urinosum as a marker of progression. And can that be taken further? In terms of how to identify novel biomarkers for the tubular functions, we talked about leveraging KPMP. What could be added? I heard everything that we heard yesterday should be ripe for testing. There was also discussion about whether biomarkers and imaging should be combined, such as functional imaging tests used in other fields. Finally, it ended with, are we missing anything? How might we address it? Topics raised were whether urine could be collected over a period to get viable cells, so we could address things like stem cells and genetic profiles, as well as other particles. So that's a summary of our discussion. Jay, Susan, do you want to add?
I think that was a great summary. I think for the resounding sentiment that I think that I heard, which you touched on, is the idea that there isn't going to be just one thing, right? There's not going to be one test for all tubular function or damage. And that for me, part of it is thinking about a multimodal assessment where different segments may be injured at different points in time or may not be functioning at different points in time, or depending on what stage of CKD or where someone is in their transplant journey, you may expect different levels of function in different segments, and having the ability to, not necessarily in real time, but map that transition, whether that's a transition of progression in the wrong direction or a transition to recovery through tubular disease becomes important. And understanding the debundling of tubular function from glomerular function, that the two of those things go together, but they're different. It's a little bit of, I didn't say it then, but it's your chocolate's in my peanut butter. No, your peanut butter's in my chocolate type of situation, that they are inextricably linked to each other. But many nephrologists, let alone non-nephrologists, don't think of them as sort of different things. I'm gonna shut up.
That was great.
That's great.
Anna?
Yeah, just to add to what Jay was saying, our group on renal reserve talked quite a bit to start off our discussion about should we be parsing out glomerular reserve versus tubular reserve. And again, there could be a lot of links there, but as we frame this discussion, thinking about the term tubular reserve and ways that we might think about quantifying that in our patients as well, different from glomerular reserve or what we think of as maybe renal functional reserve.
Brian, I think Lisa has her hand up.
Hey, so, and that was great. Just curious, was there any discussion about whether there are particular rare diseases or sort of disease settings that might be particularly helpful to sort of do some of the work in, either as relates to, developing the toolkit of biomarkers or just better understanding some of these issues. I hope that makes sense.
We didn't discuss that. That's an excellent idea. The idea of leveraging rare diseases where the defect is either monogenetic or known to affect tubules is a great idea as a place to develop some of these markers.
Maybe I'll just add that from a drug development standpoint, it's also a sort of an area where it's very difficult to develop drugs if you have a disease that doesn't really have much albuminuria or proteinuria in terms of getting something that will give you an early readout on whether the drug is working. So yeah, it'd be great if we had a better toolkit that could better assess the tubular health, I think.
We talked about not so much about diseases, but we also talked about the idea that we're now giving people all these drugs that will preferentially cause things like glucoseuria or things are showing up in the urine that weren't supposed to be there. I know we've focused a little bit about albumin. I will say that I generally have concerns that I'm making albuminuria disappear in all of my patients. And so we may be well positioned to answer some of the questions Joe was asking, but some of those questions may go away as we put people on 3 and 4 drugs that cause albuminuria to disappear. I think that rare disease states is a great idea, but we've got plenty of substrate, millions of Americans taking SGLT2s and MRAs who now have urine that doesn't look like it looked before. And we should have some sense of being able to leverage that to figure out if there are injury. The idea that people don't have protein or continue to have proteinuria after being on max doses of all those things is probably a useful thing to know in figuring out why they're resistant to those medications or the actions of those medications.
Andy?
Did you all address the sort of the assumption in the literature that in the absence of tubular markers of damage, that decreases in GFR after starting drugs are purely hemodynamic and don't reflect glomerular damage? In particular, do you think that tests of tubular function can reliably tell us whether there's glomerular damage or not?
I mean,
So I think.
I mean,
Go ahead, Brian.
I mean, no, I mean, I mean, it's probably hard to get a disease and not have these, some of these, have all these things occur to some degree. It'd be hard to have I mean, maybe at the very beginning of minimal change disease or something where you have something that's purely glomerular, but over, I assume over a very relatively short period of time, these diseases start to involve other parts of the kidney as well, and they're all involved and correlated to some degree, depending on when.
I mean, certainly I've thought about that idea a lot in the setting of AKI, and Joe and others have published data that if you think about functional markers versus traditional damage markers, people who have elevations in neither do great, people who have elevations in both do poorly, but that the outcomes are very, very similar if your KIM1 is high, but your urine output and creatinine stay the same, and vice versa. I mean, I think that there's something specific to the setting of AKI, there's something to the idea that you're talking about, and there are multiple biomarkers that have been able to demonstrate in biomarker positive people who are creatinine and urine output negative, they wind up with the same degree of adverse outcomes as the people who are the exact opposite, what some people think of as pre-renal or volume responsive AKI, right? So I think that that paradigm exists and is true in the setting of AKI, whether that, whether there are markers that we can do that for in the setting of CKD or other disease states is very different.
A question I might have, and sort of this is an open question, but it involves data integration. So with the tubule, like when I look at the tubule, I think about if I were to try to find a problem, my question would be what cell type or what segment of the tubule is potentially causing, is causing an issue, or are there multiple? Or is it all messed up? And as the gentleman just said, Dr. Levy just said, is that, can you use tubular markers to actually say that there's an issue with the glomerulus? And so a question I would have is there would there be room for a model that is mathematical or AI in nature that could take, urine, all the measurements, in urine, so that would include sodium, potassium, in addition to creatinine and even protein, and then blood, and be able to elucidate those potential problems that it's not just that the amount of potassium in the urine is not just is not in isolation, that in reality there are transporters that are, sodium and potassium antiporters. So I guess that has been a kind of a common question I've had is there a potential to use the data that we have more so than trying to find individual biomarkers that act on their own? And has anyone done that successfully? And is there a way to actually do that in a clinically relevant way? Because then there's no more, you don't need more assays. You don't need more, you can actually just get that information right there. It's a pie in the sky idea, but that's a question I've had.
So, Owen, it's Gary Friedman. Your pie in the sky idea is what industry is currently doing. So we are utilizing going now beyond beyond Chat GPT and using GPT 4.0 and higher, we are utilizing sources of real world evidence, as well as some of the literature that some have spoken about on this call. We use those to create kind of a picture that is, ultra detailed, and then also steps back and takes a 50,000-foot view. So the answer is that it's not pie in the sky, and the calculation and the integration of this data, the pace of it can be really very, very rapid. So I think this is something that as a group, this is something that we would be very interested in pursuing together. Exactly this. So not taking any old data and ignoring it, instead using that to create, some type of posterior probability, and then seeing what happens in healthy volunteers, in patients with FSGS, in patients, and just fill in the blank. Great thought. Great thought.
So in the KPMP sort of single cell transcriptomic data, we actually now have mapped the levels of the different transporters across many cell types along the tubule, and we can give the relative proportions and so on. What I don't know how to do is whether how to take those data, and we can make models out of that, right? So saying you might get so much change because of the relative proportions of cells, and we are doing that. But how to map that onto clinical data, whether such clinical data exists for the KPMP patients, I don't know, but I don't think such detailed data exists. But how we can match them up because it's a smaller cohort in KPMP versus the large amount of clinical data that exists in other things to make such a model. Maybe using, like you say, something like a AI type model, it might not be conclusive, but if it gives you appropriate mapping, then one can think of doing further studies where patients who get these detailed measurements can also get molecular measurements from biopsies. The one thing that I can say is that in these things, you don't need a very large number of patients because we have so many degrees of constraints. Even a small group, like between 5 and 10 patients, might give good statistically meaningful relationship data. We should be able to map levels of transporters in disease states to levels of what ions, multiple ions, if you want to call it, multiple markers in urine, sort of. That's doable if you want to.
So can I have one question? Can you hear me?
Yes, go ahead, please.
So I always have questions for myself. I was a kidney transplant surgeon, but now I do the full-time research. The question is, so far, we do we use the cells as somatic cells, like podocytes, the renal tubular cells. We're looking for these cells, like everybody said that. But is any other cell source we can use to test the kidney potential, or the kidney, we can test is the kidney can reversible or not. That means maybe we can looking for the stem cells marker in the kidney. If some drugs or some disease will hurt the somatic cells, but not hurt the kidney stem cells, but some drug or toxicity will hurt stem cells, not hurt somatic cells. But if stem cells get injury, there's no any potential, the repair potential. The kidney will lead to the irreversible condition. So if we can find that, then maybe help us to predicate the irreversible renal function. So if this works to that, maybe we can looking for this the stem cells as stem cells marker for the toxicity or the kidney disease. That will be branded a new marker for this.
Thank you for that idea. I think we're up on time for this section. So now we're going to turn to the next section, last but not least, renal reserve. And I will now turn it over then to Dana and Ragnar, who help moderate that session.
All right, thank you very much. So I was going to try to go through our discussion and see if I can maybe share this screen here. I don't know if it's showing up for you, but I just tried to write down a few of these points that we had been discussing.
It's showing up.
So
Yep.
It's showing up. Okay. So we had a great discussion, quite broad discussion, I might say. We started off just discussing that there's of course a need when we discuss this term, renal functional reserve, to be a bit accurate, whether we're focusing or referring to glomerular reserve or other functional domains. And so this was already obviously covered quite a bit by group 3. So reserve capacity could of course refer to the tubular functions, so such as tubular secretion or urine acidification, the concentration of urine and so forth. And our group discussed a bit various types of tubular stress tests that might be considered, including salt loading tests and phosphate loading tests. Of course, some of these tests, such as of urinary concentrating capacity, have been studied, and so forth. There was also a discussion at the very beginning of the regenerative capacity of the kidney, which is something we were not discussing. So we're focusing on physiologic reserve. And we felt it was quite likely that, given that different kidney diseases will impact different compartments of the kidney to a varying degree, that it might be useful to actually combine different types of stress tests. So if you have a patient with tubular interstitial disease, they may lose their tubular functional capacity before they lose glomerular capacity, and the opposite might apply if you have a patient with microvascular disease. So our discussion was all focused on the glomerular reserve. And so at the beginning, we also brought up the point that it's been known for a long time. It's actually been known for a century that dietary intake influences GFR. And the term renal functional reserve shows up in the literature 4 decades ago, but there hasn't really been much progress in this field over these 4 decades. And it's quite interesting that very few studies have actually looked prospectively at associations of renal functional reserve and important patient outcomes. And so to us, that seems like quite a critical gap in knowledge. And it's quite unclear how useful measuring renal functional reserve truly is at this point. And so when thinking about what might be causing that, we felt that there are multiple methodological issues that haven't really been resolved. And so because of that, there's really no consensus on how to measure renal functional reserve. One thing that we did bring up in our discussion was that there's very little data on how reproducibly we can actually measure renal functional reserve. So in most studies of renal functional reserve, each individual just comes in once for a test. And there's very little data on whether you get the same results if you take that person and bring them in again, maybe a month later, and run the test again. So this is something where there's a big gap in knowledge. Can we actually reliably measure this, and are the results reproducible? There's also a discussion that not only do we need to capture the peak GFR, but the baseline GFR is actually something that can't be ignored. There are influences on the baseline GFR that affect the measurement of renal functional reserve, such as the habitual protein intake of the person coming in for the measurement. So vegetarians will have a lower baseline GFR. And this is something that needs to be studied in this context. It's interesting that the most common protocols that are being used in studies today, which rely on an oral protein stimulus, which is usually just a meat meal. It's the same type of protocol that was used back in the 1980s. And using creatinine clearance to measure changes in GFR, of course, we all know has significant flaws. So creatinine clearance is not a perfect measure by any means of GFR, even at baseline. And if we add to that we're giving individuals meal, which may influence creatinine directly, there are changes in creatinine secretion. There might even be diurnal changes in creatinine because these protocols take 8 or 10 hours, sometimes a long time. There's a lot of things that may influence the validity of these measurements. Incomplete bladder emptying could also just be a huge error. So the accuracy of these measurements needs to be considered. So there was a discussion of this, and the point was brought up that in the end, if the test actually is predictive of clinical outcomes and is useful for clinical practice, then maybe it doesn't have to be perfect. And maybe if we find a test that is giving us useful clinical information, more people would be behind it and study it, and we would get a standardized test that might at least be clinically useful. But the more robust methods are quite cumbersome, as we know, with exogenous filtration markers and so forth, infusions of amino acids or dopamine infusions. So we discussed also what patient groups might be the focus of studies of renal functional reserve, and there's a lot that could be brought up. Kidney donors came up repeatedly during our discussion as a priority group where this might be highly relevant. And patients undergoing nephrectomy more broadly might benefit from studies of renal reserve. It might help tell patients or expect sort of what to expect after their nephrectomy. We've also thought about measurements of renal functional reserve as being something that might be helpful to identify patients with hyperfiltration. So those could be, for example, sickle cell disease patients or patients with diabetes. So they may have little renal reserve because they're already hyperfiltrating, essentially. So, and there are multiple other applications. So renal functional reserve might be used to detect inadequate recovery after AKI or subtle CKD. There's actually quite limited knowledge of what is a normal renal functional reserve in different populations. So that's another gap in our knowledge. And there was a discussion, for example, about renal functional reserve, whether we need to have different reference ranges depending on age. So this is a discussion that's obviously well known just in measurements of GFR in general. We discussed new technologies that might impact this field. So in particular, there's quite a lot of interest in real-time GFR measurements, such as we heard about yesterday with transdermal devices. The sentiment was that such technologies might actually revolutionize this field, because that's really what would be critically useful here, is to be able to more reliably detect changes in GFR by such means. There was also interest in potentially using other imaging methodologies, so such as MRIs, measuring renal blood flow in association with studies of renal functional reserve. There were discussions that studies also should incorporate renal functional reserve measurements when they are obtaining kidney biopsies. So kidney histology could be studied in its associations with renal functional reserve. And there were discussions about the associations of renal functional reserve with nephron number and just with kidney mass in general. All of these things are areas that are requiring study. And then maybe here briefly just to end, so there was also a discussion that evaluating a physiologic measure like renal functional reserve while simultaneously obtaining kidney injury biomarkers might be valuable. This is something that has also not been studied in really any detail. So it might be helpful to compare renal functional reserve changes and kidney injury biomarkers. I think those were sort of the major points, and I'm sorry there was a lot that we discussed, so I'm probably leaving out many good points, but we can hopefully bring other things up during the Q&A. Thank you.
Something I wanted to ask about the renal reserve parameter is it so, and like you say, there's glomerular reserve, there's tubular reserve, and the ideas of that. Is the current thought on, you know, increased protein intake or a bolus of protein increases GFR acutely? First question is, does that happen chronically? Do people with higher protein intake actually have higher GFRs chronically, or is it primarily an acute occurrence? And if it is, and either way, chronic or acute, is it an increased colloid osmotic pressure that causes TGF to relax the afferent arteriole and push more blood into the glomerulus? Is that the, you know, ultimately the mechanism that is assumed to be occurring in renal reserve, or are there many mechanisms? What's like kind of the current thought process on that?
So I don't know, Dana, if you want me to answer or if you want to go ahead, but maybe I can take this one. You know, the mechanism is actually not well understood. So that's one of the limitations here. And that's why I think we haven't really come to a consensus on what's a perfect test of renal functional reserve. We know it's quite complicated. It's been studied for decades in animals and in humans. And there is an increase in renal blood flow. I do not believe, and I have not seen studies suggesting that it's increased colloid pressure. It's a hormonal influence that occurs. And it involves probably hormones from the pancreas. It involves perhaps metabolism through the liver. And it influences renal blood flow in this way. So I do not believe it's colloid pressure from the protein. And regarding the habitual, whether it's an acute or a chronic effect, so it is actually a bit of both. So you can get an acute effect each time you eat protein, but it's also something that has, if you habitually go on a very low protein diet, it will actually cause you to have a lower baseline GFR. So it actually influences both GFR acutely and chronically.
Yes, to add, we make sure when at least I bring patients in to note what their baseline diet is, because I think that really is important. There is literature supporting differences in GFR based on whether you adhere to a strict vegetarian diet or you're a carnivore. And yeah, it's just as Ragnar said, a lot of literature on the physiology and what the principles behind this change in GFR, what the protein load are, but likely very multifactorial in that space, and something with tubular glomerular feedback resetting and likely hormonal involvement as well.
Can I make a comment here? So exciting topic. I think there's a lot of opportunity to study this in living kidney donors. You can, in living kidney donors, take their kidney, get a biopsy at the time of donation, and use their CT scan cortical volume to calculate their nephron number, and then divide their GFR by that to estimate their single nephron GFR. And presumably, all these tests are doing for renal functional capacity are raising the single nephron GFR. So if you know the patient's baseline single nephron GFR, that might be a huge determinant about how much additional capacity they can increase it. The other thing you can do is take their biopsy and use serological models to calculate their glomerular volume. That's a high correlate with single nephron GFR, and patients who have enlarged glomeruli may have less reserve to further increase their GFR. So there's one of the challenges, of course, with doing these kind of research in humans is getting access to all the measurements you need. And there are unique clinical settings such as kidney donation where you can do some of these studies. And, I think definitely the histology. The problem, of course, is many transplant centers don't get a biopsy at the time of donation. So some do, some don't. And there's also, I would point out, precision issues. You need a large enough sample size. You can do, population type epidemiological studies. I think at an individual level, your precision would be fairly limited. And I think that kind of, relates to some of the discussions you guys had earlier about renal functional reserve in general. Knowing the precision is certainly key for clinical use, though you can learn a lot even with imprecise tests with an epidemiological statistically powered study. I guess that was more of a comment than a question. Sorry.
To follow up on that, and in living donors, but then also thinking about the mechanisms by which this is occurring. The ex vivo normothermic perfused kidneys are an interesting model because you have a human kidney that is not viable for transplant, which may mean that it has some issues. But there are people here at Yale that are very interested in challenging these organs while they're being perfused, and so challenging them in different ways. And increasing protein is a relatively simple challenge that you could do, and then you actually are just isolating because it's just the organ. There is no systemic involvement.
Hey, Leslie, go ahead and we'll make that the last question.
I was just following up on your comment about the MRI for renal function reserve, and actually in connection with Andrew's comment about precision. Are the imaging technologies sufficiently precise to look at that? I think the imaging would be very exciting if there was a way to do it the same time.
I will say, in terms of published studies, there are very few that have looked at this elliptical equation technique, which I'm struggling to understand, but very interested in for that purpose. But as far as I know, this is a new idea, and the most recent publication was very recent from KI, but would be intriguing. And as our group talked about, these transplant donors are getting a lot of imaging anyway. So what a great opportunity to study them efficiently and effectively.
Actually, in transplant, we did it in the early 2000s in pediatric, and that established that when you put an adult kidney in, you get a massive increase in infra-aortic blood flow. So you have to measure at the right place, right? Because what's your renal blood flow? If you have one single big renal artery and you can measure there, then that's unambiguous. But we found that with the babies that we had to literally consider aortic flow in order to get a big enough image. But it's been done for a while, and you have to calibrate it against something. We did against electromagnetic flow meters. So
I noticed that Adam Bush had his hand up. Do you want to go ahead in a comment?
It's just like the imager, I feel like, online. I'll chime in here. I think the elliptical technique that Dana is referring to is called diffusion tensor imaging. It's just huge in the brain. It's relatively new in the kidney, but there is some work being done there, and there's many different ways to assess it. So not only do you get microstructure information, but more sophisticated models can actually give you different compartmentalized flow parameters. So looking at perfusion and teasing that apart from tubular flow is possible. That's been demonstrated. I think there's more work that needs to be done between communication of the imaging community and the nephrology community, because these techniques have been validated for decades now in the brain and the heart, and no one's doing it in the kidney. Phase contrast is another one that it works beautifully for quantifying flow. This can be done in sub-millimeter vessels using quite sophisticated techniques. So the renal arteries, I think free breathing techniques, it's very possible. And there's work out of Wisconsin as well as Stanford that has been doing this for literally decades.
Great, thanks for those great responses, Adam. And we're gonna close on that. Good thing there was a little bit of buffer room. The discussions were too good to cut everything short, but we will still end before 2, which was my hard stop time. So without further ado, I'm going to leave the hardest part to Rob Starr to close everything out. Rob, it's all yours.
Thank you. How do I share my screen? I think you have to, someone has to let me share my screen.
See, you don't have the option at the bottom, John.
Oh, there it is. I see. Wait, I see it. I see it. I got it. Okay. Okay. Let's see. Does it look like full screen now? Yes.
Yes.
Okay. So I'm going to start and end in the same place, which is to just thank everyone for really fabulous discussions. One of the major points of this meeting was to try and get the juices to flow. And I think we certainly did this. There's a lot of expertise around the Zoom room, people knowing studies from 50 years ago and last week, and being able to integrate the two together, I think are really important. What I wanted to try and do now was a more of a high-level summary of the meeting. I apologize ahead of time, but I haven't mentioned your favorite topic. But I do want to try and fit some of the pieces together. And my first observation is that it's actually been we've come a long way since the last time we did a meeting like this, which I checked back was 2008. So more than 15 years ago, things have advanced quite a bit. So I'd like to start the summary with where I usually start, which is to talk about questions. There are lots of questions raised during the meeting. Here are a few of them. It's pretty obvious that GFR varies during the day. There are circadian rhythms we heard about, and that the current measurements have limitations. Can we simplify or standardize measured GFR in research settings? And can we measure instantaneous GFR in hospitalized settings? Because clearly the EGFR equations don't work in acute kidney injury. There was a lot of discussion about how to dose renally excreted drugs, particularly those with narrow therapeutic indices, and how we currently use EGFR, but that's not so great. Can we find a more accurate estimate of renal drug clearance? And is there a tubular function reserve, the Tmax of old days? Next, we currently use complete and partial remission of proteinuria or albuminuria to assess the response to therapy in glomerular disease. But as we heard beautiful talks on the filtration barrier, that it's very complex, that it's probably not what I learned in medical. What I learned in medical school is actually not correct, that the permeability is affected by swelling of the glomerular basement membrane as well as the podocytes. And can we measure these two pathways directly to improve our assessment both of drug ability or drug response in glomerular disease? Well, what about acute kidney injury? We currently assess risk from clinical history, some static tests. The biomarkers have not been so helpful. Can GFR reserve, I'm going to use that instead of renal reserve to be more specific. Could GFR reserve or tubular reserve or FST better assess risk or prognosis? And last question I'll come up with, but there are many, many more again that were raised during the meeting. We currently use all these global measures of renal function, but renal disease we know can be localized, can be patchy. Clearly this is seen in animal models, and it's one of the pitfalls of just looking at one renal biopsy from a patient. Can we measure local renal function, injury, fibrosis, repair in order to A, was figure out what's going on, and B, use it to target biopsies? Oh, sorry, I have one more. And this is probably Action's favorite, that the renal diseases are not homogeneous. Can we use these measures to develop measures of precision medicine? And others have talked about that. So sort of where are we and what do we need? There was a lot of talk about the lack of resolution, that GFR proteinuria are quite suitable for routine clinical use for the most part, but they are not sufficient clearly to unravel complex renal disturbances or to directly evaluate renal health. We seem to be flying with one eye closed. We definitely need clear vision. Part of that clearer vision is to realize that we need to comprehensively assess how the kidney works, not just, quote, renal function or GFR, but to identify dysfunction subgroups and gain new insights into different compartments in the kidney. Our current resolution is inadequate to do this. And as Sus and others pointed out, we really are understating the elegance of the kidney by the two tests that we use. It's clear, and you've seen this throughout the meeting, that we need to delineate multiple independent measures of renal function and dysfunction. One or two tests can't solve the complex problem of renal health. We need to delve into the anatomy of the kidney and look at the function of the glomeruli, the glomerular barrier, the tubules, the many different segments, endocrine functions of the kidney in both health and dysfunction in each of these individual compartments, and recognize that any of our measures for these individual functions will not correlate with whole kidney GFR or proteinuria levels. And we clearly need multimodal tools to assess each of these individual renal compartments and functions that match the clinical questions that I raised and raised throughout the meeting. This is really complex. It is going to take a lot of time. One thing that I remembered from my fellowship with Mo Berg was that if you want to measure something, measure it directly, and try best you can not to use a surrogate where possible. So that and the reason I bring this up is that there's a lot of talk about measuring, drug levels drug excretion and using eGFR as a surrogate for that. As we've heard today, there are probably better ways to do that. The meeting highlighted the problems that we have and the need for more in-depth assessments of kidney functions, plural, to get us out of the current rut, and we clearly need new tools. So there were some other overarching themes, and that's what would we use these tools for? The first is to keep an eye on why we're all here, and that is to improve public health. We're not just using it to figure out how to make animals better, but to use this in people. So these have to be tests that can be done in humans, not just in animals, and use them also, as Afshin has talked about, to identify the subtypes or endophenotypes or sub-endophenotypes to help KPNP and other precision medicine projects, either here or abroad. And the other piece, which is critically important, and Paul Kimmel pointed this out, is the need to use all of this data to nucleate new research fields, such as finding new drug targets or new early drug response biomarkers, but there are many that could be added to this list. Okay, so, we're here, we want to design the future. One future is, of course, for the Star Trek fans, the tricorder, which I don't know, I guess looks something like this, that you scan the patient with, and it rapidly tells you what's going on. I guess you push another button and it fixes the problem. We're not quite there yet. But what are we talking about? So I think what we're talking about, and I started the meeting with this, was to develop this idea in your head of some kind of renal function menu, stress testing, or crash cart that measures a bunch of different things. It measures glomerular filtration, both instantaneous and time average, to give us the equivalent of glucose and hemoglobin A1C, as well as this GFR functional reserve. It measures a couple of different measures of glomerular current selectivity, including glomerular basement membrane swelling, the shunt pathway through the podocytes, as well as repair regeneration. And maybe there's some stress test hiding here that we didn't hear about. We also clearly need to measure tubular function independent from glomerular function or tubular fitness. We have some ways to do that now with concentrating and dilution ability, but we heard a lot about specific OAT pathways and being able to measure them either endogenously or endogenously, looking at tubular secretion and maybe the tubular function reserve. There were some beautiful talks on the furosemide stress test and the for biomarkers, as we've heard for a long time, about injury repair, regeneration, fibrosis. And although it didn't come up at this meeting, Deb Gibson has pointed out, let's not forget the kidney has some endocrine functions that may be helpful to measure also. all of the tests that I talked about above were looking at sort of global kidney function. I think it would be really beautiful to be able to use imaging to localize these things to various parts of the kidney so that you can then perhaps even biopsy a good looking area and a bad looking area and see what's different between them. So this was the sort of 2D table that I came up with. You can see my pointer. The tests are arrayed in rows from anatomy to glomerular filtration, prime selectivity, tubular function, and some others. And then what can we measure now, either right now or close to now, what's measurable in short term, what might be useful to develop long term, and then how does imaging fit into this? On purpose, this table is rather sparse. I have not filled out all the cells because I think that was the point of the meeting, was to talk about sort of what's, we talked a lot about what's needed. What will probably happen as as you continue to discuss this, and I heard that there are going to be a couple of review papers for the meeting worked on, is to try and flesh out this table to have some estimates of what might be available in short term, what could be done long term, to better assess in these 4 or 5 different areas. So that's how I would piece this together, that there's a renal function menu or crash cart or a bunch of stress tests that are measuring different parts of the kidney. And they may partially correlate, but again, this is clinical research, is the outliers are people we want to be looking at more carefully. And of course, we'd like to integrate all of these kinds of tests as fast as possible into our projects and your projects, like the Kidney Precision Medicine Project and other complicated projects that are looking in more detail at subphenotypes and subcompartments of the kidney. So with that, I'm going to end actually a few minutes early and end with the thank yous. I want to really thank the organizing committee and Action and KUH staff for putting together a really beautiful meeting that got a lot of discussion going. I want to thank the speakers for really fabulous talks, and for all of you for working hard during the breakout groups to really think through some of these complicated issues. I know we're just scratching the surface in the 2 days, but we know that these meetings do nucleate a lot of activity. We look forward to seeing a lot of applications. And for those of you that get funded instantly, that's great. For those of you that just missed the pay line, we do have ways to help you. So please, please always talk to your program officers to find out how best to submit applications to us. We will gladly help you figure that out. And with that, I want to thank you all and wish you safe travels. Bye, everyone.